from back is projected, catheter is perpendicular, whereas the normal axial view is about 45 degree, the catheter is placed on the foot, then projected. So you can see the difference in the X-ray where foot is seen normal axial, whereas foot is masked because of the internal view, 30 degrees assessment view. So here case example how to identify the pathologies. This is the calcium fracture which has arthritis, and more predominantly the assessment view will be how the hind foot is lying. So whenever there is a fracture suspension or area or heel aspect, hind foot is lying to the varus. And we can see that there is the loss of the subtalar joint. It is impacted into the calcaneum. So that can be identified by the bolus and the highest point in the calcaneum. And we have a horizontal form of bolus and of the longitudinal, and here we can see that alignment is lost. And the reason is also there is the contraction of the posterior facet to the calcaneum. The normal kissing angle is about 120 to 140. Here you can see it is more of a obtuse angle. And these are malinter calcaneal fractures with subtalar arthritis. So coming to flat foot, how to identify is very important. Here you can see, obviously see the flat foot, but then the tarsal bones are overlapped. So here the talus and calcaneal relation is not very well made out like this, because the calcaneum, we can see that calcaneum is in equinus position or it is flattened out straight. So the subtalar joint is overlapped, and that is again because of subtalar subluxation, which can be well appreciated in the Salzman view, and then there is a hind foot valgus is there. And in the midfoot also we can see that there is a lot of overlap of bone, whereas the normal bones do overlap in the normal view, but it has got exaggerated. And even the Mary's angle is less, and here we can see that cuboid height is lost of 5 to 10 mm. It is probably below, it is in the minus. The other important X-rays to be taken for the ankle is in cases of dynamic views, that is a stress view, which can be taken with a manual stress on medial or lateral to see the medial joint opening or lateral joint opening, or the gravitation also can be used to take this stress view. For example, this appears to be a normal appearing X-ray, but he is a basketball player with a persistent pain on the axial loading. So here we can see that there is a cross opening of the lateral aspect, showing there is a tear of the anterior talofibular ligament insufficiency. And this is the X-ray example in case of FICS planus. As I told, there is the Mary's angle, that is axis of the talus and first metatarsal is lost. And if it is more than 15 degree, it can be graded based on mild, moderate and severe for the deformity of plus planus. And this is an example for weight bearing views in case of suspected Lisfranc injury. So normal X-ray, non-weight bearing, we might miss out this, the widening of the space, and there is a flex sign, that is the oval-shaped fragment of the Lisfranc ligament. And also weight bearing view will definitely show that there is a dorsal subluxation and opening in the first TFT joint as well. So weight bearing views are very important. And the oblique views and the AP view will give the definite relationship of metatarsal to the tarsal bone. So here we can say that there is a widening space is there, and then the alignment is supposed to be a smooth straight line, but there is a breakage in this. And for the lateral Lisfranc, the fourth MT will be continuous with the cuboid, and the third MT will be continuous with the lateral cuneiform medial border. So if these two relations are lost, then the Lisfranc can be suspected. And the case example of rocker bottom foot in the Charcos, where we can see that there is a breakage in the midfoot TFT joint, and here we can see that again the calcaneal pitch is lost and the cuboid height is lost, and the first MT and the talar axis is also lost, showing that there is a breakage in the TMT joint. So these axes, alignments are very important to identify the amount of pathology by which we can plan our surgical treatment. So reading these X-rays are very important. And here you can see the Charcot's TMT joint where the alignment again is lost because of the forefoot abduction, where gives the congruity of the empty joint. See that there are small spurs, and then the MRI will definitely shows a lot of marrow edema and synovitis at this region. So these are the patients who has ankle impingement, and then ankle arthroscopy will give a lot of relief for these patients. And then whenever there is a foot and ankle pain of unknown origin, we always need to take an MRI to diagnose, and that will give a lot of information. And how to identify is basically from the marrow edema and from the joint effusion. So this another patient with the chronic ankle pain was more severe in the night, and then we saw a lot of marrow edema, and then we asked for a CT scan, and then it showed the sclerotic rim with the nidus, and it came out to be osteoid osteoma. So this anterior aspect and anterior superior aspect, definitely we can do ankle arthroscopy, and then we can remove it, curate it, and send for biopsy, as well as we can do a sclerotherapy as the cauterization as well. So this is another patient. Here we can see there are two tendons on the lateral aspect of the calcaneum. This is a normal MRI. Here you can see that there is a one tendon and then one which was stretched out. So it came to be as a peroneal brevis tear. So there is a single tendon on the lateral aspect of the tendon. So it's very important to identify these pathologies from the MRI, and they present with a lot of edema and the severe pain. The other hindfoot pathologies, what we can identify from MRI and X-rays are the loose body or os trigonum. It shows a lot of marrow edema, and then the correction, the white signal is synovitis and correction. Post-traumatic calcification, or sometimes the avulsion fractures can be identified from CT and MRI, and subtalar arthrodesis. So the shepherd fracture and the cyril fracture of the posterior process. So these are all aspects we can use arthroscopy assisted fixations or removal of these fragments. And X-ray of other pathologies, very rarely we can get a chondromatosis or posterior aspect of the talus can present with OCD, and this can be, we can use subtalar posterior hindfoot arthroscopy to address these pathologies as well. This is reported from the literature where we can see the MRI. There is a bright intra-articular signal in T2 and hypointense signal in T1. It was PVNS, and this again can be addressed with the hindfoot arthroscopy. And this one case which we recently had, the patient had a lot of pain, X-ray was looking normal, and then the MRI showed only the bone marrow edema. So we were not sure what was this lesion, and then we took a CT scan, and then it was identified to be osteoid osteoma with central nidus. So that again was dealt with the hindfoot arthroscopy. This is another example of X-ray with typical features of lysis and sclerosis and irregular margins. It was nothing but the CT also identified the sequestrum. This was an old ankle dislocation where the steamer pin was put and then it was gone for a secondary infection. So and then MRI, you can see the tracking of the pus and lot of sclerosis in the white signal signifies there is a lot of collection within the bone and other soft tissues around. And then the axial views also show. So the take-home message is to understand the normal architecture is very important to identify the foot. And foot and ankle is amazingly three-dimensional architecture where the bones are interlinked in a specific design. So understanding is very important to treat the pathology and identification of pathology. Thank you. If patient is able to walk, especially the Lisfranc fracture and all those things, we can definitely take a weight-bearing views. Otherwise, in acute cases, weight-bearing views are very difficult to take. But most of the conditions, definitely if patient is able to stand and weight bear, so we can take the weight-bearing views. And in trauma cases, again, all the periarticular fractures and all the fractures, for the surgical planning, definitely CT scan is required. So to plan or fixation, and fixation and the most commonly ruptured tendons in our body. gone up. Yes. Sorry. And the retraction was of so the tender spot was about 3 to 4 centimeters, and all the classical signs of Thomas test were. And ultrasound identified the tear and the degeneration, and the ultrasound was retracted, and then there was a 4 centimeter of retraction of the tendon space. So intraoperatively the still out, and there was a scenario of 4 to 5 centimeter of retraction. So here what we have used is deflection. Deflection is a good one which can substitute and give heal itself. So original tendon, we did VY plasty, so it can be combined with the VY plasty and the FHL tendon. So even though it is a high impact, the FHL will substitute for good healing, and then in this case, we can see that the gap was still 45 cm, the traction sutures were given, and the length of 2 centimeters from the VY plasty has gone, and another 2 centimeters from keeping the foot in the equine position shut that shortens it, and then the suture this repair was dealt. So around 3 to 4 centimeters, FHL tendon can augment the original tendon is there, because VY plasty alone might be forming a very tight tire, so FHL augmentation should be good, give a good healing of the tendon. So the patient was placed for 6 weeks, non-weight for 6 weeks, and then partial weight training progresses to weight training, and the checking exercise from the 3 months. So this is the post-op X-ray, the FHL and the was separated for situation. So we also did sometimes follow visual awareness just to see how the loss of FHL tendon impacts the foot. As you see that there is a lesser great growth of FHL, but then gets lost over a period of time. This is another foot phenomenon showing the amount of force exerted by the foot during the walking phase of the gait. This is the same patient 1.5 years followed. So FHL do recover to some extent from the compensated by the Hendricks norm and also from flexor analysis brevis. But for the normal gait, it doesn't cause any big difference. So here the follow-up MRI was done in this case, so you can see that the FHL is nicely healed, and then there is a hyper. So another case example, this was a chronic case. 52-year diabetic, he had an injury 6 months back, and this is a chronic tear of more than 6 months. Thompson test, and he on the posterior aspect. The Thompson test was, and then we can see that amount of gap in the MRI, and then the distal stump was there to some extent. So here intraoperatively we can see that there was a gap of almost 9 centimeters, because he presented 6 months, it has got retracted and only some small fibrous tissue was around, and then the distal stump was there. So this challenging case, again FHL transfer was done onto the calcaneum, and then the 9 centimeter was compensated by the collagen from the turn-down plasty, where the proximal incision is extended, and then the 9 centimeter and then 2 centimeter stump is being marked here, and then the of the turn-down was taken, and then we have the collagen from the original tendo-Achilles and also the FHL. So the proximally the gap was closed, and then the turn down is mixed with the FHL. So this gives the collagen as well as the dynamic part comes from the FHL, and then it is inserted into the calcaneum by creating that socket. It was about 9 mm diameter, and then which was inserted into the calcaneum and then fixed with the interference screw. And then you can see that interference screw being inserted, and then this is a final repair, and then the remnant tissue from surrounding was closed. So this gives the robust thick portion for this chronic kind of tear. So for chronic retracted tear, more than 5 centimeter, or if it is 3 to 5 centimeter also, FHL is a good tendon option locally available, and also the FHL forms similar phasic contracture with the triceps surae. It's a good option. The knot of Henry and the flexor analysis will compensate to some extent for the loss of FHL tendon. So the morbidity post FHL may be clinically less significance. Then around 52% from the literature, it shows that FHL tendon goes for a hypertrophy. So we have did analysis of pedobaragram analysis, and then published in a journal of Isacos the peak pressures. We analyzed the peak pressures from the pedobaragram of all the chronic tendon cases, and it was presented in Isacos. And this was our study, where we can see that initially there was no pressures in the forefoot, and there was a lot of pressures in the hindfoot, and then it gets normalized by about 1 to 1.5 years to about normal pressures. So this was presented in Isacos in US this year, and I'm happy to share that I won the Achilles Sports Medicine Award for that. So FHL is ideal for transfer, can be used for chronic cases and for retracted tendo-Achilles. It's a substitute, and also it can be combined with turn down for a robust repair. So to summarize, 2 centimeters, less than 2 centimeter, direct repair can be tried. If it is tight, the equinus position will give about 1 to 1.5 centimeter. And for 3 to 5 centimeters, VY plasty can be combined with FHL if it is a tight, or VY plasty alone can be done. For more than 5 centimeter, turn down and FHL will give a good robust repair. Thank you. Any questions from the floor? Yes, sir.
So sir, what is your rehab protocol?
So rehab protocol, what we follow is 6 weeks of complete repairing, and then after start with the partial weight bearing, progress to full weight bearing by 2 months, and strengthening and stretching after 3 months period.
Tendinopathy patient, they present bilateral Haglund prominency as well as bilateral tendinopathy.
Yes, sir.
But in such a here, patient has come for the unilateral.
Yes.
For the other side, to go for the Haglund excision to avoid the tear.
Yes, that's a good question, sir. So it is important to know the symptoms for how long it is. So we can always treat it with the conservative measures like heel rise, stretching exercise and all those things. And also we should warn the patient regarding the possible tear in the future. If the patient is having severe pain and the Haglund is too prominent and there is a sign of degeneration, that is calcification and lot of tenderness. So definitely we can do the Haglund excision of the calcific portion and then reattach it, rather than waiting for the to tear and then do it. So it is not a prophylactic, but we are treating like a external tendinopathy. We can do the excision and then do the repair. When there is a sign of degeneration, so it will always be painful, and then we can definitely suggest the patient, and then it depends on the patient whether he wants to undergo surgery or not.
Yes.
Yes, sir.
Yeah, a question for you, sir.
Yes, sir.
So actually, in most of the
and very important one. So whenever the technical aspect, so a lot of people suggest we can put a medial incision to avoid the posterior heel. So the one the incision. So if you go directly straight, and most of the patients we have seen there is no skin problem. So it is technical also is very important.
so taking a bold thick flap, you mean it?
Yeah, thick flap, and we should not undermine the edges, and we should tell the assistant not to pull too much. The watershed area is mainly the last 3 to 4 centimeter. Above, there has never been a skin issues. So that is the 3 to 4 centimeter is the problem area.
And closer you say subcuticular to be taken or directly skin?
What we do is we directly take like a little bit of the remnant tissue and some also another important thing, because vicryl is a braided suture. It can form a source of nidus for infection, and what we use in our hospital is a thin 2O monofilament we use. So that is like monofilament is good for closure.
And also avoid ethibond for the same purpose.
Yeah, ethibond again is a braided suture.
Okay. Thank you.
What I think is, if you make a revision of this case, it's very important to remove the scars of the Achilles tendon. Because then when you remove the scars, you have enough space to get the closure. You have scarring, even if you have an older rupture, you have a big scar in beside, this scar is for nothing.
Yes.
You can remove it, and then I get much more space for the closure.
Yes, sure. Debulking.
So your experience with infiltrating with PRP after
No, we don't use PRP in our institute. Again, it is depends. It is we are giving PRP mainly for the healing purpose. So it again it depends on the surgeon. But in our institute, we are completely against PRP. So we don't use PRP for knee joint or for ankles.
One last question from Dr. Matthew.
No.
Okay.
Well, congratulations for your award.
Yes, sir, thank you.
And
Thank you.
very well documented topic. I saw your treatment algorithm. You tend to favor the FHA transfer for a defect that are above 5 centimeters.
Yes,
And
sir.
you said plus or minus between 2 and 5.
Yes, sir.
With your positive experience, are you tending to go now more and more towards the limited defect, using your technique for 3 centimeters defect, 2 centimeters defect? Are you changing your habits? Are you changing your thinking? Are you adapting your algorithm to your good results?
Yes, sir. So my decision for FHL transfer not only depends on amount of retraction, so it also depends on the chronicity of the tear and then how much I can bring the original tendon to the calcaneum. So I do the measurement after doing the Haglund excision. So I make the slopy surface and then do this thing. So I know the back of my mind that when I give a equinus and then try to get the tendon down, I get 1.5 centimeter of length. And then I combine it VOA-plasty, I get 2 centimeter length. So that marks like a 3.5 centimeter. And I feel it is a tight repair, then I add the FHL. So less than 2 centimeter, I have never done a FHL. And FHL is the more than 5 centimeter, always FHL and turn down. The gray zone is between 3.5 to 5 centimeter. It depends on the chronicity of the tear and the amount of tendon I can bring it down to the calcaneum. Thank you, sir.
Thank you, Dr. So next talk will be on tips and pulse of ankle fracture along with neglected ankle fracture. I request Dr.
Yes, thank you. First for the invitation. I come far away from Europe, and thank you for the hospitality and the honor to be here. And class in Varanasi, but it's yes, the first ankle fracture what I did was the most important, difficult operation I ever done, because it was my first operation and it was crazy to do it. But it's sometimes simple fractures look very difficult, and the problem is they must learn to read the fracture. That it is. When you can read the fractures and you see where are the problems of this. And the cartilage damage mostly is not done visible. We make it mostly indirectly. No one looks into the joint, and we know from literature that cartilage damage in ankle fractures goes up to 30% or more. And that's the risk what we can have. If you make it operatively, the results are bad. We know it. Each well alignment must be corrected. That's all the papers which show, and what is interesting, good results about 60%. Weber R fracture, but the same is in Weber C fracture. And that's, we always think an A fracture is a good healing fracture and the C fracture is a bad healing fracture. But if you show the literature non-operatively, it's almost the same. And that must be really important. It's the same in the operative therapy. Even in A fractures, you see good results only in 60%. That means sometimes fractures than C fractures. And that what is the reason? A fractures are coronation injuries. The coronation injuries to the ankle joint are much worse to treat than supination injuries. That's really important to know. And we look at this, the typical A fracture, but what you see, what is mostly overlooked is this here. The action of the distal tibia, in this case on the medial side. When it dislocates, you get an impaction. That must be recognized and that must be corrected during the operation. What influences the final results? The mechanism of injury, of course. The compression injury is more difficult to treat than a torsion injury. The size and the dislocation of the Faulkner's triangle, the functional osteoporotic treatment and the osteoporosis. That's really important for the treatment. And the correct analysis of the X-ray is important. If there has been a dislocation during the operation and not. If it was dislocated and it was longer time dislocated, the results are worse because the damage is much higher. Yeah? The type of dislocation, do we know if it's a positioning screw or not? And what do we do first? Do our reconstruction, and then it comes some tricks for osteosynthesis. Yeah? And the key for correct planning is an exact X-ray. Nowadays, we are able to get a CT scan of all of our fractures. But mostly, very often, it's only done an X-ray and no one looks on a CT scan, and especially after the operation, sometimes it's necessary to make a CT scan to check the quality of the reconstruction. If you look at this case here, it looks really simple, but in the CT scan, you see, that's this fragment here. And you have such a fragment and this place, you can imagine that must be a big trauma to the joint, because you have here, you see the impaction on this side, you see this fragment. That's not a simple fracture of the median malleolus, that's a very complex fracture of the distal tibia. It's an ankle fracture, but a very bad ankle fracture. If it looks so simple like here, that must be recognized on the X-ray, and if there's any questions, there must be done a CT scan. The standard X-ray is apilateral in the 20 degree of internal rotation, but if you're not sure, sometimes you need additional X-rays, either CT scan or X-ray with external or internal rotation. If you look at this case, yeah, it looks normal, yeah. But if you move it 45 degrees internal rotated, you see this fragment, yeah. And what is very often said, it's a simple fragment of the malleolus. It's no fracture of the malleolus. It's a peroneal tendon dislocation. Very often not recognized. It's a simple peroneal, simple ankle fracture. You can cast it or fix it, but mostly they are not recognized that the peroneal tendons are dislocated in this case, and it must be brought, and that must be mentioned during the operation. The other is during the operation, the X-ray quality must be high. That is really essential. If you look at this, it looks good. It's the same case. But when you look here, if it's exactly X-ray, you see there's an impaction of the posterior third of the joint. That means the joint line is not correct. You have an impaction of the posterior third of the distal tibia, and that's really bad for the future. And if you see this during the operation, you can go from anterior and push it down a little bit. And good reconstruction of the joint. It must be exact lateral means is correct. The joint face must be seen free, and the X-ray must be done in a perpendicular position of the ankle joint. Very often they do it in maximum plantar flexion. In maximum plantar flexion dorsally, all it must be done in a perpendicular in a 90-degree position. AP is the same. If you have such an X-ray, intraoperative, you don't see anything on the lateral side. It's an overlapping. This is the view that must be. AP X-ray means ankle must be in a perpendicular position in 90 degrees, not like in this with a plantar flexion. It must be done in 20 degrees of internal rotation, and the joint space must be visible on the medial, on the dorsal, and on the lateral side. And then you can check it, how it's really. And in this, you can check the length of the fibula too. Not in this. Here you can never check the length of the fibula. Of these X-rays. Weber criteria, what does this mean? That's from Hardy Weber. You see, this spike here, yes, is in corresponding situation like here. And you see the spike, if the spike is up, yeah, then you see your fibula is much shortened. And we have done an experimental study many years ago when it is mentioned that the fibula is shortened. And it must be more than 3 millimeters. When it's more than 3 millimeters, then you see it on the X than 3 millimeters. That means you cannot see it. That means it must be really done exactly. And when you have such a widening of the medial clear space, of course you know it's shortened. And that's the same as this so-called Weber ball. Yeah? You can sign here a ball when the length is okay, and like it is here, the ball does not fit. And that's a practical situation. That the patient who came with this situation from another country, this X-ray. Yeah? And if you see this soft, you have a tendency to say, oh, it looks, the skin is so bad, we don't do any operation. But what did happen? You see here, that's a high fibular fracture, and you see it, that is really too short. It's short about 3 millimeters. It can be done in this case. Okay, you can go up there and open it directly, make your fibula directly, and then lengthen the fibula, yeah, directly, not indirect head normally, so make it directly, like in this case, it pulls back and then it fits. So see, we fix the fibula, and then the length is okay. You see it here now the length is okay. The positioning during the operation for me is very important. It must be hang free, so they can come from both sides. And then, if you start with reconstruction, the question where to start first. My method was always this is the method of Lauge Hansen, who said what breaks one after the other. And I start with the last breaking bone. The first and the last breaking bone is always the posterior tibial, the Faulkner's triangle. And the Faulkner's triangle must be corrected totally and anatomically. And if it does not is done anatomically, it will not work in the other side. The 3 columns are the fibular syndesmotic complex, the medial malleolus with the deltoid, and the posterior edge, the Faulkner's triangle on the dorsal side. And in general, the posterior edge is the last which breaks, and that's the first what I did in my hands. When we go to the medial malleolus, then we have some tips and tricks to make a reconstruction. Yeah? The target should be the anatomic reconstruction. And what for options do we have? K-wires, of course. K-wires can be done. Leg screws. But leg screws always have the risk to tilt your medial malleolus because of the head of the leg screw has not the angle of the medial malleolus. It does not fit perfectly on it, and it must be really mentioned and you can do a tension band wire with correct the valgus position. That's for me the best method. When you look at this case, that's show it later on, but if you look at this case, the typical situation, you see the leg screws on the medial malleolus, and the washer at the tip, yeah, presses the medial malleolus to lateral when you make a compression. That means you get a hyperpressure on the tip of the medial malleolus. And that, of course, if you do it during the operation, the patient feels it because pressure is the tip of the medial malleolus and the talus, and it hurts. A tension band wire like here is one option, it holds it good, but it's something a little bit tricky to make it. And that's one trick, a variation of a tension band wiring, what I prefer. When you look back here, that's a you make the K-wires and took your tension band and bring it through the bone. But to make tension on it is really sometimes tricky. And very often the wire breaks and so on. When you take, instead of take a screw here, a leg screw here, with a washer, bring the wire over the leg screw and then bring in the leg screw. And this screw you get a lot of tension on this tension band wire. I'll show you again. You see it again. You bring it in here, the K wire. Here you have your wire, and then that's the head of the screw. And now you on this side, the screw, you get a really high tension on the medial side, and that means that you bring your medial malleolus a little bit more to medial, and you decompress it here, and that's what the patient needs. And that's a very simple trick to make it wire with a screw instead through the whole of the distal tibia. When you make it in this way, it's wrong, because there you don't get compression. You must take the screw up. If you bring up the screw here about in 30 degrees, wire on it, and then you bring the screw in, and then you get the best compression with the tension band wire. And the other side is the lateral malleolus. What is more now is lateral approach. It's a posterior approach. In general, we have very often done the mistake to come from anterior lateral, and it's much better to come from posterior medial or fully from posterior. Yeah? And the dorsal plating is the best position of the for the plate. The dorsal plating and the dorsolateral plating, because if you look on a dislocation of an ankle fracture, where does it dislocate? It dislocates to posterior and to lateral. That means if it dislocates from posterior and to lateral, it's important to bring the plate to the posterior lateral edge to protect for redislocation, not come from anterior. And like in this case, you must go more posterior, and then you can this Weber plate and fix it, and you see you can fix it without the posterior side on the distal end of the fibula. That's the open reduction, take care of the nerve. And another trick what I very like very much in a very osteopenic bone and osteoporotic bone, really fixation of the fibula to the tibia. That brings much more stability. Of course, in younger patients, it's not good. In younger patients, they don't tolerate it. But elder patients really have a soft bone. It's a good way to fix the plate which is soft bone to the tibia. And not only, but very often you can, if you feel it, you can take it out after some months. But this holds it much better. And you see such a cases, you see the osteopenic bone, and that's a function. If you make it in an older patient, it's no problem. He will have some loss of dorsal extension. He's happy when he can walk without any. If you have such a comminution fracture, yeah, it's really difficult to make the reconstruction, how to get the length. And one trick to get this is to take a long tubular plate, tubular plate, and then fix it distally with one screw, perhaps with two screws, and then make an additional screw above the plate. And then take a laminar spreader, and with a laminar spreader you can distract it. Yeah? You make a distraction over the plate, and in the moment where you see that also gap closes, that the length is okay, then you make your first screw here and you fix it. And that's really in an osteopenic bone a good trick. Yeah? You really you take with your lung, and what you see here, how much length is possible and sometimes necessary. And if you have such a comminution, the other advantage is you must not open this comminution. You must only open it to bring in your plate, but not more. That means for healing this osteopenic bone, when you don't make the periosteal, you let it like it is. fracture dislocation of the, like a Weber C fracture, very often they have a slight bone avulsion of the syndesmosis, and this bone can be impacted with and when you have some bones there, you never can make a correct reconstruction because you have a piece of bone in between. That really must be checked, and when you open it, take a small laminar spreader, open the syndesmosis when it's loose, and look in and take some hook to clean it out. So it's normal in all fractures. You take also interpositional bone, and the same should be done in the syndesmosis. Take the laminar spreader, reconstruction of the length of the fibula, and then the reconstruction and the fibula, the transfixation screw, I always do in neutral position or slight dorsal extension. Mine slight dorsal extension. The talus is much broader on the anterior side than on the posterior side. If you make it in the plantar flexion, you make it too small, and that means you have a loose and a loss of dorsal extension. It must be done in the neutral position or in a slight dorsal extension, and then, like in this case, again you see a small gap here, the side shortening of the fibula, and first we open it, we come in with a laminar spreader with a small one, and look, is there in some bone interposed. Then you can get the length with a sharp hook here. With a sharp hook you can pull it down, yeah? Same incision, and set the foot in the neutral position. And what is really important is the foot must be free. If the foot hangs to dorsal, you get always a dorsal subluxation of the whole foot. It must be positioned in this way that there's no tension to dorsal and to anterior. It must be in a dorsal, in a neutral position in this way. And then I take a percutaneous clamp. With a percutaneous clamp, I hold it together. You can take an additional K-wire to hold it, and then bring the screw. The screw is brought from posterior to anterior. We all know about 3 to 4 centimeters above. But that's most screw is to bring the foot in the neutral position, to bring the fibula in the correct position, and to close the gap in this way. Like in this way, you see we came from posterior to anterior. Here it's fixed with a percutaneous clamp, and that's the way the screw should be, about 30 to 40 degrees above. And then it's a screw which has all corticals are drilled, and that means you must find with your screw the cortex of the tibia in your first step. If you have it, if it's a screw here and you don't find the hole in the tibia, what will be? It distracts, because it's not a leg screw, it's a positioning screw. That should be done under fluoroscopic control if it's possible. Yeah? And then you get the length, and you can see that it fits. And then you see the range of motion at the end of the operation is free. And that's important. If you have made your positioning screw, the range of motion of the joint must be free for the dorsal extension. If it's not free, there's some mistake in the synthesis. Yeah? Posterior approach to the tibia at the end, I like very much. The posterior approach to the tibia, it's simple. It's, of course, you can do it in the prone position, but that's sometimes really tricky to get the patient in the prone position. But if he's lying in likes this half supine position, you can bend your knee, and then they can come from posterior. That makes it easier, and then there's really a space where you can come to the distal fibula and the distal tibia from dorsal in a very simple way in between fibula and tibia. There's nothing, there's only the flexor, longus tendon and some veins, not more. They're really in a fast way to the structures, and it's simple and it's safe. Again, case, it's a very old case. You see, he came with this osteosynthesis from Turkey, I think so he was, and you see it was a well-positioned fracture, and what we did, even in this situation, we came from more posterior, made a new incision, and then we reconstructed this. Like in this case, it was too short, and then we could reconstruct the whole situation from posterior to anterior. Yeah. At the end, diabetes patient is a total other entity, and the thing here in India, a big problem in our country is the same. Yeah. Like in these cases, of course we know it, yeah. But how's the impact of diabetes on patients with With ankle fractures, the mortality is higher. That really the blood pressure and blood should be corrected. Same is with PNP, but sometimes the healing of ankle fractures in diabetes is much worse. When you look at this case, yeah, it looks simple, yeah, but that's the other side of the patient. He had an ankle fracture on the other side too, some years ago, and that was the final result. It was sharp before the below knee amputation, even in a simple ankle fracture. Yeah? And that's, in this case, we do in our simple cases even an internal fixation. And that's what you should do. How important is osteoporosis? Osteoporosis is important. With osteoporosis you have a much higher complication rate. Smokers is higher, BMI of 30 is higher. Yeah? And that can be really a challenge. Possible solution, dorsolateral plating, tibiofibular transfixation, fixation of the posterior wedge of the tibia even if it's small. That's are tricks to get it more stable in osteoporotics. That's dorsolateral tibiofibular and so on. And the approach from dorsal, indirect reduction and minimizing the soft tissue damage. That must be, if you have an osteopenic bone, think of these options to have less complications. In summary, what is important in ankle fracture? It's, in the beginning it looks simple, and you do with it, deal with it, the more complicated it becomes. Correct and good X-rays, correct positioning. I think the modified tension band wire is a big advantage, especially on the medial side. Dorsolateral plate is a big advantage against anterior plating, and fixation of tibiofibula in extreme osteoporosis is a big advantage. Indirect reconstruction according to mass, to weight with this tubular plate and the distraction, correct position and indication of the positioning screw, that is important, and the dorsal approach to the posterior wedge and reconstruction under direct visualization is a big advantage. Yeah? A standardized procedure is essential. Thank you for your attention.
Austria, in cases you differently ask the CT scan also.
Okay. We are very aggressive with the CT scan because it depends. You have really good X-ray, you can check it. But you make a lot of X-rays before the operation, but you make a lot of X-rays after the operation. So, because very often you see the X-ray even very often you see after the operation, the X-ray is not perfect. It's easier to check it. It's really, there exists a paper from Germany, Martinus Richter. There exists a paper from Germany, from Martinus Richter, who was the past president of the FICS, and he said he found 42% of correctable malpositioning after operation of the ankle fracture. I said to him, if my staff would of malpositioning, to learn, but he didn't like this answer. But it's much higher than you think. And the interesting thing is that after an ankle fracture, the results, you always think it's a simple fracture, and you have a lot of patients which are not satisfied. Because I have some pain, I have a lack of motion, I get some arthrosis. That means cartilage damage and malposition is one of the most common reasons. Okay, yeah, okay.
So Dr. neglected ankle fracture, few case examples, and then after we will have Dr. Ramakant sir to present his.
Comes. That's okay. Yes. My talk is the different thing, malunion in foot and ankles. That's really a very, very tough thing. If you look at these feet, on the left side, on the right side, that's really mal-positioned feet. What to do with them? Yeah? What does malunion mean? Should look for an answer. That's what we really have, and sometimes, and then we know it from big joints, and as anatomic reconstruction as possible should be done. That's really essential, but it's especially in the distal. It's sometimes not so easy. Yeah? When we make a reconstruction, think on a reconstruction in foot and ankle surgery. One can be acute cases where you have a malposition or malreduction. And all the others are unnecessary. But it means if you have unnecessary joints, you can take these joints for correction and fuse these joints because the foot still works. And that's one of the most important things for reconstructions. Yeah? And what is the most important thing for a good function of a foot? Position, position, position. If the good foot is in a good position, yeah, Ted Hansen said, if it looks good, it works good. If you have unnecessary diagnosis, and this hospital where it was done, it was fixed with K-wires, and it was not done a post-operative CT scan. Yeah? And then it was fixed, you see it here, in a malposition. It was subluxed and it was unstable. And even in a 15-year-old, what can be done, even if they're so young, of course, it's a non-essential joint. It's good. And we fused it here. It's of course it's simple. You see, we fused it here with a K-wire, and after half a year, it was totally fused, and the patient was happy. That's very simple because it was a fusion in an unnecessary joint. Yeah? And that's the key. If you do a fusion in an ankle joint, a 15-year-old girl, it's very bad for the future. And this works, and that's the final result. Basic for academic examination, check the leg in position to the foot, checking the range of motion of the joint, for cofactors like cavus, diabetes, neurologic, and so on. That's the basis. And then the question is, do we have reduction? If you have a malreduction, you should restore and make the reduction better. If you have a malunion, you must correct it. Yeah? And then correction fusion. That's the question. And very important, we had here before, Achilles tendon is ruptured, but the Achilles tendon shortening is one of the very bad things in the feet, and the lengthening of the Achilles tendon is a very good procedure. Yeah? And that's the situation. What do we need for planning? Coleman block test is for me a very good and interesting test for the cavus foot to look how is the mobility of the hind foot. If you have a Coleman block test, you see that the hind foot goes in the correct position. Hind foot and the flexible situation. The flexible situation should be treated different than a fixed situation. If you have flexible leg position, you can do a lot with tendon transfers. If you have a fixed position, you must do osteotomies or osteotomy fusions. Like that's a Coleman block test, and the other is for me very, very important. You see where's the axis. Yeah? When you have such a situation that the calcaneus because it's case, yeah, CTs can be asked before, CTs can we do? The case, you see here, plate here, but you see, here in the ankle joint, you see, that's a malrotation, yeah, and of course, X-ray looks good, but you only see this on the CT scan. Bilateral. We make it with both feet, and when you do it bilateral, you must do it in the same position of the ankle joint. It must really be checked that it must be in a 90 degrees position, because if you make the operated in the cast with 90 degrees and the non-operated in a plantar flex position, you cannot compare it. You cannot only compare it when the foot is in the same position. And that's for the CT scan, if you compare it with both sides, essential. And that's what we did in this case, you see, and it was corrected. When we go to the distal tibia, if it's possible, in a pilon fracture, but very often reconstruction are possible. That's a pilon fracture with a typical varus alignment, and you see. So you see this situation, it was not done by us, but you see it's a typical situation, pilon fracture, no plate, only some screws. And that's unstable. A stable situation on the lateral side and an unstable situation on the medial side. What happens? You get a varus. It's normal. Yeah? And then, after removal of the screws, she had a slight infection too. Yeah? First was healing of the infection, and then removal of the screws, and that was the final result then, after healing. And now the question is what to do. Should we let it or not? Yeah? Is it tolerates this position or the malreduction or not? And of course that's bad for the joint. Yeah? And especially she had the most fracture on this side, on the medial side. And with this varus position, the highest pressure now is on the medial side. Yeah? The weakest point of the joint has the highest load. And that means it's a good idea to correct it, because then the pressure goes more to lateral, and you see on the lateral side the joint looks much better. And that's very, if you look at the hind foot, it's not very much difference. It looks not almost normal on both sides. But the patient tells me, he says to me, I stand too much on the lateral side. I feel too much pressure on the lateral side and not on the medial side. And said it is. And what we did is an additional correction, osteotomy in this double plating. And you see it here now. It was done with these special plates. And what for me is really, we make a compress it on the and then you have this calcaneus on this side. It means you have a arthroscopy to lateral. Yeah? And the question is always only to make a correction of the tibia or to correct both. And these cases I always do both. Because the correction of the tibia, you cannot change the position of the distal tibia only some degrees. If it's too oblique, you cannot walk. It can be 5 degrees. And what we did in this case, you see, we opened it here, made a closing wedge osteotomy, and still, you see, the calcaneus is still not under the axis. And that must be mentioned if you make a correction. In this case, you must add a calcaneus osteotomy. You deal this medial displacement osteotomy. It's very simple. We always make it with a plate. We prefer it with a plate because then we can really make 8, 10, 12, 14 millimeters as much as we want, and it's controlled. And that's pre-operatively, and you see it after 3 months, the gap opened. Yeah? Calcaneus is under the axis, and that's really correction what can be done. Another case, again, it was ski accident. It's rare in northern India, ski accidents. We have it more in Austria when we have snow. But you see, he was operated with this distal tibial fracture. Yeah? And you see the positioning of the joint is not perfect. And there's always a question, should we do it or let it? It was 12 months after he was not happy with it. Then you see it does not fit together, and then the CT scan. And what we did find is the distal end of the tibia, that's correct in length. The other part, what we did in this case, we opened the old fracture, yeah, did let the plate in place, removed the part of the screws and lengthened it. Yeah? We osteotomized it and lengthened the distal tibia, and then with lengthening of this distal tibia it came down, and then the alignment was perfect. Yeah? And then you see the final result. Now it looks like a normal ankle joint again, yeah? And it was healed. It was the same plate like in the beginning. We didn't change the plate because we only changed the distal screws, but not the plate, because the plate was okay. Another case, 50-year-old female, smoking a little bit, non-alcoholic, that's important. It's not so important like in our country. And she has pain since 6 months. And she came without any treatment after 6 months with this situation. And that's the question what to do. When you see this subluxation to anterior impaction here, and said, okay, can only be a total ankle or a fusion? She said, no, I don't want the total ankle. And said, okay. She said, let's try if you can reconstruct it. Said, let's try. And then came posterior approach, big advantage. And you see the posterior approach, opened it. You see the subluxation to anterior. But when it's in prone position, you can press it posterior. And then the trick was, we went with the wire through the tails and went into the anterior part of the tibia, but through the tibia on the tibia. And with this, we brought the tails back. Yeah? And then we take a laminar spreader through the joint to distract it, to get it loose, and then we could really bring it back. And then you see, and at the end you see, it looks like a normal joint. It's still, because it was 6 months, it was almost healed, but after 6 months it was still possible. Yeah, we fixed it with 2 plates. Yeah, the K-wires was then removed after some weeks, and that's the result after 2 years. There's still no arthrosis and has a good function. So that means there are really very often options to make a reconstruction even in such tough cases. That's another tough case. It's a talus fracture. He came after 8 weeks with an external fixator and this situation. These K-wires are very interesting because they are in the fibula. He was a sport teacher and he was 30 years old. Yeah? And then if you look, that's a CT scan. Yeah? And when you have this situation, ankle joint, subtalar joint, yeah? And this fracture and malrotation, what can be done? Make it sense to make a reconstruction in this case, because it's a sport teacher. If you make a sport teacher, you must make a fusion of the ankle and then the subtalar joint. That means she gets a totally stiff hindfoot, you cannot work anymore. And we tried, okay, let's do. We opened it, made our tension band wire for the osteotomy, and then that's the talus, you see. And the talus, you see some, from the K-wires, you see some attempts of the first surgeon, and then we reconstructed it, filled it then up with a bone graft, and we could really, in this case, reconstruct the ankle and the subtalar joint. And that's the final result. You get some avascular necrosis here, but it healed, and she's still working as a sport teacher, and she's active and she's mobile. That you see, that's the final result after 2 years. That's the range of motion what she has. That means it can be really done in many cases, big reconstruction, if possible. If you look at this case, when it comes, looks crazy, but that's X-ray. X-ray looks more crazy than the foot. Yeah? And what can be done in such a foot? Because the patient said he can amputate it, of course, but it makes it sense. And we said, we had a CT scan and it sees the ankle joint was the only joint which was not destroyed. It was not so good, but it was not so bad. Yeah? And said, let's try to make a complex reconstruction. We made a really three-dimensional reconstruction. Made the distal fibula and the tibia and fused it here. But we did the lengthening osteotomy of the first and so on. But what you see, the ankle joint, now you see the ankle joint. And we said to the patient, we fuse your hindfoot, we correct the axis of the distal tibia, and at the end, if you have still problems in the ankle joint, we make you an artificial joint, you make a total ankle after it. And that was the result, you see, it's healed after 3 months, and she said, I don't want a total ankle, I'm so happy with my foot, and she's now working for more than 10 years, and she's still working on it, and didn't do an additional operation, because the foot is balanced, and the foot is in the position, and that is really so important. And you see the end of the situation, that's the final result, you see. And what's really interesting, there's still a joint space on the ankle joint, and with this she walks. And that's the final, that was before the operation, she is standing now. Next crazy case, distal proximal tibia fracture, osteosynthesis, infection, compartment syndrome. Due to the infection, the compartment syndrome, she did get a stiff knee, and from the compartment, this equinovarus, and a stiff equinovarus. That means she had a stiff foot, a cavel's foot, and a stiff knee. So it's the craziest situation what you can have. A malposition of the foot and a stiff knee, because she had a fusion on the knee joint, meanwhile. And that's the situation of the foot. And then, what's the question what to do? One attempted to make an Achilles tendon lengthening, that did not work, of course. Yeah? And then we opened it, she came, that's the fused knee. And then we opened one joint after the other, and nothing did happen. We opened one joint, and the third joint which was opened, my nurse asked me, and now what is the next joint what you will open? And nothing happens. And then we were moving it, and we were working on it, and then you see here, we loosened the navicular bone, and then the navicular bone popped out. And even in the moment where the navicular bone popped out, it was mobile. And then, you see it here, we fused it, made a talar cuneiform fusion, resected the CC joint, and fused the talus to the cuneiform. Now we have done it about 15 times in cavel's fit, and it's really a very good procedure to resect the navicular bone, resect the CC joint, and correct over the Chopra joint the cavel's foot. So it's really a good, and in this case, you see, that's the situation it was before, and now that's the final position. The foot is a little bit shorter, but she's balanced and she's good aligned. Well, in this case, that's ski accident again, yeah. Here and here. What to do? And the question is, you must correct it here, you must correct it here, the forefoot. Which approach is possible? Because if you come, how do you come here and here in one approach? That's and there exists really, that's the situation of the patient, yeah? And that's the approach, that's really the published approach. It's a longitudinal incision over the heel from distal to here. And you see it here. You can open it in one flap. It's really important is to make it in one flap exactly central on the calcaneus, up like your Achilles tendon. Same incision that you make for the Achilles tendon, then you go down to the skin, to the bone, up to the midfoot. And then you can resect this bone, impact this bone in the defect, and with this you can reconstruct the height of the hindfoot and make a subtalar fusion. And you see that's the lateral wall of the calcaneus, that's our resected lateral wall. The ankle joint is still okay. We have, and if you look here, how is now the distance of the distal tibia to the talus, yeah? And that's the healing. If you make such an incision through the skin, you see it heals, yeah? Again, and that's the final result. And now he's standing normal and walking on it. That's really all options what can be done in the hindfoot. And before I show you the last case, then I will finish because I'm much too long. Sorry for it, but that's a very impressive case. Distal tibia fracture, yeah. 5 times operated, 5 weeks after the accident. You see, you look on the plate, and you have some skin graft, but you know, slow infection. Plate is looking out. What to do? It's really a tough thing because that's all damaged. And you have a big defect, and very often it's done in a Liserov, but you do in a Liserov over 10 centimeters in an adult. So it's really a tricky procedure, and you have a lot of complications. We did out, and make it with a colleague, we did out this infected dead bone, and then, despite the low-grade infection, we made an intramedullary nailing, yeah. No problems. If you make a fusion 4 or 5, the patient is not happy because it feels stiff. That means TMT4 and 5 is a joint good to have, and MTP1, the basic joint of the great toe. Yeah? But essential joints are ankle subtalar TN and MTP 2 to 5, metatarsal falso 2 to 5, because when you fuse this, you cannot walk. With a fused MTP joint, you can walk. And all other joints, all the joints of the midfoot, this franc 1 to 3, and C joints are all unnecessary joints. And this can be fused, and the advantage is it cannot be only fused, you can take the fusion for a correction. You can not only fuse them, you can make your correction over this joint and you take out wedges, and then you can take out the one. That's a concept, and it really works.
Thank you, sir. By the time we can have one talk from Dr. Ramakant. We will talk on diabetic foot and orthopedic domain.
Good evening once again. I thank SK sir, Swaroop and Amit for giving me this opportunity. I seek apologies for altering the program because of the climate conditions. They have preponed my flight, so that's why I had to wrap up with that. Apologies for it, for changing the order of the program. So my expertise is diabetic Charcot's hindfoot and midfoot reconstruction. So in this presentation, I'll be talking on what is charcoats, midfoot need for reconstruction, hindfoot, what is the role of plastic and orthosurgeons. So charcoats is a limb tetany condition. It is due to neuroarthropathy, instability leading to deformities and ulcers, infection, and then progresses finally to an amputation. So the diabetes, neuroarthropathy, loss of joint sense initiate the process, and then the bony deformity occurs due to various pathogenesis, and these bony deformities causes dislocation of the bones and the progression of deformities, and then further loading can also cause ulcer on the bony prominence, and then the vicious cycle continues. So we all know that forefoot, midfoot, hindfoot, the most common portion is hindfoot and the midfoot region. And to start with, the dislocation can lead to the pathological fractures, the collapse of arch, and then some patients' foot gets consolidated and forms a rocker bottom foot, and then eventually the ulcers develop due to altered weight bearing region. There's a stage of presentation, acute stages, we can treat it with cast immobilization and these kind of appliances, and ulcer management, regular dressing, and surgical management for ulcer, and then surgically orthopedic part of view, the fusion, debridement, and exostosis. So the debate always happens whether to treat early stabilization or non-operative, and further the surgical management has 20 to 30% of complications as well. So the challenges in non-operative management are prolonged non-weight bearing walking with these appliances, poor patient's complaints, total contact cast, and ulcer management are the challenges. So what is the need for surgery in these patients? So once the arch collapses, so we can see that there is a high pressure in the foot which can lead to ulcer formation at these regions. So is it possible to achieve by surgery to get a good result and reconstruct the arch, prevent the ulcers or heal the ulcers and stabilize the foot, and what are the implants and fusions principles we need to follow to salvage the foot from the amputation? So there are three sets of joints in the midfoot: TMT, intertarsal, and the hindfoot joints. So the clinical presentation of charcoats, generally they present with the deformity, flat foot, ulcers, self-dislocating bones, and the midfoot instabilities. So we'll see the examples of each one of these. So these are the presentations: flat foot, forefoot abduction deformity, midfoot instability, where we can ballot it with the fingers when there is unstable midfoot because of chakra, they present with an ulcers. So here we can ballot it because of the midfoot instability in some of the patients. So some of the examples are here. The patient has a severe abduction deformity and medial prominence. And here from the X-ray we can see that there is a forefoot abduction and a lot of pressure on the medial aspect which causes the ulcer. So the abduction deformity is quantified with first talo metatarsal angle, and we can see that ulcer. So this is a culprit for the ulcer formation. So once the arch is reconstructed, this ulcer goes for a healing, otherwise it will stay as a prolonged non-weight bearing healing. So what happens when the patient presents with a kind of infected ulcer like this? So the exostectomy would definitely deload that zone of foot, and then the ulcer will go on to heal very well. And after that we can plan for a secondary arch reconstruction. What if patient presents with the infected large ulcer like this? So the stage 1 management would be definitely ulcer management, and then the second stage, to prevent the further ulcer formations, we can do a arch reconstruction. So here another patient with a prominent midfoot region has ulcer, so for which exostectomy was done. So if it is a clean ulcer, then we can directly do a arch reconstruction, and then the ulcer will go on for healing. If it is a large ulcer, again the ulcer excision, and then the secondary stage, the arch reconstruction is needed. If it is a so what are the examples of pathological fractures and self-dislocating bones? So the bones can subluxate like this because of Charcot's arthropathy, or in this case the cuneiform is being dislocated. Here the cuboid is getting, it is all self-dislocated. There is no trauma or very minimal trauma or trivial injury, where the bones get dislocated because of the Charcot's arthropathy. Here the intermediate example and the navicular getting self-dislocated and then causing ulcer on these regions. So very important to take weight-bearing X-rays. Talometatarsal angle will quantify the amount of forefoot abduction deformity, and the Mary's angle will tell about the arch collapse, and we can quantify it by measuring the first MT to talar axis angle. The principle of fixation what we follow is the medial column fusion and the lateral column fusion for the medial column bones and the lateral column bones. So we use a long segment IM screws for arch reconstruction and bone grafting, and then super construct with the plate augmentation. So some of the case example, this 48-year-old Charcot right side with healed ulcer on the medial side and impending ulcer on the plantar aspect. These are his range of movement. So these are his X-ray where we can see that there is a dissociation of TMT joint causing prominence on the plantar aspect. If you don't treat it early, then this patient will develop an ulcer at this point where there is a bone prominent on the plantar aspect. And here we can see that forefoot there is a abduction deformity, and then there is a splaying is there, so the fourth metatarsal is not aligned to the calcaneum, and here we can quantify it with measuring the fourth MT axis to the calcaneal axis. So the Mary's angle in this case it was about 43 degrees, where normal is only about 5 to 8 degrees, and the calcaneal pitch is also lost, means that calcaneum is slightly in the plantarflex position, and the cuboid also was in the negative height, that is beyond the horizontal line. So the deformity in this was forefoot abduction, forefoot splaying, arch collapse, plantar prominence, and heel cord tightening because of calcaneum is in slightly in equinus position. So through medial and lateral approach, this was what the arch reconstruction was done, long segment fusion augmented with plate augmentation. Lateral side also was depreded, and then the tricortical graft was put. Here we can see that Mary's angle is corrected to within normal aspect. The forefoot abduction is also corrected from 18 degree to 9 degree, and the Mary's angle was corrected from 43 degree to 3 degree, and it all holds up even after 1.5 years of follow-up. So the principle is medial column fusion to talus and lateral column fusion to hindfoot. So for hindfoot reconstruction, ankle and subtalar joint, the option is TTC fusion. So I'll go directly to the case example. The patient presented with pain and swelling for almost 9 months, discomfort in walking, and we can see that the subluxation of the ankle, there was a gross abnormal movement at the ankle and the subtalar joint, and we can look that hindfoot is in valgus. So he walks like this with a valgus thrust, and almost to medial side we can see that it is jetting out, the medial tibial was jetting out. This is his X-ray. It clearly shows that calcaneum is completely dislocated onto the lateral aspect, and then the weight bearing for him is at present is the talus, and he walks with a valgus thrust gait. So TTC reconstruction with hindfoot alignment is very important. Once we got the ankle and subtalar aligned to the tibia, the fibula was higher. So fibula can be used as a stud graft for the fusion. So to incorporate fibula onto the IM nail, I have distalized fibula like an onlay graft that gives the lateral good support for the good healing, and the fibula was distalized, and then the standard procedure of TTC was done. And here the interlocking nail is inserted, so this gives a 4 cortical purchases onto the nail, tibia and the talus. So these the small amount of fibula also was used as stud graft for the anterior healing. And the extra nail additional screw fixation from the calcaneum to tibia is also passed. So this is the hindfoot reconstruction with fibula being the stud graft and the anterior aspect as well. So this is a 2 months follow-up. This is a 4 months follow-up, and then it is completely consolidated by 3.5 years follow-up of fibular stud graft, and hind foot is reconstructed. So this is a pre-op to 3.5 years follow-up of comparison of lateral view and also the ankle AP view, where there is a happening. So this is his walking from valgus thrust gait. He is able to walk. There is a slight varus from valgus. Slightly there is a varus, but varus is there at the final, but patient is tolerant to that. So for the decision making, midfoot and hindfoot, the stage of presentation is important. Early stage conservative and non-operative and ulcer management, and all the pre-op parameters needs to be considered to decide on operative and conservative management. So pre-op parameters, what we take is ESR, CRP should be normalized, HbA1c should be less than 7, and the arterial Doppler to know the vascular distal vascularity. So conservative is inflammatory stage, high risk patient, and severe atherosclerosis, all can be treated conservatively, and operative patients are plantar dislocation, quiescent stage, midfoot instability, tight heel cord and self-dislocating bones, and the deformities what we spoke. So the midfoot Charcots present as ulcer with bony prominence with instability, or consolidated midfoot with just plantar prominence, or foot sepsis which needs amputation at the primary stage itself. If it is only bony prominence, exostosis can be done. For ulcer and plantar bony prominence and midfoot instability, arch reconstruction is required with long segment fusion as shown. The post-operative protocol, cam boot is required almost for 6 to 8 months to protect the surgical fixation, and the weight bearing is started only after 3 months. So these are some of the examples. The arch reconstruction was done, and then 1.5 years there was a secondary collapse, and then the patient developed secondary ulcer, this time for which exostosis was needed. Of course, we do have a lot of complications in these Charcots. Infection and cellulitis can present as late as 1 year or 1.5 years. Implant breakage is another common complication. This was only the long segment fusion was then, but the secondary superconstruct was not added. So what is most important in Charcots is to stabilize with long segment fusion and provide independent walking for the patients without support to have their own. And of course the arch reconstruction will heal the ulcer well, and the goal is to salvage the limb from ulcer and provide ulcer-free plantigrade foot, so that the therapeutic footwear can be walk and then provide a long weight bearing. So we had analyzed all our patients' results. We had 88% satisfactory result, and it is the largest reported case series. We had good correction of abduction and reconstruction. So we have published our hindfoot and midfoot series in JFAS AP. It is freely available in Indian Foot and Ankle Society website, and also published various options for hindfoot fusions with tricortical, allograft and other things. So from our experience, good results can be obtained in 80 to 85%. Arch reconstruction is possible. Secondary collapse can occur in 45% patient. The patient needs to walk without ulcers, and superconstruct is the answer. The learning point is early ortho stabilization and arch reconstruction again with long segment fusions and TTC fusion for hindfoot. Thank you.
So we are going to have a next on ankle and subtalar arthroscopy. Then after we will proceed with the pediatric foot examination.
Thanks again, sir. Sorry, I'm continuing it. Apologies from the foreign faculties to have taken changed the order of the presentation. My next talk is, I'm basically arthroscopic surgeon, ankle and hindfoot arthroscopy. So anatomy is very important, where it is very simple joint compared to the shoulder, just two portals anteriorly, medial to the tibialis anterior, and the hind foot anatomy is important to know. These are the 4 tendons which we need to keep in mind. It's very simple, nothing to be nothing complicated. It's a posterior tibiofibular, PTFL, FHL tendon, and intermalleolar ligament. So understanding regional anatomy is critical for arthroscopy. This anatomy, we know that subtalar joint has 3 facets, and only posterior arthroscopy we look only into the posterior facet. And the indication for ankle arthroscopy is commonly the synovitis, impingement and instability, and the bony causes are osteochondral lesions, loose body, traumatic osteoarthritis, ankle fusions. So this is the normal and the OA and loose body ankle arthroscopy. I'll be showing the photos and videos. So the position, the 3 positions can be used. One with the thigh support, and or with a traction device, or just patient at the edge of the table, 2 to 3 centimeters beyond the edge of the table, which can be used for the ankle arthroscopy. Distinction with the gravity flow pump is really not needed. The traction, there are manual traction can be given, or with the mechanical devices, the traction for the ankle joint to look into the ankle. But the traction should not exceed more than 7 to 8 of distraction, and forces should not be more than 90. It can cause secondary ligament injury, iatrogenic injury. So the standard scope, 4 mm scope and 30-degree arthroscope can be used, but we need a smaller burst and graspers to have really play around the ankle joint. So the 2 portals, most important 2 portals are anteromedial portal, just medial to the tibialis anterior, and the anterolateral portal to the long extensor tendons. So the portals. So this video of showing marking of the soft point and then the tendons, and then we can mark the portals, and then insufflate the joint with saline for it gets distended so that passage of instruments are easy, and then we don't do any damage. So the diagnostic round is very simple. There is no big anatomical structures around. Just we'll be able to see the distal tibia, lateral malleolus and the talus, and the medial gutter, lateral gutter, the central portion, and the anterior portion. So if the joint is distracted well, we can go into the ankle as well. So here we can see the anterior tibiofibular ligament, and the trifurcation point we can see that the facet of the lateral malleolus, the talus, and the tibia. Once the joint is distracted good, we can go inside the ankle. We can see the posterior structures from the interarticular portion. That is a posterior tibiofibular ligament, and posterior talofibular is lower here, and posterior tibiofibular is higher. This is fibula, this is tibia, the posterior tibiofibular and talofibular. And then we swipe it across, go medially. There we start moving the great toe. We can see that like a pulsating, that is the FHL tendon, movement of the FHL tendon. And then that is a medial gutter, and then the medial deep deltoid ligament also we can see. Not many anatomical structures are there in the ankle. Posterior scopy, we can use it with the prone position, and the most important indication of posterior impingement and subtalar arthritis. The other indication for hind foot arthroscopy are, again, as I told, loose body, calcification, avulsion, osteophytes, and arthritis. The cartilage lesions, as I showed, chondromatosis or posterior OCD or intraosseous talar ganglion. The posterior, the last 3 zones can be addressed from the hind foot arthroscopy as well. And the soft tissue like synovitis or PVNS, which are very rare, are also the indications. And the fracture fixation also can be tried with the arthroscopy. So coming to clinical case example, this patient had pain in the ankle for 1 year and fall from height from 1.5 years. He was able to walk, but he had a lot of pain around the ankle on the lateral aspect. That was the point tenderness he was pointing out. There was a lot of pain in the subtalar region. So we can see that there is a step off, and then it is a malunited calcaneal, simple malunited, not much varus deformity. So if there is a varus deformity, then probably we have to combine with the osteotomy, or only if it is a pain and subtalar arthritis, hindfoot arthroscopy can be done. So patient in a prone position, we need two portals, posterolateral and posteromedial portal. So how to mark the portals? So first is to draw the tendo-Achilles on either side, and then the medial malleolus and the lateral malleolus is drawn. So that is a medial malleolus and the lateral malleolus, and then we can take the ruler, transmalleolar line can be drawn. So this will give exactly the what level we can go up, and then on just above the transmalleolar line we can draw this posteromedial and posterolateral ankle portal. Sorry, and then the arthrodesis we may need an accessory portal, that is the accessory sinus tarsi portal. Okay, once we mark the portals, and this is the intermalleolar ligament which I told, and this is through the sinus tarsi portal we can distract the joint with use of that Wisinger rod, so that gives a space for us to clear the cartilage debris, and the cartilage needs to be removed with a shaver. We can use a ring curette to remove the articular cartilage from the subtalar joint, that is from the inferior portion of the talus and the superior portion of the calcaneum. So once we need a good debridement of the joint for the fusion to happen for bony to bone region. So this creates a space of almost 5 mm in the end, and then our just 6.5 mm screws may not be sufficient to cause the compression. So here we can see that guide wire can be passed under CM as well as under arthroscopic guidance. So we can see the where the guide wire goes, then it will visualizing the subtalar joint through the hindfoot arthroscopy. Here the reaming is being done, and then the screw is being inserted one after the other. So the space may not be able to completely collapse, so we might need some bone graft or some allograft to pack it to this 5 mm space. We do get some amount of compression, maybe like 3 to 4 mm with the screws, but then some bone graft might be needed to pack that joint. So this is the final picture of hindfoot assisted subtalar fusion, minimally invasive technique. So recently we had that distal tibial osteoid osteoma case just about 2 weeks back. So it was diagnosed with the CT scan with the nidus. So we also have worm in our CT guided navigation in our operation theatre. So we, since the technology was available, so it was made use, and then these are very minimally invasive, gives good pain relief for the patient. So arthroscopy and also the CT guided navigation was done. So this is a subtalar joint and joint, and then the intermalleolar ligament, and then above the tibia. So the CT navigation also was done for this, identify the exact location of the lesion. and then we could also see the lesion from the hindfoot arthroscopy, and we did the thorough curettage and burring out and cleared the lesion. So this was after removal. We can see that nidus is gone, and intra CT navigation also was done, and also to prevent the recurrence, the coagulation and burring and then curettage also was done to done for the lesion. Yeah, so the another indication is just to clear the hindfoot haglund. So to conclude, ankle arthroscopy is relatively new and dynamic tool, and the decreased morbidity and faster recovery and careful attention for the surrounding anatomy and meticulous instrumentation will avoid complication and achieve the desired results. Thank you. And it is very simple to do as well. Thank you, sir.
Thank you, sir, for your wonderful talk. Now I request
किशोर इन 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 हो गया गया गया
मुझे हॉल में थोड़ी हलचल नजर आ रही, भूख लग रही लोगों को, या थक गए, बेचैन हो। So boss, it's always a very tall order to follow any faculty from Ganga Hospital. So Ganga Hospital to orthopedics is something what Tata Hospital is to cancer. You know, whenever somebody stands and he says he's from Ganga Hospital, faculty becomes great. They are always one of the best faculty, as you could have made out from the talk. Now today we are going to do a very basic thing. Okay, we got a 7-day-old boy, and I'll just show you how, as a pediatric orthopedic surgeon, I go about quickly examining every aspect of a 7-day-old child orthopedically. Okay, and now the parents say that the child has some foot deformity. So the first thing that comes into your mind is obviously club foot hi hoga, but it's not necessary. It can be vertical talus, it can be something else as well. Okay, so and the examination has to be real quick, because the child is not going to allow us to do very elaborate evaluation, and yet everything which has to be sort of locked in your brain has to come about. So before, of course it's a part of my talk which I'll also tell you later, but what all am I going to see? So am I going to see that is it truly CTV, is it a idiopathic, non-idiopathic variety, or it's merely a postural variety, and does the child have any other problems, and how am I then going to get this diagnosis and then counsel the patient. Okay, so fortunately for us, in spite of the cold, in spite of the audience, the baby is still quiet, so we are very blessed with a quiet baby. foot size is smaller than the average foot size. An average foot size of a newborn should be 7 centimeters. And this is roughly we calculated 5.5 centimeters. Okay. Now I am not getting any dorsiflexion here. Normally you should get about 40 degrees of dorsiflexion in a newborn foot. And there is hardly any eversion. So we know that this is a structure. Now we come a similar opinion on the left side, because the child is cranky and we doing this fast. So this child I have already previously examined has got very straight knees. Normally in a newborn you should have about 15 to 20 degrees flexion at both the knees. So if the knees are very straight, right, almost neutral or recurvatum, so it's very important to examine the knee and the hip. This particular patient, the left hip was a little odd, just a feeling I had of a little odd feeling. So we may do a USG of both the hips when the baby is 3 weeks old. Now for this we quickly do the trunk evaluation and we have to do the spine evaluation to look for a low sacral dimple which this child has. I don't know whether the camera is able to show, but the child has full movements are there, whether there is any arthrogryposis. So आप उसको फीड करेंगे. So basically what am I concluding? I am concluding that the patient has bilateral complex clubfoot. Why am I saying the patient has a complex clubfoot? Because the deformity is very severe. The medial crease is extremely deep. Okay. And how is it going to differ from our regular idiopathic clubfoot manipulation? All of you all must be doing clubfoot manipulation. So you can tell me, how will a complex clubfoot manipulation differ from a simple idiopathic clubfoot manipulation? So the first cast which we give, we take the entire foot. So it's not just the first metatarsal which will be taken into supination. Whereas as many metatarsals, all the 4 or 5 metatarsals, as much as you can grip in the small foot, you will take into supination. Okay, and a complex clubfoot casting will go much slower than a regular idiopathic clubfoot casting. So I have covered it in my talk also. An idiopathic clubfoot will be between 4 to 6 and a complex clubfoot cast will go between 7, 9, 10, 11. But the outcome would be great. So there would be no problems at all. Okay, but you must be able to identify that this patient has complex clubfoot. Counseling will differ. The fitting of the foot abduction orthosis, which we are going to do, will also change. Okay, the patient may not tolerate your standard 60-70 degrees of abduction and external rotation. So you may start with a lower range and then gradually build it up for a better fitting of the FAO. So this is how a complex clubfoot management would differ from a simple idiopathic. I'll cast the baby once the baby is better fed and quiet. A few more things which I have also covered. A pacifier to be given, it's officially proven actually by Dr. Anil Agarwal, in a published paper, that a pacifier actually keeps the baby quieter as compared to even parental presence or feeding. So a non-nutritional pacifier, they have objectively documented with pulse oximetry readings, and they have found that the child gets lesser tachycardia, the cry, they have also measured the decibel of cry and the duration of cry of the child. So it's a very, very interesting spectrum. And the beauty of clubfoot is it's a democratic condition, right? There is no orthopedic surgeon has ever referred a clubfoot to me, though I'm a pediatrician. So it just comes sporadically, and I must be getting the same probably number of clubfoot as anybody with any huge practice in my own private practice. They come to gravitate towards educational institution a lot. Therefore, you will see lot of published literature from teaching hospitals, especially because of the Cure Foundation and the free castings which are done, right? So it will be covered, everything will be covered in my talk. So I have covered from antenatal counseling से लेकर ना सर early relapse कैसे identify करना है उसको gradually मैंने cover किया. अभी फिर फटाफट खाली casting दिखा देते हैं. Sorry, I'm deviating to the colloquial language. It attracts them more.
We have one more case. What is that? The baby is dead. It will be displayed here, so you can examine him then. तब तक बच्चा feed करा. We have another case.
examine the case before. Okay.
Sir, you are the master. You can do it.
पूरा पैर ये पतला है ना, ये भी पतला है, ये और ये सेम साइज, ये भी पतला है, चल के दिखाइए, So I would not expect a neglected clubfoot to be like this, right? A neglected clubfoot is going to be walking on the, yeah. So this patient is definitely something else. And so how I would think, means I have not seen the child, so I would think maybe some sort of a neuromuscular condition, some sort of a spine issue, something of that sort. But by this time, if it was a spine issue, the patient would have developed trophic ulcers, which the patient has not developed. So as of now, these thoughts are running into my mind. In a more sort of a comfortable environment, I would like to disrobe this patient and then examine him, then assess the power, then maybe draw a conclusion. X-rays, and I would like to see what's the situation of the heel. The foot surgeons are all here, but I don't think the hind foot is the cause here. The whole problem is at the midfoot. So probably we contemplate a midfoot and a foot sort of shortening procedure which will give instant result to this patient. My personal experience says that we tend to undercorrect them. So I think to do it very precisely is the most important.
Will you do the neuromuscular condition? Interphalangeal joint.
Midfoot करेंगे. Midfoot osteotomy.
For the osteotomy, there should be the level of should be there. Where will it start? Muscle power should be there. This seems that muscles are atrophic.
बैठा सकते. बैठो बैठो ऊपर.
इसमें ऊपर बैठा दो.
But whatever you would say, no, I would not debate on this particular patient because I really that's a very honest admittance. So basically I have been cornered with this case, but I would probably do soft tissue release plantar, do sequential serial casting, okay? Then probably I would even contemplate putting in a jazz fixator and doing distraction and seeing how much I can achieve, and then minimize the amount of bone that I would have to resect for the osteotomy.
Is there any subtalar movement or tibiotalar movement? How is that?
It's pretty supple because it's not been treated before. So the problem is all at the midfoot. I'm sure.
Sir has examined. Once you give one perspective, I think we'll get sir's perspective.
Yeah, please take his perspective. My perspective, I said soft tissue release, serial casting, maybe apply an external fixator for distraction, minimize the amount of bone required. But ultimately, our objective would be to give him a painless plantigrade foot and then maintain it with an AFO for some time. If he's got good active power, he should be able to retain. And of course, make a genuine attempt to have the but the joints are pretty intact, sir. It's all happening at the plantar fascia. It's all happening at the plantar structure level. And there is not much
Of equinus, it's all at the midfoot level, and the posterior part of the talus is articulating with the tibia.
We have checked the patient.
We have checked the patient some hours ago.
It would be a Charcot Marie tooth because he's got some cavus on the other side also. He's got a tight plantar fascia on the right side of the patient.
Yeah, but it's a unidirectional deformity. It's like a duckfoot. It's a unidirectional deformity. So since the Achilles tendon is much too short, it must be. To me, the problem is the plantar flexion of the midfoot is 100 degrees, and if you take on the wedge, you get about.
So close from the dorsum and open from the plantar.
But it's really unidirectional. The reason is unknown, and he has no short leg. If you look at leg discrepancy, it's if you bring it up, you see it's almost the same length. That means yes, the biggest problem can be to bring the talus into the joint.
The biggest problem would be to get the talus back.
Yes.
But I
guess that we are going to read the way it is, right? We are going to correct ahead of the talus.
Is it a muscular imbalance in this?
Mostly it is a neuro.
But you know what?
Neuromuscular is a nice broad term. So many things come into it. Charcot marriage.
Yeah, something like that.
I think
Some variation of the Lamborghini.
Yes, but the Lamborghini is for the high foot. And he has a
midfoot.
Yeah.
So your wedge will be where it will be centering the wedge, where you will be centering. What will be the apex of the wedge? What will you do to the soft tissues?
The soft tissues is you must release the plantar fascia first. Release the plantar fascia, and in such a tough case, I will cut exactly in the middle of the midfoot, and up to down, and then take out the wedge. But the wedge ends in the middle, the subtalar plane of the midfoot. Not the bottom, it ends in the middle, and it takes this wedge and bring it down with the plantar side. And you can correct it more.
So what about the hyperextension of the metatarsophalangeal joints?
That will correct on its own, no? Once everything is very supple, fortunately.
So he's got an equinus, for that you do a TL lengthening, and you do a dorsal wedge, and that will correct this also.
No, I think the TL should not be touched here at the.
Say if you do a dorsal wedge,
So where you are going to put that?
if you do a dorsal wedge, you get the midfoot straight.
What I would probably feel is the whole sort of all the cuneiforms, the navicular, the cuboid. That's where the osteotomy is going to be. And almost the entire bone is going to sort of move out. It is a complex case. Whatever said.
Do you call it as a dorsal skew foot? You call it as a dorsal skew foot?
So I'm not familiar with that terminology. The skew foot which I know is that you have a hindfoot valgus and a forefoot varus, or the other way, hindfoot varus and a forefoot valgus.
It's a uniplanar. Uniplanar deformity, so it cannot be called a skew, but it's all in the same sagittal plane.
How much the section of this wedge will be removed?
No, you don't calculate, you do it. Means you just need to get a plantigrade foot. Yeah, whatever. Why give it a name? Chapas never tackled a deformity like this. So you can give a name. Don't stick around with the name. You have to cut bone to make it plantigrade. Means that question is irrelevant.
Not like a V shape,
This is, at least in the pediatric spectrum, it does that. So even if you do chest, you will have to take the patient under anesthesia, keep readjusting your chest. But it will definitely help. Only thing is, I have never done it. So I would love to do such a serial sequential chest just for a uniplanar deformity. Maybe an Elizaro also could be done. More than 12 years of age, an Elizaro fixator is probably much better. I got explanation. This chat requires to be. But
So now he is going to cast the baby. The baby is comfortable, I guess. Sir,
so few things which I do from absolute the neonate onwards also. No? I am always studying this out of habit, and probably what I have learned. I have worked with Dr. Johari for 5 years. So we used to always cut the 6-inch plaster into two and never the 4-inch plaster. It becomes too difficult to handle. So they are always roughly 2.5 to 3 inches. Same goes for the soft roll. I am not at all happy cutting the 4-inch. Normally, in my own clinic practice, I also like to remove the diaper. The patient may pee on us, but it's a good idea to remove the diaper. Two things I have seen. Okay, one is in your busy practice, you will forget it's a boy and a girl if you keep the diaper on. 95% of your clubfoot patients will be boys. I have found that if you have a girl clubfoot patient, generally they don't respond as well as the boys. This is just my personal arbitrary opinion, I can't publish it. Okay. Now, another thing is when the child cries, you can simultaneously see if the child is having inguinoscrotal swelling. So when you are contemplating your tenotomy in the same cast, because most of them are not financially well to do, so they are very happy that you can settle their hernia hydrocele in the same as a tenotomy. Okay. So now there will be one assistant on this side who will be holding the limb from the side. So this person will never hold this. और इनका काम है यहाँ पे one thumb on the trochanter and he has to grip this. खाली अंगूठा पकड़ना. और अंगूठे ही पकड़ना. The soft roll padding behind the heel has to be thin. Rest of the padding can be as thick as you want. The padding goes all the way up to the top. The thigh padding I keep little thicker. Okay. Now the length of these plasters have generally come with feel and experience. So I have not really. This again the point I am mentioning is the water should be at a comfortable level. I have mentioned in my talk. No, I don't use gloves, but you could use gloves. We start off. So first 3 turns will be here. So initially your
it looks almost straight. And now one finger of mine, the index finger keeps moving on the top of the heel. And now I have moved the entire forefoot in alignment with your hind foot. Why? Because there is relative pronation in comparison to the hind foot, right? So we are going to do the first practice in supination.
this is a very important point I would feel in the foot class. Kids have pain only during this. So this is the only problem of removing the diaper. So इसका भी practical solution is to keep the soft wool.
There are a couple of reasons why they cry. I think the temperature of the plaster, at the same time our pressure. So in this particular patient, what happens is the moment you change the sort of the place where you are casting, the plaster setting time changes. So your sort of gut feeling keeps changing. Now how the patient has been acquired. Many of the parents don't like to give any of the bottle feeds to their newborn. We have used honey and you can also use the non-nutritional pacifier as per Dr. Anil Agarwal's paper. So now this plaster is just set. Just now this part is done and now we'll just do the top part. Again 3 rolls first on the top and now 3 rolls in our favorite figure of what? Figure of? 8.
So for PG student, for PGs.
Well, so first of all, the cast is in equinus, so below knee cast is not going to remain there. Then first I would feel most important is to hold and then stretch the tissues.
Tendo Achilles will be relaxed on that.
But I think the most important practical point is the cast is not to hold unless you have a high ground cast. So the cast has to be a high ground cast. Again now take a wide to step. So see this baby has become quiet with the feet and when we stop pressing the foot. Again the baby will cry when we go to the foot manipulation. So there is some component of pain which has been proven in literature. It's the experience.
So if you could demonstrate the components of the cast, what all components have been incorporated, the deformities which have been corrected.
So I didn't correct anything actually. It's the first cast. So I have just held the entire forefoot and
forefoot, you have gently,
not just the grid, all toes, and I have brought it in alignment with the hind foot.
And after
that also I don't correct anything. I show you the
supination. In supination.
We have a workshop and we have the model where you all can practice it, sir. So we'll proceed with the talk in a second and we will come back for the workshop.
So the same thing I'll be doing on the
other side. You guys can proceed there.
And then we can have the workshop on the models.
Now?
Not now, later.
And the top?
And then we will do the talk as well.
Where?
after you finish.
You take it.
one very important point is that before you go to the other side, you should wash your hands thoroughly. All the assistants also wash. Some plaster dust can remain inside and cause irritability of the newborn and dry of everybody involved.
So we are going to have our next talk on pylon fracture by Dr. Matthew Assel.
Wow. Wow. It's on. Okay. Close. Yeah, not too close. That's good. Okay, so they're still casting over there, but I have to start. So we're moving now from baby to adults, and pilon fractures is a challenging topic, as you may know, in the field of foot and ankle trauma. It's my pleasure to be here in Varanasi. Thank you very much for the invitation. Thank you for the great job at organizing the meeting. I'm from Switzerland, Geneva, and I'm the former president of the Swiss Foot and Ankle Society. As you may know, there are several approaches to address pilon fractures. So if we look at them, they are from medial to lateral, the MIPO incision, as you may know, which is here. Then we have the anteromedial approach, which is also called the AO approach, and the extensile approach, which is a new approach we have described, and then the anterolateral and extended lateral approaches. Then posteriorly, you have the posteromedial, central, and the posteromedial and posterolateral. So, you know, when you face a fracture, the main question is really where should you place your incisions, how you should approach the fracture, and all these fractures look a little bit alike. They involve the distal tibia, but actually they are very different in terms of biomechanics and, of course, surgical approach and hardware placement. So we have decided a few years ago to divide the pilon video clip about this that we did. Oh gosh.
The three-column concept of the distal tibia. According to Sarafian, the proximal limit of the distal tibial segment is 8 centimeters above the ankle joint. The cortex of the diaphysis changes direction, extending medially and laterally, forming an inverted. According to Sarafian, the proximal limit of the distal tibial segment extending medially and laterally, forming.
Okay, let's do it now.
The three-column concept of the distal tibia. According to Sarafian, the proximal limit of the distal tibial segment is 8 centimeters above the ankle joint. The cortex of the diaphysis changes direction, extending medially and laterally, forming an inverted cone, the metaphysis, here in blue. The metaphysis ends inferiorly at the large flare of the distal epiphysis known as the tibial pilon or plafond in red, which is purely articular. The articular surface is concave from posterior to anterior and lower at the back than the front, creating a mean opening angle of 12 degrees. In the sagittal plane, the articular surface of the plafond resembles a wingspan or chevron. The central concavity of the talar dome matches the plafond anatomy. Geometrically, the superior aspect of the metaphysis is a triangle corresponding to the three sides of the tibial diaphysis: medial, which is subcutaneous; lateral, which is covered by the anterior muscle compartment; and posterior. As one moves distally, the progressive flattening of the triangular shape of the tibial shaft results in the quadrilateral shape of the pilon. Transverse CT cuts demonstrate the progressive transition from the thick cortical bone of the proximal metaphysis to the very thin, less than a millimeter cortex in the lower metaphysis, whose content is primarily cancellous at this level. The lateral column is the prolongation of the anterolateral side of the tibial diaphysis and contains the notch for the fibula at the syndesmosis and the tubercle of Tillot-Chapuis. It forms the anterolateral articular surface of the plafond. The medial column is the continuation of the medial side of the triangular tibial diaphysis. This column ends in the large subcutaneous medial malleolus, which is in continuity with the horizontal articular surface. The posterior tibial tendon and deltoid ligament are intimately associated with the medial column. The posterior column is convex and formed by the flattened posterior triangle of the diaphysis, known as Volkmann's triangle or posterior malleolus. It descends further distally than the anterior margin of the articular surface. The articular morphology of the plafond forms a trapezoidal shape whose lateral border is longer than medial, and similarly its anterior border longer than posterior. The articular projection of the lateral, medial, and posterior columns can be observed here. Focusing on this column concept when evaluating pilon fractures will help to plan for internal fixation, specifically plate placement, and as well the best approach to secure this fixation.
Okay, so let's move on now. You are, I guess you are familiar with the AO classification of the pilon fractures. If not, 4 is the number for the tibia, 3 is always the distal part of a bone, and then you have B and C. So A is more for our extra-articular fractures, B, simple articular fractures. Simple meaning that part of the joint is still connected to the diaphysis. And then you have the C group, where none of the joint fragments are connected to the diaphysis. So here we have a typical involvement of the medial column. The lateral column looks intact here. So this is certainly a B, so it's a 43B. And then since it's the medial column which is affected, it's called a B2 or B3, the lateral column being intact. So how to approach this kind of fractures? Well, this is typically a fracture to be approached with the AO approach. For those who have been to Davos, I'm sure you have learned that. And the AO approach is an anterior approach, anterior-medial, that stays 3-4 millimeters medial to the anterior crest of the tibia. Then here you have the details of that approach. Remember that you cannot use the AO approach if you have a fracture of the lateral column. Okay, otherwise you're going to have to have too much retraction on the soft tissues laterally. You will not be able to put to place a plate and address the screwing of the plate. So the AO approach is really for those specific medial column fractures. You cannot access the Chapuis correctly. Then you have patients with the fracture of the lateral column, including the Chapuis. These are the 43B1 fractures, basically. And this is best approach with the so-called anterolateral approach. It's a very popular approach. Now this approach will not let you go medial. So don't try to go medial with an anterolateral approach, otherwise you're going to have soft tissues problems around your pilon fracture, mainly on the medial side. So consider that if you want to have to go medial, you cannot go medial from the anterolateral approach. So the anterolateral approach is a very simple approach. It's along 1 centimeter anterior to the anterior border of the fibula. And once you access the anterolateral compartment, basically all that compartment goes medially. See here, and you can really dissect the compartment with your finger, and basically along the anterosseous membrane here, you can really divide the tissues and put them medially. And then you have a very, very nice access to the chapu and that lateral column. Okay, I won't show you the video. So now what about those patients presenting a fracture of the medial and the lateral column, just like this one? So you have typically a 43C fracture, where none of the articular fragments are connected to the diaphysis. So here you have typically a fracture of the lateral column and of the medial column. So how to surgically address these fractures, where to pass through, and what should be your corridor. So here you see the two columns which are involved. So we have developed, like now 15 years ago, the extensile approach, which became the approach of choice in many big trauma centers. It's an approach that is an extension of the AO approach, extending more lateral than the anteromedial approach. And strangely, it has never been published or described before us, and now it's becoming a standard approach for fractures of both columns, medial and lateral. And I will show you a little video clip for those who want after my speech. So typically this is the issue here. So these patients, as you can see, required three approaches. Three columns that had to be fixed: the medial column, lateral column, and the fibular column. So we did it through an extensile approach. And you will see here the scar, okay, plus laterally an approach addressing the fibula. However, there are other ways to do that. There is another way. Same fracture, 43C, with impaction of the chapu here and fracture dislocation of the medial column here. And this was approached with the anterolateral approach, together with a MIPO approach. And so this is another way to do it. It's quite popular in some trauma center in the US. This combination of anterolateral and MIPO approach. So depending on if you are more familiar with the extensile approach, go for that one. Or if you're more familiar with the anterolateral approach, you can go for a MIPO plus anterolateral. The condition of the soft tissues, of course, will let you decide. Now, fractures of the posterior column, they are quite frequent, but it's rarely necessary to go posterior, actually, because most of these fractures can be addressed from anterior, and it's not recommended to go posterior unless you really have to. So this is typically a fracture where we had to go posterior because one of the fragments was incarcerated in the FHL. And so this is a condition where we had to build the fracture. Just as Dr. Ortner, we like to start posterior because by reconstructing the posterior column, this will serve as a template to reconstruct then later on the anteromedial and anterolateral columns. So we have described this approach, which is called the modified posterior medial approach. It's in our book, and if I mean, if you have questions about this approach, you can come to me a little later on. The most important message of this speech, of course, is the condition of the soft tissues. Remember, you have a high energy fracture, and you have on an X-ray, you know, an exciting fracture to be fixed, but actually the same amount of energy went through the soft tissues, and the soft tissues envelope are not on the X-ray. So you have to consider any soft tissue lesions, acute or soft tissue lesions that will just progress. And as we know, it's only around day 8 post-trauma that the necrosis will delineate in terms of surface and depth. So it's never wrong to go first with an X-fix, a temporary X-fix. And the goal of the temporary X-fix is really to stabilize the soft tissue more than reduce the fracture, okay? So you really want to stabilize the soft tissues with an X-fix. It has nothing to do with, you know, reducing the fracture, actually. So once you put the X-fix, you know, wait, scan, plan. So yeah, after the X-fix, have a CT scan done and plan your surgery and decide your surgical approaches. So basically, this is for, you know, for our residents. I had to come up with something that was quite simple. So, you know, for the AO43, B2 and 3 medial column, go for a medial approach. For the lateral column, go for an anterolateral approach. And then if you have both columns, medial and lateral, you have two options, extensor approach or anterolateral plus MIPO. And for those 43A fracture, which are a little different, you can go MIPO or intramedullary nailing. So I just want to show you those AO43A. So 43A again, 4 is tibia, 3 is distal, A is extraarticular, but close to the joint. And I would like to show you a case like this. I have a nice little video clip about the MIPO approach. And I used the same approach like just 2 days before we left to India, and I like that little video clip. So let me show you. I hope it works.
Minimally invasive plate osteosynthesis for distal tibia fractures with simple intra-articular extension. Here are the radiographs of a 19-year-old male who has a multifragmentary fracture of the distal tibia with a single split into the articular surface. There is a gap, but no step off at the articular line. Under C-arm control, an incision is made just above the articular surface, and a Kirschner wire is used to stabilize the simple articular split. A cannulated, partially threaded screw is then inserted to achieve interfragmentary compression. A is made just inferior to the tip of the medial malleolus. The soft tissue plane is developed above the periosteum. A pre-contoured anatomic distal tibia plate is then selected of appropriate length. There are combi holes for both and for compression. The plate length that is chosen is 3 times the length of the fracture. A drill sleeve is then locked into the plate to be used as a handle to pass the plate along the subcutaneous border of the tibia. Through the previously developed soft tissue plane, the plate is slid up the leg, again under C-arm control. Fixation of the plate. The first step is to check distally to see that the plate is. The plate is then secured distally with a temporary Kirschner wire. The second step is to check proximal to see that the The fourth and final step is to insert the locking screws. Distally, this is done under direct vision. For proximal insertion, we use an identical plate positioned on the skin, which accurately determines the point of the small incisions to achieve insertion of the locking screws. Following this, the wound is closed in standard fashion. Distally, the deep closure will achieve coverage of the plate and screws. With interrupted nylon sutures. Radiographs are seen on the left immediately post-operative and on the right at 1 year follow-up. Notice the anatomic reduction of the articular surface and good healing of this fracture.
Okay, so take-home messages. Always think in terms of columns. Dr. Ortner has shown a beautiful case of valgus failure after a simple fracture. Basically on the wrong side. And the plate has to work as a buttress in the periarticular area. The plate should not work periarticular fracture. So the plate should work as a buttress in the periarticular fracture. It should resist the forces that are basically reproducing the injury line. So if you have a valgus failure during the injury, the plate should be lateral to resist the valgus failure. So this is the first thing. So once you know on which side you want to put the plate, on which column, then you need to know which approach you have to choose, and you know there are several approaches you can choose from my speech. Also, you need to be flexible. The fracture pattern is sometimes complex, so we always spend 15 minutes before any difficult surgery to plan it accurately. We put it on a paper in the OR, so everyone knows the steps, and everyone is aware of how the procedure will move on. The fracture is one thing, but the soft tissue is another condition, and the soft tissue
So the next talk will be on calcaneus fracture. I will request Dr. to present his talk.
No discussion.
I think they're tired.
It will come. Next is calcaneus fractures. How to do it open. Calcaneus fractures have a
now there is a tendency to make it minimal invasive, but the problem with minimal invasive is if you older and so on, and it's really important to know how to do it. Yeah? In the literature, what has been done, developed in the last 20, 30 years in calcaneus fractures, Hans Zwipp from Dresden made a big work on calcaneus fractures, and he checking how much money does it give patient if it's a workers' compensation case. And in workers' compensation cases, the amount of money what the patient did get over time was reduced from 26 to 16% over time, because when it was done in a good fashion, a good reduction and a good fixation. That means it really makes sense, even in tough fractures, to make it. If the operation is done and reconstruction is done open, it's necessary and essential to make it anatomically. Yeah? And open reduction and reconstruction is in a three-dimensional visualization easier than in minimal invasive procedures. We have seen this case before, but that's the other side. That's minimal invasive case. Yeah? When you look at this case, that's minimal invasive, but it's crazy. It's no reduction. It's a no reduction and percutaneous fixation. That makes no sense. Or if you look at this case, yeah, that's the problem in minimal invasive. That's only fixation, but no reduction. And the problem is how to do it. And that's sometimes the final result after these procedures. And in such a case, it's really, really tough to treat it. Standardized is necessary. What is essential? CT scan is essential. If you have a calcaneus fracture, you must do a CT scan. Without a CT scan, it's unable to look what really did happen. And what is not known very much, very often the CT scan is done in a conventional manner. When the gantry is tilted about 15 degrees, yeah, and the beam is tilted 15 degrees, it's much easier to check the calcaneus fractures, like in this case. And then when you have the CT scan, the next step is you must learn to read the CT scan. Not only see that there's a fracture and a big comminution, you must look what are the essential parts of the joint. Yeah? That's the tuber fragment, the lateral fragment, the sustentacular fragment, and the CC fragment from the lateral view and from the medial view. If you look at this, yeah, here is the talus. And what's very important is to look at this sustentacular fragment. In about 95% of the cases, the sustentacular fragment is in place. And only in 5% of the cases it is out, it's dislocated. But that means if it's dislocated, it's a totally different fracture type. And that's the fractures, the rare cases, where sometimes must come from medial to reconstruct the sustentacular fragment to its place. That's the lateral joint fragment, that's a tuber fragment, and then here's the CC fragment. Yeah? But always you must check for the different fragments and active finding of the different parts of the fracture, because then you can orientate how to do it. That's the Sanders classification. But if you look at the CT scan, look for additional fractures in the foot. Not rare. In about 18% of the cases, you have additional fractures out of the calcaneus fractures. Yeah? If you look at this case, here you have a small fracture of the posterior tubercle, posterior tali, or in this case, that's a peroneal tendon dislocations. The peroneal tendon dislocations in clavicular bone. Yeah? It's really not only look on the calcaneus, look on the other bones of the foot. CT analysis, that's really essential what to do. And then, how do we do the reconstruction? How's the target? The target is the anatomic reconstruction of the calcaneus. The calcaneus is shortened, the joint is pressed down, and it's made broader. That means you must reconstruct the length, the width, and the position of the joint. And very often when I see results from percutaneous done reconstructions, they try to bring the joint up. But you cannot bring up the joint when you have not restored the length and the width. We in our hand for percutaneous reconstruction take an external fixator and a distractor to distract, brings the length in the percutaneous method to bring the length and the correction of the varus. And then very often the joint line goes up. And that's really important, not only in the minimal invasive surgery, it's the same in the open surgery. You must restore the length, the width, and the step-free joint. Not only bring the joint line back, you must correct the whole calcaneus. You see it here. This joint is shortened and it's broader. Yeah? Interlar fractures are often extended to the CC joint, like you see it here. Don't forget the CC joint. And you see it here, that it is. Yeah? In most of the cases, the sustentacular fragment is intact and not dislocated, and that's the first anchor of our reconstruction. We can really take the sustentaculum as a stable part of the former calcaneus. Like in this case, there's a comminution here, but the sustentacular fragment is still in place. And that's a stable anchor for the reconstruction. And what is really essential is the soft tissue handling. The rate of infections after open reduction is high, but most of the cases are really the problem of the incision and the soft tissue handling. And you must mobilize the soft tissue in one layer. And when you look at this, that's a typical complication of an open reconstruction. But the problem is the incision is on the really total wrong place. The incision must be much more plantarly. At this edge, exact on this point, there is an anastomosis of the arteries of the hindfoot. And there exists a paper when by the injury, this anastomosis is destroyed, the rate of infections and necrosis increases a lot. If this anastomosis is okay, you have a healing problem. But that means you must really protect this anastomosis. And that means you must go really extremely and the edge between the of the skin of the sole to the lateral wall. Yeah? That's really totally wrong. Yeah? Here you can see, here is this anastomosis. Yeah? And when you look here, and you look at this, and look what is here, yeah? It's the same. And when you go with your incision exactly here, you cut this anastomosis. And what is the reason, the result? It's a skin necrosis. And then you get really the typical problem on this, and that's the typical edge. And that's so important to look what is really the height of the incision. That's from the AO book, yeah? You see here, right? That's really plantarly. extremely plantally here. That's the right incision. And if you go up here, look for the sural nerve, and the same is here. At the end, there's a big injury, a big risk for the sural nerve. Yeah? And then the second is, you must do it in one layer. You must really over the bone go with your scalpel direct to the bone. No preparation, really direct to the bone, and then really make the preparation superiostally, that you have really one flap. And you can make one flap, and with this flap on the bone go up to the sinus tarsi. And as soon as in the sinus tarsi, you can take a small Hohmann hook and bring it in, and then you can retract it. Yeah? But very important is to take gentle instruments. We take only hand instruments for calcaneus fractures. No big Hohmann hooks, no big instruments, only small instruments, because the risk to get a damage by a big instrument is high. Yeah? Again, you see, that's sural nerve. You must take care, yeah, and take care for the additional pathology. Yeah, here you see a case where a peroneal tendon dislocation is. Yeah, here's a case of the posterior tali. You must mention these additional injuries before the operation, because it can be cured during the operation. It's simple. You must see it. Yeah, and then open the fracture for the posterior facet, and that's what you see here. You see here this flap. Yeah. And then what we have heard before, calcaneus fracture, what is? It's shortened and it's broader. Yeah? It's recommended to bring it back with a Steinmann pin. And for me, especially if an elder patient and an elder bone, yeah, with Steinmann pin, it doesn't hold very good. But what is possible is to take and to go in with a laminar spreader into the fracture. And if you go with a laminar spreader, there's a mid-sized laminar spreader into the fracture, then you can really distract the fracture. And that is really very important, to disimpact the fracture. Because when you disimpact the fracture, you can move your fragments. And when you take this laminar spreader, you have one piece of bone. If you take a Steinmann pin and start to manipulate, you have many pieces of bone. It makes it much more difficult. You see it here, open it, and then you can really see, take out well-positioned cancellous bone, and then you can start with reconstruction. Yeah, that means you open your fracture with a really thick skin flap in one layer, and then go direct to the fracture, and then disimpact the fracture, restore the length with a laminar spreader, and make it mobile. And when it's mobile, then you can reconstruct it. And then the next step is, you see it here again, small Hohmann hook, small instrument, and a big laminar spreader. So you see it here. He's really, and he goes into this. That's a really trick that's very effective for reconstructions. The next step is to fix the posterior facet. And of course you can take your posterior facet and bring it up to the talus. That means the posterior facet fits to the talus, because most of the talus is not fractured. That means you can take the talus as a tapper, but what is very often is that the fragments are not only pushed down, the same is they go a little bit to anterior or posterior. That means you must really disimpact it, bring it up to the talar, and then look how is the fragment in the anterior posterior position. And then you must bring it to anterior or posterior how it was before. That's the toughest thing. Yeah? And when you have repositioned this fragment, the next what you can do is to fix it with a K-wire. Yeah? And you see, you can take the K-wire and drill the K-wire to medial. Because if the K-wire looks out here to lateral, it's sometimes very difficult to make the other reposition and reconstruction, because the K-wire is on a place where it's not useful. That means you drill the K-wire to medial and pull it out as that it's vanishing on the surface of the posterior facet. Yeah? And then small fragments as well as central fragments can be fixed with thin K-wires from lateral, drilled out to medial, and from medial to lateral can be over-drilled with a cannulated screw. That's a really good trick. If you have your fragments, take your K-wire, trick it to medial, then make your reconstruction, and then you come with your screws from medial over this over this K-wire, and then you can make your plate on the lateral side. Yeah. The last step then is reconstruction of the CC joint. Don't forget the CC joint. Yeah, but because very often the patient have a good reconstruction of the subtalar joint, but the CC joint is not reconstructed because it's damaged too, but it makes it simple. Yeah. Again, make a transfixation with a corrected position. Reconstructed it step by step. Yeah, that means length, width, push up the posterior fragment, adjust it, and then fix it with K-wire. Then the K-wires are over-drilled with cannulated screws. That means the size of your K-wire must be the size of the cannulated screw. One of the baddest things, if you have a thicker K-wire and you have not a screw which fits over the K-wires, that's crazy. That's all happens. Yeah? And then, what I really did like when I had an injury to the CC joint, I made a longer plate and made a transfixation of the CC joint with this long plate here. Yeah? Because with this, you can hold it a little bit on distraction. You can really make a reconstruction of the CC joint, and you hold it, and these two screws here are then removed under fluoroscopic control after 6 to 8 weeks. And after 6 to 8 weeks, when this starts really with weight bearing, then these screws are removed, then it's healed here, and you get some motion. The plate is laid in. Sometimes this plate breaks here, doesn't matter, and it breaks because the screws have been taken out. But at the end, you see the adjustment, the axis is okay, the width is okay, and the height is okay. Yeah, yeah. Another trick, what is sometimes, if you have always a question, should we make a bone graft or not? We almost never use the bone graft in the last years, because heel bone is a healing bone. The US and the Americans say it heals very fast, and if you have a defect here centrally, almost always the plantar part of the calcaneus is intact. And what you can do is to make a leg screw percutaneous from plantar to dorsal. And with this leg screw, you push up the plantar plate of the calcaneus, and with this you close the defect. You don't need a bone graft, only one leg screw with a washer, and that pushes it up, and that brings it up and closes the defect here. Yeah? Again, you see it here. That's a comminuted fracture, but you see here, that's the plantar plate. That's okay, and with this screw, it's fixed up and it's held up, and the gap and the hole is closed. Again, you see such a case. Yeah? Again, you see it here, and you see it here. Yeah? If it's reconstructed good and it's stable enough, you see the defect here, but the shape of the mid facet is perfect, and after half a year, it's closed, because heel bone is a heel bone. It heals very fast and very effective. Yeah? And that's the function of this patient after 8 weeks. In conclusion, I think open reduction is still a good option, and it's important to learn open reduction of calcaneus fractures if you want to start with minimal invasive, because in minimal invasive you must understand how the fracture is, and you cannot learn how the fracture is when you have never seen it. Yeah? And of course you have a CT scan, but the CT scan you can only say 15 fragments, yes, but what is really whom to who, it's much easier to learn it open and then to start minimal invasive. CT scan is essential. Soft tissue handling is for me one of the most important things, and we have almost no wound healing complications really if you do it. And it's for me one problem in my department was we had about 30 calcaneus fractures per year, and the stuff was big. That means when everyone makes calcaneus fractures, he makes 1 or 2 a year, and 1 or 2 a year is not enough. You cannot learn it. It's like Acetabulum fractures makes not everyone one a year. One makes it, and the other, or pylon fracture, is was for specialists. It's the same as with calcaneus fractures. If a calcaneus fracture, you must be specialized, you must learn it, and then you can do it. Non-layer preparation is important, hand instrument is important, systematic approach is more important, stable fixation, and then what is always forgotten is the postoperative management. One is wound healing, and the other is motion. Motion. Postoperative treatment is essential, and I do a lot of insurance cases, and what I see is many of the patients get the cast, and they cast for 6 to 8 weeks. How should such a complex fracture be mobile when you cast it for 6 to 8 weeks? It's stiff. That means, and the other side, no weight bearing for 6 weeks. That's normal. But motion exercises, but not say, suppose patient, you must move your foot, you must move your subtalar joint. When you say to your patient, move your subtalar joint, he says yes. All say yes. And in Austria it's the same, says yes, but they don't understand what we mean. But they didn't, till to this moment, they didn't know that a subtalar joint exists. They didn't know what is a subtalar joint, but they have understand what to move. You must show it, and show it on the other side of the foot. On the healthy foot, you must show, that's the subtalar joint. And that you must move, not up and down. Up and down is easy. Medial laterals, that's important, Best show it on the contralateral side, physiotherapy as soon as possible. But what I do, I send him to physiotherapy, and 1 week after the beginning of the physiotherapy, I say, come back to me again, and then show me what they do with you. And then what they do, sometimes they make curing the scars, they make it against the swelling, anything, but no one moves the subtalar joint. They move the ankle joint a little bit, but not the subtalar joint. That's really, you must not only learn it to the patient, you must check what the physiotherapy is doing. And when you call the physiotherapist that the subtalar joint is not the ankle joint, you must do it different. Then you have a good physiotherapist. You will be surprised what motion exercises are done by the physiotherapy at the beginning. And then when you don't do it, they become stiff, and that is the problem. Don't ask, only ask, let me show what they're doing with you. And that's what I show at the end. When you do it in this way, then you will see this will happen. I hope it happens. It does not happen. Oh, sorry. Ah yes, you see, that's, and now he's operated, and now he's running fast. Yes. Thank you. It's a good operation.
Thank you, sir. Doctor, I'm Harish Bakkar from Lucknow. I wanted to know more clarity about the cuboid and calcaneus. In which case you think you want to extend the plate, one thing. And second thing, that your physiotherapists are as good as ours. Because they also do not do what is much required. Yes. My question was regarding calcaneus cuboid plate that you extended. In which cases do you do it? And
the CC joint, when you make the reconstruction of the calcaneus and you make the length, sometimes you have the CC joint has a slight tendency to go up a little bit. The prosthesis under calcaneus sometimes goes a little bit up, and when the fracture goes through the joint, then I look, that says really no gap, perhaps small screws, but then I make a longer plate which goes from the tuber to the cuboid. And that means with this longer plate I transfix the CC joint. And with this transfixation I can make the reposition of the CC joint too. That's anterior part of the calcaneus is, when it's fractured, I make the transfixation to the cuboid. That's
Sir, how often do you encounter hardware problems in post-operative period, and how
in general, really hardware problems with this thinner plates, almost never. The problem is very often you see wound healing problems. That's a problem. If you have such that they showed with the skin necrosis under the skin, there of course is the plate, and that means you have an infection of the plate. That's a hardware problem. Interesting is when you have the screws, sometimes the screws are too long. You look on the postoperative CT scan and the screw is 6 to 8 millimeters too long, and on the medial side it looks surprising. Most of the patients don't feel it. They don't on this. The medial side of the foot tolerates a lot of overlengths of the screws. That can be done, but it's really in general we remove the plate almost never. Yeah. The only when you have you need an additional procedure. Yeah. Then sometimes when you get an arthrosis, instead of a fusion, then I say to the patient, first I want to remove the plate, and half a year later I make the fusion. Because the problem is when you make this L-shaped incision, and from this L-shaped incision to make a subtalar fusion, it's really tough. And after a calcaneus fracture, to make an arthroscopic fusion is possible, but if they are really stiff, we have seen it on the video, the way to make a subtalar fusion arthroscopically, you need a rasp. Most take a 6 millimeter rasp, go into synostasy and twist it, and with this twisting they open the joint. But when the joint is totally stiff, it's almost impossible to come there. That means I make it in 2 steps.
Thank you, sir. And so you can have your seat. Now, Dr. Pradeep Manot, he doesn't need any introduction. He's a specialist at foot and ankle from Mumbai, and sir is going to talk about the Lisp frank fracture. Handing over you to sir.
Thank you very much. Good evening. I would like to thank Dr. Swaroop and Dr. Amit and the organizing chairman for inviting me to this lovely city. This is my first visit, and I hope I can do justice to the talks which I have been assigned. So without wasting much time, we'll talk about Lisp frank. Now, it's quite a vast topic, so I would just cover initially only the acute injuries of Lisp frank, and we take it initially case by case, and then a little bit of discussion as well on that same thing. I would try to keep between 10 and 15 minutes, not more than that. So this is how I would break it up. So let's start with a case. 30-year-old female, minor fall from stairs, diagnosed with midfoot sprain. Now I'm sure you would have seen in your practice, this is a very common scenario. Okay. Now since it is a topic of Lisp frank, now everybody would see this X-ray and say no, there is a Lisp frank. But that's not what happens in your day-to-day practice. So this patient was then said midfoot sprain, sent it back home, seen by another physician, diagnosed as fracture base foot metatarsal, because a second physician thought that something is happening here. So diagnosed with sprain, treated in the cast for 6 weeks, and lo and behold, she came back 3 months later, now in almost 6 to 8 weeks in plaster, and thought that foot is not right. She's already 3 months in cast. And she came, and she was then finally referred by another third doctor to me that this lady is not happy, and look at that. And you can see from the front and the back, there is a bump here. You see that's your normal side, that's a bump here. Look from the back, that's a normal thing, and she is falling off and going in valgus. 3 months post injury X-ray. Look at that now. Now that's a weight bearing X-ray. Okay, that's the most important thing. Get weight bearing X-rays if you are suspecting a foot injury. And to be honest, if you want to take 1 point from this talk, there is foot sprain. Take that. Okay, if you start thinking that way, and you think that every time there's patient come with a midfoot injury, it's Lisp frank unless proven otherwise. So literally you have to disprove that there is no Lis franc. That means you have to investigate to an extent where it says, okay, there is no Lis franc, now I can treat it as a conservative treatment. If you go that way, you would never miss a Lis franc. So why should we not miss a Lis franc? Because it is a very debilitating condition. It has functional loss, residual ligamentous instability, deformity. We already saw patient having a paralysis in 3 months. Anatomy, I won't bore you much. You can divide into 3 columns or 4 columns. I like to divide into 4 columns. The first column is your medial column. It is not a fix. It has a few degrees of movement and you need that. Okay, so that's 6 degrees of mobility. Second and third are fixed. Don't need have much mobility. You can diffuse them if you wish to. And the fourth and the fifth are the mobile segment, which you should not fix it. Lis franc ligament, it's a very, very important ligament. It's a large ligament, extends from the base of the plantar aspect of the medial cuneiform to the base of the second metatarsal. Again, it can be divided into 3 parts. Don't need to know it. The most important is the interosseous and the plantar aspect. You're not going to go around and fetch it. The key thing is, but if you want to go and see on an MRI scan, and I would suggest, again, foot MRIs is very difficult. Okay, you need really good sections. The MRI centers really should have a foot module to get a foot MRI, which I don't know if you have it or not. Even in Mumbai, sometimes we struggle. And so you need to have a nice section, and there you can see a Lis franc. So just try to see if you can see it, because once you see normal, then you know what is not normal. Classification: sprains graded by 3 grades. Grade 1, it's a mild pain, minimal swelling, no instability. You cannot see any dissociation. Increasing pain, increasing swelling, but again no instability, there is no diastasis. That means the differentiation or the displacement is less than 2 millimeter. Point comes is, this is what interesting point. Grade 3, complete ligament rupture and there is more than 2 millimeter diastasis. Physical exam, high index of suspicion. As I said, midfoot swelling, tenderness, always suspect a Lis franc. You can have polytrauma patients, assess the soft tissues. Key is look at that midfoot swelling. Again, Lis franc unless proven otherwise. Key thing is, if you have patients like this, always look on the plantar side. Again, we are not used to, patients come, lie down, you just go on the dorsum, pain either hai, examine and put a slab or something. No, turn around, look on the plantar side. If you have an ecchymosis, you can appreciate that telltale sign of Lis franc. Okay, telltale sign. Again, as I said, you have to disprove it is not Lis franc, disprove it is not displacement, disprove that you cannot operate. Okay, ecchymosis, gentle stressing, and then pain is not, so you hold here and ballot it, and patient complains of pain in the midfoot. Okay, that's what will again prove it's Lis franc. X-rays AP oblique lateral, both sides. Okay, now if the patient comes acutely, you may not be able to get a weight bearing. Wait for a week. Let the swelling settle down, painkillers, analgesics, and then you can get a weight bearing comparative X-rays. Knot sign is another important sign which shows that the cuneiform is slightly rotated. Again, a telltale sign of intercuneiform instability. That's again very, very important sign. May or may not be present with C1-M2 whitening. Again, lateral views. Again, I see time and again patients, we do not get lateral views. Mindset change has to be done. AP, oblique and lateral views are very, very important, because sometimes a subtle dorsal subluxation, you can pick it up on lateral view. And again, the X-ray signs are not meant for this. This, any job log, any post or Orthopedic resident will tell you this is less frank. We are not trying to say this is less frank or not. We are trying to pick up the subtle less frank which can have a life-changing events. Now, I have not gone through the lines, a few things, just for the sake of time. I'm sure people are aware, but for residents and staff, medial border of the second metatarsal, metatarsal should be along the medial border of the medial cuneiform, middle cuneiform. Lateral border again should be through the lateral border. Corner is a dime sign or the coin sign. So these are few signs which you really need to look at it. And that has to be a man. There cannot be a 1 millimeter step. That's not acceptable. Okay. Now, as I said, if you think there is a less frank but you don't know how to do it, just as I said, wait for a week, let the pain and swelling settle down, come back and do stress views. Either you can take them to theatre and do a stress view. In Mumbai, a patient coming to theatre is too expensive than actually getting a CT and an MRI. Okay, so I just wait, get weight bearing x-rays. As soon as you do a weight bearing x-rays, again here you see, this is another sign on x-ray. You can see a small flake of bone between the first, so between the base of the first and the second. Again a telltale sign that this is less frank. As soon as you do a weight bearing, you can see the displacement. You don't need anything else. You can make sure, you can prepare the patient for surgery. You can get, as I said, stress views or fluoroscopy, get CT scan, you can check if there is a displacement, you can get an MRI scan if it is a pure ligamentous injuries, and ask your radiograph or radiologist, who should be a MSK radiologist, to tell you if it's a less frank ligament injury or not. If suspicious, keep looking, keep looking, keep looking. Okay? Management, conservative versus surgical. Is there a role for a displaced less frank injury conservatively? Answer is no. Okay? Is there a role of conservative or operative management of displaced less frank with KYS? Answer is no. Okay? You cannot treat less frank closed injuries. Again, there are some exception. Closed less frank displaced with KYS. Okay, that's good. Everybody is on top of that. Check for stability. As I said, stability, instability is more than 2 millimeter displacement. For me, if I see a displacement on my normal eyes on a normal X-ray, it is more than 2 millimeters. So it has to be operated. Full stop. Story ends. Except you have a very strong reason not to operate. Again, poor skin tissue, poor vascularity, open fractures, normal standard stuff, which everybody is aware of it. If you want to do a non-operative, put them in a cast for 6 weeks, non-weight bearing, and then gradually after 4 to 6 weeks, you can mobilize them in a cast and a walker boot. Okay? So that's what a conservative treatment for a really ligamentous, non-displaced type 1 and 2 would be. For type 3 ligamentous and all displaced less frank, operative management is the best time. You don't need to rush in. You can wait for the swelling to settle down and then get your team right, get your implants right, and operate in a proper environment. Now, before you operate, always you may think that yes, it's a pure less frank second TMT displaced, you want to fix a second TMT. Before you put your knife to the skin, always again screen the foot, because you may find that initially you thought it was only the second, but hang on, the first also looks unstable, the third also looks unstable. Now you need to change your planning and change the operative approach, because if you have 3 less frank joints unstable, then you would need a 2 incision. Okay, so if you have first, second, third, then you would want a medial incision for your first, and between the second and third for your second, third. Okay, you cannot approach 3 first, second TMT joints through single. Usually I'm saying you would want to do a dual approach. So you do not want to end up with a skin incision on the base of the second, and then suddenly you find the first also unstable, third also unstable, fourth, fifth, then you cannot do it. So always screen. Once you screen it, usually the Lisfranc, the dissection is already made, your neurovascular is already out, you clean up the hematoma, you will straight away be into that Lisfranc joint. This is what it shows. It's completely unstable. Identify the instability, clean up, remove the debris, and remove and reduce the second TMT with a clamp. You don't need any special clamp. A big towel clamp which you normally would use is suffice, or a medium one. You don't need a big patella one. You don't need it. Trust me, you don't need it. Once you have reduced it, check on X-ray. Your base of the second metatarsal should be in line with the medial part of the middle cuneiform. Both X-rays, so CM images, and you can see here visually it is perfectly reduced. There is no acceptability of even 1 millimeter. Both mediolateral and dorsoplantar. That is very, very important. Once you have done that, you pass a wire. Now this is again another important thing. Lisfranc screw. How do you pass a, how do you pass a Lisfranc screw? You pass a wire from the base of the second into the middle, onto the medial cuneiform. Now the key thing is you need to really drop your hand, and this is one place where you need a drill guide. Okay, because this is usually a 4 mm screw, or a 3.5 fully threaded, or a 4 mm screw. The wires for the 4 mm screw, if you're using an Indian one, is too thin. Okay, I've used most of the companies. The wires are very thin. So if you do not use a drill guide, you will faff around it, your wires will get bent, and you will not be able to get the trajectory. So get a drill guide, really a hand almost parallel to the bed, to the, your OT table, and pass your wire. Okay, this is an extra articular wire. Why do I say it? Because it goes from the base here, so it's not in the joint. So this is a second joint, this is a fourth joint. So it's an extra articular wire. That's how damage to the articular surface is minimal. It's hardly there, and it needs to be parallel to the OT table, and that's why you need a guide, drill guide. Only exception is if you're using a synthis. Synthis has a thicker wire, you can get away with it, but I would advise you to do that. So that's how you pass it. That's the trajectory, and you see here, this is a fully threaded screw. It is not a compression screw, it is a fully it's not compressing. Okay, very, very important. And fully threaded, and ideally means I still use cannulated. Yes, ideal would be to use a fully threaded solid screw. That's a very stable screw. Screws are positional, not lag. Once you have done that, check for intercuneiform instability. I would say 60 to 70% of the times intercuneiform instability is there. You need to fix it. So pass a screw from the medial to the middle cuneiform. Okay, so that's done there, and then yes, you can get away with it, but just holding your whole Lisfranc with one screw, you need to cast them and do that. Put a plate. Okay, these are 2.7 mm plates. Now I think most of the Indian companies are making it. Put a plate. It's a neutralization plate. Hunky dory finish. You don't need to immobilize them. You can immobilize them for 2 weeks max. There is medial instability. You need to fix them. Fourth and fifth, if it is instable, you need to K-wire it. Okay, that's what it is. You do not do that. Now, this is a nice paper from can't see it, whichever recent papers, and they looked at 3 different types of fixation: transarticular screws, dorsal bridge plating, and a combination. 108 patients, and what they found was bridge plating is the best because it does not violate articular surface. Okay, and the key thing is the quality of the functional outcome really depends on the quality of reduction. So get anatomical reduction. So patients with dorsal bridge plating have better functional and radiological outcomes than those treated with the transarticular screws. Again, this is another combination: incision between the first and second, medial side, and the middle one. Okay, again you have a different types. You can have 2 plates, you can have 1 plate, screws, everything. Now pure ligamentous, open reduction internal fixation, primary arthrodesis, something else. There's a new thing which you can do is pure ligamentous, you can use flexible fixation. So a mini tightrope can also be used. So there's another patient, this frank was unstable, already. That's your mini tightrope, comes in a whole set, and there it is, now completely stable. Okay, you don't need to do much, and they can be mobilized straight away. Weight bearing, of course, later. 34-year-old road traffic accident, swelling, some blisters there, severe injury. Look at the base of the first. Okay, so here you need for a medial and then go center and then lateral. So medial incision 1, medially length was gained. Once the medial side was done, then the second was approach, reduced, list frank screw, and then a plate between second and third and fourth and fifth K-wires. Finally done, follow up, done very well. Another case, road traffic accident treated in cast, mild list frank, again you can see here. So it is, we got a weight bearing CT scan done. This was a time where for 6 months it was available in Mumbai. There you can see a C1M2 widening. There may be see, this is what I was talking about. The wire really is horizontal. Okay, so that's what it was, and that was finally stabilized and done very well. Okay, just sake of time, I'll just move on. So weight bearing CT scan. So this is very, see here, this is a screening which I always do. You can see the M1, the first TMT joint is unstable. There you can see the instability, and that's been fixed to completely stable. So post-op, splint for 10 to 14 days, non-weight bearing cast, non-weight bearing for 4 to 6 weeks. If I have a now good solid fixation, I don't ever put them in a cast. I mobilize them from 2 weeks onwards. Weight bearing I started later, around 2 months time, and I give them an insole, customized insole for almost 6 months. If I expand, especially the first TMT joint, I would remove the hardware between 4 and 6 months. Rest I can leave them. Always warn the patient, especially the list frank screw. I tell them that you may break it, don't worry about it. So good or excellent results have been accomplished in 50 to 95% of patients with anatomic alignment, compared to only 1/3 of the patients if you do not get a good anatomic reductions. So in conclusion, these are commonly missed injuries. Don't diagnose as midfoot sprain, investigate till you rule out list frank. Key is anatomic reduction and good fixation with plates and screws. Again, list frank himself in the 18th century has said, surgery is bright when operating, but it is still brighter when there is no blood and mutilation and yet leads to patient recovery. Nothing better than in the list frank joint itself. Thank you very much.
Any questions for sir?
Rather than putting a plate or a screw and holding it there, can't we keep it fused?
Yeah, so the second and third list frank, pure ligamentous. There is Coetzee's paper from 2014, I think, who said that for pure ligamentous you can do fusion as well. But I think now with the advent of the whole mini tightropes and flexible fixation, I think they've got equally good results. And in second and third you can fuse it, but what about the first? First TMT fusion should be avoided because it still has that 6 degrees of movement, and trust me, most of my patients where I've done a 4 plates, as soon as I remove the plate, they said foot loose ho gaya, not flexible.
What about in the older cases? Suppose 8-month-old list frank with painful foot came. What to do?
Yeah, so again I have a paper which we got it printed, it's in print and got accepted in AOFAS as well, on a series of almost 15 cases of missed list frank. So the key is individualized treatment for these patients. If it is a mild list frank, minimal subluxation, I would open it up, check for the articular surface, how good it is.
you. And that's when we started to think that, in the Lisfranc injury, it's sometimes more than just, the Lisfranc joint injury per se. Really supports the foot and doesn't let the Lisfranc shift back into abduction. That's our observation.
No, so I completely agree, and that's why I have a very low threshold for fixing the first TMT. People just hung out about the second TMT and they just go and fix the second and third. I think the first is more an important culprit, because if the first goes, your second cannot hold on. It's too big a joint to be left well alone. And that's why if you see most of mine, I would fix it, I would not fuse it. Second, third, I am not too bothered. They are anyway immobile, you can fuse it, that's fine. But holding that first is very, very important. And even that lady I showed who had in 3 months, she going in abduction, I did fix the first as well in that. Thank you.
Thank you, sir, for your wonderful talk. Now we are going from trauma session to tendon disorder. Community session will be done after that. So I will request Dr. Liska at least calcaneal osteotomy versus debridement. And
No, das, aha, danke. Nee, das funktioniert, das ist gut. Nee, I just need...
And I congratulate Dr. Liska because he has elected Swiss Foot and Ankle Society President for this year.
Yeah, I need that first. I'm sorry? No, it's going to be easy.
You're all set?
Let's see.
President?
Yeah, thank you. Thank you very much for the invitation. I'm very honored to be here, the only female presenter today. So I am going to talk about the operative treatment of insertional Achilles tendinitis before it ruptures, as we have heard before. So the question that we foot and ankle surgeons always face is, should we try to do a calcaneal osteotomy, or should we go in for a debridement and reinsertion, as we heard before? This is a question that is a real one, so I'm going to give you an answer on that one. So the Haglund is definitely not just an exostosis. It's definitely just recently a paper by a French foot and ankle surgeon described it as a triad, actually. So we have the bony exostosis, the Haglund, the classical one, but we also have this calcification that we've already heard about that sits on the posterior. What is going to lead to a Haglund syndrome? Why some people have that? High-pitched angle. From a very nice paper from Latournay as well, that people with excessively long calcaneus tend to have that problem more. Seems kind of logical. So let's talk about that question. Should we do an osteotomy or debridement? I don't know who is all familiar with those osteotomies that are being used. So we find various techniques. Closing wedge calcaneal osteotomy. The very first to have published that was a New York surgeon who and he Didactic osteotomy. He made actually his first publication on a small series of 4 patients where he would treat them with a lateral incision. It was a longitudinal lateral incision, not a midline one, and he would remove the hagland and the bursa and perform this typical wedge-type osteotomy. He will then fix it with osteosutures, so no metal at that time. And he already described his post-op protocol. It was actually 5 weeks of casts with no weight bearing. So we see that we still have about the same guidelines so many. This osteotomy was truly popularized by another American group from the Mayo Clinic. It was Keck and Kelly, basically, so this is why it's called the Kelly-Keck osteotomy. They proposed a series where they actually did separate incisions, some medial, some lateral, without really telling us when they did what. And they would do the resection of the closing wedge a bit more proximal from the tenon, as we can see in the next slide. I will show you that. They also resected the hagland and shown in their mini series of 4 that they had only 1 good, 2 fair, and 1 poor results. I mean, it's pretty incredible that that osteotomy still found a way to be popular with that results, right? We would have a problem with going on with that today. So this is why, because the concept works, actually. The anatomic effect of this closing wedge osteotomy is the one that it will tilt the heel away from the Achilles tendon, so tilt away the hagland excess from the Achilles tendon. But it also will elevate the insertion of the Achilles tendon, so functionally lengthen the posterior chain. Here is our technique. So what we do, we have the patient in a lateral position, and then we do some kind of modified extensile approach to calcaneus, just as in trauma, but a bit smaller, a bit rounder, which gives us a very nice approach to lateral calcaneus. And then we would go and mark the wedge that we'd like to remove with 3 K wires. The other 2 K wires are simply there to remove the flap, the skin flap, so that we don't need no assistant to hold it. And once we have those K wires, we control it under the scopy to see what we need to put away. What's very important is plantar cognitive curve. The edge will be flat, will actually be an elevation of the tuberosity. From wedge, that can be sometimes in reality because it's actually the periodial side, so it's sometimes it's a long but eventually we'll get there. We'll remove the wedge. Simple dorsiflexion of the ankle, we can actually close the wedge. You can fix it with screws, or we prefer staples, so we put 2 staples to fix it there. And then, of course, some meticulous wound closure, since this is a really delicate region, as we all know. So that's one of these tools. Yes, sir. Oh, thank you for helping me. Has it been not displaying for a long time? Okay, thanks. So, did you see that one? No? Okay. So this is the closure of the fixation of the wedge closure with 2 staples, and then the closure with meticulous single knots. That was one of the 2 methods I would like to show you. Then the other one I'm going to debate is the debridement and reinsertion. So the first question we solve is, which approach will we use for that? As you may be aware, there are several approaches that have been published, like vertical medial, lateral, even double incisions, and J-shaped, or the endoscopically. I mean, there's no consensus, but there's a personal preference. Mine would be the one of the best exposure to the gland, the diseased tissue, and as we already heard, it was a possibility of FHL transfer should you think that it possibility. this approach has been widely popularized by Nunley very early on already. As soon as he reassured us that the tendon can actually be detached by 50% without so this is what it looks like. You have that central direct approach to the bone through the Achilles tendon basically. And then you have a wide exposure to that Haglund zone that you can debride really, but you can also debride the central parts of the tendon that are usually thick. They are usually altered. They have the calcification within, but also the non-calcified part will be a bit, they don't have no healing potential anymore. So we remove them. And then we fix the tendon back to the bone, usually with one anchor, depending on the amount that we had to release it, basically. So now, when would I rather tend for the debridement and when for the Zadek? The definite advantages of the debridement will be that we can address the tendon as well. If the tendon has no healing potential anymore, it needs to be addressed, in my opinion. But it does definitely need a much longer recovery time. It's actually proven that it's about 6 to 12 months because before we recover from that. So in an athlete, for example, that's a very long time sometimes. And it does need to come with a lengthening of the posterior chain, for example, with a Strayer procedure or whatever. It's something that we'd rather keep for normal arched feet, while the Zadek would rather be for the cavus feet. In a Zadek procedure, you don't need to touch smooth coverage of the insertional bone around the processus posterius of the heel. So that's an advantage in my eyes. Those people generally recover much faster. Within 4 to 6 months, they're back to sports, actually. And it does not need an additional procedure like a Strayer or anything. So this is our personal decision tree in treating the Haglund syndrome. First, of course, we need to check if the patient is really has realistic expectations. Has he an adequate degree of suffering for surgery and been resistant to conservative treatment? And if that's the case, we have a go for surgery. If this patient has a cavus foot, we'd rather go on a Zadek if he has little calcification. If he has a cavus foot with major calcification and alteration of the tendon, we'll still go for the central split with a Strayer. If he has a non-cavus foot, then we'll straight go to the central split and don't think about the Zadek at all. Thank you very much. Any questions? No? Okay.
No debridement of the tendon is required.
Sorry?
No debridement of tendon is required. Can we go ahead with the endoscopy?
Arthroscopy.
If there is no requirement of tendon debridement, just to remove the hairlines, can we go arthroscopically?
Just remove the Haglund with an arthroscopic or endoscopic. Yes, of course, of course. But I would still go for lengthening of the posterior chain. I think that is important. Yes, and that would be rather for non-cavus feet. They work well.
Strayer?
The Strayer, I'm sorry, a posterior lengthening procedure of any, a gastric slide.
Okay, gastrocnemial slide also, yeah.
Yes, exactly.
Okay, thank you.
Yeah.
How do we decide whether there is minor calcification or is it a major calcification? What is the criteria of minor and major?
So
because in our cases, mostly we get major calcification.
Yeah, okay. I mean, an X-ray, of course, but then I usually do an MRI as well just to see how damaged the tendon actually is. And if you have 50% damage or more, then for me it's clear. You need to go straight there. If it's less and small, then I think there's still a lot of healing potential. That's about my algorithm, a very personal one. Yeah. So in the cavus foot, actually, when you go through the literature, I spared you that, but there's of the calcaneus. It's not the pitch. The pitch, that's that was very astonishing for me to read that paper. It's the length. So you need to keep it for long.
How much wedge you have removed? The extent of the
How much I remove? Yeah, so the wedge is going to be depending on how much length I have, but it's not more than.
How you measure that wedge?
I go for about a centimeter on the top, not more. It's eyeballing. Okay, yeah.
99.9% in India it is insertional.
Okay. That's
and I can tell you, yeah, it is interesting. While if you look at the literature, 66% is usually non-insertional and 33% is insertional. Indian pathology is different. We don't get cavus much.
Okay.
Okay.
Yeah.
We don't get tight calves. We don't get tight gastrocs. So do not go about tomorrow starting releasing all your calves.
Yeah, that's probably.
It is easier to manage a tight calf which stretches. It is very difficult to manage a calcaneus. Okay, so that's another thing. So pathology is different. We hardly get anybody with only Haglund. We always get patients with always calcification.
Okay.
Okay, so these are very, very different pathologies. So you need to take Zadec. I have started doing Zadecs, and the last 4 I did all MIS. We're waiting to see how they go by in the last 3-4 months. What is your experience on MIS?
Well, we don't do them, but it's very good to do it. It's just, it's not something I feel comfortable with.
Okay, so you do
in this indication, I do MIS, but not for the static.
No, why not?
Sliding osteotomy, I just don't feel comfortable with. I don't know. Still a bit scared of the nerve, things like that.
Okay.
It's personal.
Leo, what's your opinion? You do MIS Zadec?
Minimal invasive.
Yeah.
For me, I make it. I make it mini open and make a step plate because then I can really shift.
That's sort of shifting.
MIS Zadec.
Zadec.
I'm just not. I mean,
no?
Yeah.
But I wanted to
It's
make
difficult, isn't it?
Yeah, so there's another there's a technical tip actually which you actually can be done, but we don't have that pathology because we have posterior calcification, which you can't manage endoscopic.
How many percentage of this Haglund and the tendo they go for the surgery? Hardly the 10% of the patient they go for the surgery, and 90% they are on the conservative treatment. How is that?
No.
Every patient they go for the surgery?
No. It really no. There is
how is withdrawal, heel elevation and
no. So I understand it. You have to see 70% of the patients will get better with eccentric stretches.
I agree.
And you have to tell them that they have to be doing the physiotherapy rehab. No ultrasound, no infrared, no wax bath. Physio rehab.
Yes.
Okay, for 6 weeks to 3 months. You actually have to ask your patient, tell me the exercise which you're doing it. If they show you the exercise they're doing it and they're not getting better, then the next option is a shock therapy. I use extracorporeal shock wave therapy. Fantastic results for another 10% of patients. So 70 plus 10, 80, 15 to 20% do require surgery. But they have to grow through that hoop.
Can you demonstrate that? Can you demonstrate that exercise?
Eccentric stretches? Yeah,
Patient is not opting for it.
you just get a step. No, you can't do that. We have to get a step. A step. I'll show you there. I'll show you during the examination.
But what I won't mention, I have done endoscopic argument from 1994 to 1998, for 4 years, and that's because the rehabilitation time was so long. When you make an argument open, the rehabilitation time was 6 months normal. And I said, let's go it arthroscopic. They made it 4 years arthroscopic. The results the same, 6 months, and longer operation time. That's the reason I stopped it, because arthroscopic is no advantage. The results are not better, and the rehabilitation time is not shorter.
I could do the whole flat foot. I still don't need to do that.
Those exercises when sir will do a live examination of the patient, then we can go. We are going with our orthopedic session. So Dr. Manu sir will take talk on hallux valgus deformity.
हाँ तो फ्लैट फुट पे ले लेता फ्लैट फुट पे चलिए
He is going to talk on flat foot first, then after he will go on valgus.
So I'll need some drinks also here. Sorry, chai. So this is for Swiss guys. I'm sure you know this. And you know who's taking the photograph? Beat. Yeah. So he took me to Zermatt. Yeah. So we spent 3 days together. Who? He? Me? No, of course. It was my luck to be with him. So he was in India twice, couple of times. Thank you so much. Okay, thank you very much once again. I'll be talking on flat foot. Now again, request people when they see patients in their clinics, especially adult patients, adolescent and adult patients, first thing in your books, in your case notes, do not write flat foot. Okay? Rule number 1, do not write flat foot, not because of anything, just pure because of insurance purposes. Because the sooner you write flat foot, the patient may be a 60-year-old who is a flexible flat foot or pes planovalgus or PTDD or PCFD or AAFD, whatever term you want to call it. As soon as you write flat foot, and this is for Indians, the insurance people say this is congenital and reject the claim. So don't write it, okay? That's rule number 1. Arch support, we know tibialis posterior is the key thing. It's a powerful inverter and a plantar flexor of the foot. Locks the transverse tarsal joints and acts as an arch support, especially during gait and loading situations. And then of course you have the long and the short toe flexors. That's a diagram how it works, not going much into the details. Key thing, understand it's a complex 3-dimensional deformities. Effectively, if you want to do as a term, it's a dorsolateral peritalar subluxation. Which deformities do you see? Always examine the patient from the back. You will see that the heel is going outwards or in valgus. So hindfoot valgus, midfoot abduction, forefoot varus, and again in the exam I will show you how do you check for the spination deformity, varus deformity, and most of the times the gastroc is tight as well, so the patient has an equinus deformity. And if the patient's present in a severe deformity, you will have the ankle also in valgus. So calcaneus, awards, dorsiflexus, and hyphotis and valgus. Forefoot, abduction and supination. The arch collapses with subluxation. Now subluxation is not only at the talonavicular joint, it could be at the talonavicular, NC joint or the TMT joint. And there can be a differentiation or differential uncoverage of talar head. The lateral column effectively shortens and Achilles is tight. We've already spoken about the PTD, arises from the posterior tibia, inserts on the navicular and gives a multiple slips. The key is that there is a zone of hypovascularity around 4 cm proximal to the navicular tuberosity, and you can have transient ischemia. That's why patients present later. This is all good for Caucasian population. Because we get patients who have been having flat foot. So we have patients here also who are completely flat foot but completely asymptomatic. Okay, and then they become symptomatic at the age of 20, 30, 40, 50, 60, 70. It doesn't matter. So what came first, the hen or the egg, or chicken or the egg? We don't know. So usually in our patients, the tip post is usually secondarily affected. We had cases where patients are symptomatic, but you open up, the tip post is pristine. So you don't need to check that out. But Caucasian, usually the arches, tip post starts getting a little bit of synovitic, the arch starts falling off, and that's the primary thing. But that term has also changed. It is called PCFD. So most female, age range anywhere we can see increase in obese and diabetic, and half of the patients will relate a traumatic event to an initiation. Examination, as I said, always see from the front and the back, always expose up to the knee, because you want to know what is happening in the knee. The knee may have a deformity and the foot, so you want to make sure that if you're planning anything, you're planning properly proximal to distal. See from the front, see from the back, and from the sides. Look at that. That's a normal alignment, 0 to 5 degrees of valgus. That's hindfoot valgus. Always do these tests. It's a single heel raise test. A patient should be able, you ask a patient, I will demonstrate it, you ask a patient to put hands on the wall, not on the desk, on the wall. Ask them to go tiptoes both sides to get that confidence, understand what you're doing it. Then do it on the good side and then do it on the affected side. Not only once, at least 3 to 5 reps, because sometimes a patient may have an early tip post tenosynovitis, and if you do 3 to 5 times, then they get tired, and then you will be able to see that they are not able to single heel. If they fail the single heel, usually it's tip post plus minus something else as well. Okay, silver skull test, check for gastro tightness. Again, we will show you how do you do silver skull. Get your dorsiflexion of the ankle, knee extension and knee flexion. Different stages of flat foot or PCFD or AAFD. PCFD is a new term coined. I don't think so is any useful. Do you find it useful? PCFD term? No? It's good for medical side. PCFD, progressive collapsing for deformity. The guys who have insurance does not understand anything, your claims get passed. You that. Otherwise, the better point is to use AAFD, adult acquired deformity. Even if they search on the internet, you can still get it right. So 4 stages, stage 1, 2, 3, 4. Won't go too much into the detail, but stage 1 is tenosynovitis at the tip post. There is deformity. Patient comes in with pain on the medial side of the ankle, posterior to the medial malleolus. Rest everything is normal. X-rays are normal. MRI will show, or an ultrasound will show there is tenosynovitis. Okay. Stage 2 is the important one. Again, you have A, B, C. I have not gone into the details. It's too cumbersome. We could have a full 1 day of only flat foot lectures. Correct? And we still be not come to consensus what is the treatment option. But the key thing, which are things are in red, there are 2 very toe signs. So if you go back, sorry, I'm just going to go back a little bit and see. When you see from the back, where was the pointer? So if you see from the back, here you can usually see 1 or 1.5 toe from the back. That's a normal thing. But if you have a hindfoot valgus, you should be able to see 2 or 3 toes. That's what it is called as a too many toe sign. So that's positive in stage 2. Okay? Unable to do a single heel leg raise. So they may start with one, they may do second, but third, fourth, fifth, they will not be able to. So they categorize into stage 2. Subtalar joint is correctable, so it is flexible flat foot if it is looking at that. Radiograph shows all the other things. The arch has collapsed, Meary's line is reduced, talar head is uncovered as well. Okay. Investigations, Meary's angle is the long axis of the talar axis to the first MT. That's long axis is increased. Look, and then the key thing, weight bearing X-rays, to check where the sag is. We think many times, and most of the time, it is talonavicular, but don't get caught out, and especially if you're doing foot surgery. And even if you're doing a fusion, you can do a good double fusion, triple fusion, and find that the NC joint is sagging, and then you have to go back again. The patient come back, it's still sagging, it's still hurting. Okay, I've been caught up with that. AP, so look at that, AP X-rays, weight bearing, that's your talar head uncoverage, and you can determine either in the angle or in the percentage. Because the key thing is if it is more than 40% of talar head uncoverage, you need to start thinking of doing some lateral procedures. MRI is very good and it is important, not just to talk about flat foot, but to see if there is any other pathology happening as well. That's your tip post tenosynovitis seen here. Also, now, no, in Western side, a lot of literature talk about spring ligament, spring ligament stretch. I think in the Indian population, and I think it's Asian population, we already stretch. Because the pathology starts with spring ligaments and the ligaments all stretched out. And then the tip post comes second. So all our patients usually will have, they don't have an acute tear, they are just all stretched out. So we always have to do an imbrication or something. How do you manage? Sorry, stage 3 I have not covered on that. Stage 3, when you start getting arthritis and your deformity becomes rigid. And stage 4, where the ankle gets involved. Okay, we'll talk about what to do with the ankles. Treatment by stage 1, again, any stage patient comes, start conservative. Rest, ice, anti-inflammatories, insoles, you can give orthotics, orthotic customized, you can put UCL, AFOs, all things you can try. And if you feel that, you have a surgical principles. Surgical principles, if the pain generator is a tip post, you need to address that by tendon repair. Is you cannot do it, so you do a tendon reconstruction. If there is any osseous impingement or arch alignment, you need to realign it. If it is joints are arthritic, you need to fuse them. Tendons, if it is tight, you need to loosen it. Any deformity should be realigned. So get your foot right, basically plantigrade foot. Bony, what are the bony procedures you have? What are the options you have? Medial calcaneum osteotomy, lateral column lengthening, cottons. These are the 3 things which you can play around, and the midfoot fusions. Soft tissues, tip post reconstruction or ABL transfer, spring ligament reconstruction, and gastroc. Again, so your flat foot reconstruction will be around all these procedures. The problem is, when do you do what? We still can't decide between the foot and ankle. Orthotics I've already told, different types of orthotics can be tried. Usually the problem is the compliance. These patients have been flat for so long, you give them suddenly a big correction. The key thing is, along with the correction, there's a lot of back and forth happening between you as a doctor, the orthotist or the prosthetist guys, and the patient. Okay, so that is very, very important. Patients like this, it's severe deform and arthritis. What do? Do you do always a pantalar fusion, you do a triple fusion, you do a double fusion, or you can save the joints? It's easy to say you can do a triple arthrodesis, but you know the fact that these patients then go on to have further arthritic down the line and you treat them. So try to salvage as much as possible the joints. So if you look at individual deformities, you can find out what you need to treat and how do you treat it. If you have a patient with hindfoot valgus which is correctable, you do a medial displacement calcaneum osteotomy. This is the go thing for all the foot and ankle guys. hindfoot easy, small, I think approach we've already spoken, small incision, open it up and displace the calcaneum medially, okay. Displacement usually is more than 10 mm or 1 centimeter. The more the better, okay, because that really gets you going and really detensions all the medial structures. So that's the displacement, complete reduction of the hindfoot valgus. And if it is, you can also do a MDCO with a subtalar arthrodesis. I have not done it, but if you find that your subtalar you have not completely corrected it, then do a medial displacement. It protects the ankle joint as well. This is how you can do it. Mark your incision, that's where my osteotomy will come, marked it. Always there is a branch of the sural nerve right at the proximal part of your incision, protected. Once you've done that, then there's just soft tissue in the periosteum, elevated. Before my osteotomy, I always put a guide wire, so I know once I've shifted it, I just tell my assistant to just proceed with the guide wire. So you don't not. So that's why my osteotomy is displace it. You see, I now, this is again few years back, I shift more and more of the calcium. You can do it. There it is. I used to fix it with 1 screw, now I do 2 screws, but again no difference. So that is your calcaneum osteotomy. Now tibialis posterior, if it is degenerate, tenosynovitic, non-functional, you can't do anything, you can check it at the bin. You do an FDL transfer. It is proven clinical outcomes, no morbidity to the digits and no risk of neurovascular transfer. Where do you transfer it? To the navicular. It's a superior movement arm, does not compromise the medial column stabilization. Okay, so that's what it has been done. You take your FDL, your tip post is gone, just beneath it is your FDL, reroute through the navicular, come on itself, tighten as much as you can, that's what it is, tightened up, okay, and you can screw it onto itself, and you can also use a swivel lock if you wish to do it in the navicular. I don't use it if I'm just doing the FDL. That's what midfoot abduction, there it is. If it is more than 40% uncoverage of the talar head, then a lateral column lengthening really helps in get the whole foot back onto the talar head. So that's your lateral column done, and also then after that you assess if your forefoot is supinated or not. Usually the teaching is forefoot, if it is flexible you can do it, but what I found that the patient still tries to get that because they've been so habituated. So I now always add cotton to just get that first metatarsal down, and I think my recurrence have reduced it. So forefoot, varus we have spoken about. If it is flexible, no flexion, digit, plantar flexion, osteotomy, or you can do a fusion as well. So that's your cottons done. Equinus, in the end, check if the TA is tight, and then if it is tight, you can do a gastroc or a percutaneous. Usually if the gastroc is tight, you can do a gastroc release. Again, in the combinations, you can do if the subtalar joint is arthritic, you can do a subtalar fusion, and if it is again type 3 where subtalar plus talonavicular is arthritic, you can do a fusion as well. Rigid flat foot, again, so stage 4 we spoke about flexible ankle valgus without arthritis, and with stage 4B is rigid ankle with arthritis. 4B, it's a pantalar fusion. 4A, you can try to reconstruct the deltoid by various means. Simple joint sparing procedures, 4A and 4B. Deltoid ligament reconstruction is not an easy job. You have to use allografts or autografts. In milder cases, you can use the internal brace or the flexible tight ropes or the flexible fiber tapes, you can use it. For realignment, we have already spoken about the different procedures. Deltoid ligament reconstruction, we have spoken. You can, as I said, allografts, autografts, or you can use a tight rope. That's the algorithm. I just wait for you guys to picture. It's a long thing, I won't go through the whole thing. But as I said, flexible, try to salvage it with multiple procedures. Rigid, usually a double fusion. If it is ankle supple, reconstruct the deltoid, ankle rigid, and probably a pantalar fusion. Thank you so much. That's flat foot in 16 minutes.
It's a whole book.
I know.
So from lecture part to present, we are going to have a live examination of flat foot. So we are going to see how Manu sir is examining his patient. So it will be
Okay, so after that flat foot presentation, I think we have a volunteer, Ms. Aarti Singh. She's 40 and she's been having pain and swelling in the area for a very long time, but it has increased in the last September onwards. She has had a viral fever, and post viral fever she complains of pain and swelling in both the ankles and feet. Left my side, right? Left more than the right. Okay, so as I said, first thing, you get to have a proper exposure of the patient in terms that always get up to or above the knee. That is very, very critical and very, very important. Okay, so in my clinic, in every patient who comes to it, my staff has been instructed to tell all the patients that as soon as you go, you need to get up to the knee. Exposure has to be done. Okay, the first thing you do is, as soon as you're probably sitting, first is you examine the knee and you take them standing. That is usually my protocol. That's what I will do it.
Now, if you see, now you can clearly see now,
if you would have seen all the photographs in my presentation and in this side as well, you see how the ankle and the foot on the median side is almost falling off, and from the front also you can see that this is not a normal alignment. Okay. The second thing is always get them to turn around.
You want a pointer?
And what I always tell them to do is get the foot straight to a level कर दीजिए, level कर दीजिए.
दोनों को सटा दीजिए.
थोड़ा सा दूरी रखिए. Yes, sir. Thank you. Now you can see from here how the whole ankle, both the sides, ankle and valgus, bilaterally, there is significant swelling present both on the medial side of the ankle joint.
Okay.
And also if you see from the back, if
you see right side, how you can see it, the 2 minute toe signs.
Pointer.
Yes, sir.
2 minute toe side present on the right side, and left also is there, but
Not too much appreciative. I don't know if you can appreciate
on your
right
series
side.
as well. Now, while you are there, you don't want to go back again and again. This I'm teaching you not as a your postgraduate examination of
exam, inspection, palpation and everything. This is how you would do it in the clinic, because you don't want to go back and forth again and again and again and again.
So while you are there, I just ask the patient. Now you have also seen her walking, how she is walking. Okay.
So again, hands on the wall and ask her. I can see if the ankle is getting corrected or not. I'll just make sure.
And now, पैर के वापस नीचे आ जाइए, वापस ऊपर जाइए. Partly on the right side it is getting corrected, not completely correctable. नीचे आ जाइए, वापस ऊपर. Left side it is getting correctable. Okay, so right side
you're not sure if it is a you're not sure if it is a flexible. So between 2 and 3 you don't know. Now
इसमें ज़्यादा है.
Sir, we can see the fullness of posterior of the malleoli more on the lateral side.
Yes.
So why it is so?
So she has synovitic, she has swelling. That's what she has pain.
Okay,
we don't know. I haven't done the examination.
Okay.
This is still inspection going on. That किसमें ज़्यादा है? Left.
So she has more pain on the left side. So always do the second.
The less painful always do the first. Left पैर नीचे रखिए, right पैर. कहाँ पेन हो रहा था? जब पैरों की उंगलियों पे खड़ी हो रही थी.
Cameraman.
इधर भी पेन हो रहा था जब उंगली पे खड़े रहते हैं. So she was complaining of pain on the medial side, lateral side, and also in the midfoot area. Now, bearing in mind, this is slightly different pathology in a way, because she had a long-term symptoms, and then she had a chikungunya, or she had some viral. She had some viral, and that has changed her symptom or aggravated her symptoms. So we are not looking at a single straightforward pathology. So understand that. Okay.
So again,
right
side she is less painful.
So we'll start the right side and then go to the left side.
Okay. Now the other thing in your
in your clinic, if you're taking in a foot and ankle, either you should have a bed which really goes high up. किसका आवाज आ रहा है? Clinic, if you take an exam, either you can get on a bed, get the patient on the edge of the bed and get the bed really high up, so you really need a electrical bed, or you get a chair which is slightly high up and have a small good footstool which your chair really comes down, so you are now at the level of the foot. And this is the third way which you can do. You can put your patient's foot on your knee and examine her. But she needs to make sure you have a backrest, so she is comfortable, she is not tensed up at all. Okay, so it is very, very important. And clearly see right side, as soon as I put her on the knee, okay, she's not in valgus, I can clearly see the heel is literally below. Flexible, though she was not corrected, but it is flexible. Okay. She has a swelling on the medial side. On the this posterior there's a big the side as well. Okay, she has some swelling in the foot area. So we'll check and see is tender there or not. So again, always start from the non-tender areas towards tender. You don't want to straight away go and jump into examining where it is painful. Just start, get the confidence of the patient that you're going to be gentle with her, and then you can palpate around. सबसे ज़्यादा दर्द कहाँ है? राइट साइड में. ठीक है, बहुत ज़्यादा दर्द. ठीक है, तो मैं जस्ट इधर हाथ लगाऊंगा, मेरे को बताना. So tibialis posterior, I want to palpate. So she is slightly painful there. So just this is a medial malleolus, just tracing the tip post. So she is tender on that. She is painful there, and also around that spring ligament area. I can feel the tip post, roll it, and you can see how she is almost getting jittery. Okay, that way. Also at the same time, many times tip post, sinusitis, a lot of sinusitis, and patient complains of burning sensation or altered tarsal tunnel. You may want to check. Just relax. You can just do a tunnel scan there itself. So she is giving a TNS positive as well. So she also may have some tarsal tunnel syndrome symptoms. Okay. Then come on the medial malleolus, on the deltoid area. इधर दर्द नहीं है, ठीक है. Again the same thing. Tibialis anterior tendon. She is like synovitis in the ankle joint. इधर है. The anterior ankle joint pain, दर्द है. So her ankle is really involved. Synovitis इधर. Lateral malleolus, lateral fullness is there definitely here. Okay, anterolateral gutter is painful. And then you can just go below the below the lateral malleolus and check sinus tarsi here. That's usually, again, if you have a lateral pain and severe flat foot, you will have symptoms there. And again there I am checking for her peroneal is okay. Okay? And you can just follow the peroneals down. She doesn't have any symptoms there. Now again she complains of.
We'll go for the lateral side because he has something.
I'll do it on the other side. Now again midfoot area. Just checking talonavicular. So she has some tenderness around the talonavicular area also. Fine. Now there is an excessive movement. I don't know if that is from the ankle or the subtalar joint. You can check it. Subtalar looks okay. I think it's the ankle which may be moving. You see how? Look at here. See that? Okay. That's all right. ऐसे नहीं है, ठीक है. Okay. And then there's the last. Do a little bit of rotation and the supinated rotation of the foot to check if there is anything. Nothing. Okay, so that is done. This side. Now she knows that I've been gentle. So she allowed me on the normal. So again, the same thing. Tibialis posterior, she is significantly painful there. Same thing here on the tip post as well as the spring ligament. Tenor sign is positive. You can check for effective tenosynovitis also if you wish to. Again, get your ankle dorsiflex and plantar flex and then check. That's okay. It's okay. Deltoid. Deltoid is okay on this side. Joint line. Sorry. Joint line and anterior joint is synovitic. Lateral side is there as well. So this is the tip of malleolus. Check there, and then if you come below it, that's a sinus tarsi. So she doesn't have an impingement per se, or calculable impingement. Sinus tarsi, a little bit anterolateral gutter synovitis. So she complains of swelling tenderness between anterolateral gutter and the sinus tarsi.
check for the movements. Taking some painkillers, she's not feeling it. And then in the end, you can always check the neurovascular status. Okay, so that briefly completes on your flat foot stuff. Okay, any questions? No, crystal clear. Amit? Gastroc, sorry. For gastroc, you really need to get the patient just aram se baith jaiye. So gastroc tightness is one thing which you really need to learn to do that. Thing is, if you just do this, it's not worth it. You need to correct the heel into neutral position. Then check for dorsiflexion, and you can see here
not going.
How much dorsiflexion you have. घुटने को bend कर दीजिए. And then check for dorsiflexion again in knee flexion and सीधा करिए. There's not much difference, so she's not tight here. Okay. Normally, if you have a difference of more than 10 to 15 degrees, that means the gastroc is tight. They need to make sure that, or you should think about releasing the gastroc.
So, at this stage, sir, what will be the diagnosis?
So, diagnosis for her, she is bilateral PCFD or bilateral AAFD. As of now, left is worse than the right. Left is type 2. Okay, right, I think maybe the ankle is involved. Always get x-rays. Weight bearing x-rays. I have a whole thing called something called as a FF series x-rays. Bilateral ankle AP standing, bilateral feet AP lateral standing, and bilateral Salzman view. That's a full spectrum of x-rays for all flat foot patient. Yes, correct. Because she has more posterior survival on the left side. That's why. Not necessary. So one thing is there in flat foot, a patient from type 1 can straight away go into type 4. So we have had patients who have a very mild deformity with an ankle involvement. So it doesn't go in sequential thing. That's why. And also, as I said, she already had a long standing pain which recently got aggravated with the post viral thing. That's why.
Yeah. Thank you, sir.
Okay. I think that's a good question. So again, so what you do is you correct. See, as soon as I did that, you see from the top, either say a camera leke आओगे, so normally a foot is like this, but as soon as it is corrected, how it has gone like that, that's your forefoot supination. See, so she was like this initially when she's standing, but as soon as you correct it, I'll just do a little bit of over correction. That's your supination. Now, this is what I was talking about. When you're doing a flat foot, this is correctable. So normal traditional teaching says that if this is correctable, you don't need to do a cottons. I think what I have found out, I rely now less on soft tissues in my flat foot reconstruction than bony. So I do a calcosteotomy, I would do an FDL spring ligament, I have a low threshold for lateral column and a very, very low threshold for cottons. Because as soon as I get the heel inside, I get this. The patient also has a good tripod. You need to rely less on the soft tissues there. Okay. So again here, so this is a flexible flat foot, so I don't think so there is an issue. If it was a very severe deformity like this, and really I'm stretching it here, and this side of the skin is also very tight, then on the table I may think that, and I may think of doing a peroneus brevis to longus transfer, more so in patients whom I'm planning to do a very rigid type of deformities for a double fusion. Because in that, to get that calcaneum under the talus, the peroneus sometimes don't allow it to do it. So that's why in those cases I do a peroneus brevis stenotomy or a transfer. So this is the so these are the X-rays of this patient. Again, ankle I don't have it, but you can see here the Salzman view. Salzman views are there. Those are standing views, and you can clearly see here the tibia, the talus, and the calcaneum. You can see here this is approximately 20 degrees of valgus, so that's not normal. Normal should be around 5 to 7 degrees. And on the other side, you can also see that the ankle, the talus is not sitting congruently in the joint. There is a bit of tilt in the ankle as well. So I think that's what we were seeing on one side. Lateral view looks to be a decent arch, so I don't know, but if you see, the tibia is slightly more posterior, inclined posterior. So I think this is not a complete weight bearing X-rays. These are not complete weight bearing X-rays. Again, you have to teach your radiographer how to do a weight bearing X-rays. Okay, a single leg weight bearing X-rays is very, very important, because I think the arch could still be falling a little bit. AP view slightly overexposure, but here you can see the talus slightly uncovered, not too bad at all. So in this case, if these are the true AP standing X-rays, I don't think so. This patient requires a lateral column lengthening. I think a medial procedures and an MDCO with a deltoid reconstruction would be more than sufficient. Okay. Any questions? Happy? Not happy? Sleeping? Tea, coffee? Lisa, you have something to add? Anything to add? Please, go on. Come here. Cottons, I always do. Yeah, that's what I said. Because what happens is, what I found is, many times you see your MDCO, you do it, you okay it, but you said you could have done more, and then the patient starts weight bearing and they go like this. While if your first ray, and again it's on the cavus side. See, if you have a drop first metatarsal, patient always has a varus. Now if you have a drop metatarsal with a valgus foot, automatically your valgus will get corrected. But our side, the patients are so used to walking like this. Suddenly I've had, so the last 2 years I have changed my whole algorithm. Patient really now starts, I'm walking on my lateral pod, I'm walking on my lateral. I say, you will get used to it, you will get used to it. Yeah.
So next case is our one live examination on a diabetic foot. So this will be a quick round, because already the basic sir has shown. So on a diabetic foot, what he looks for, just a basic.
So this another gentleman, 55-year-old gentleman who is affected by a post-polio left leg, and also uncontrolled diabetes. Those are the two things. Discharging sinus in the heel for many, कितने महीनों से के सालों से? Since many years. So it comes on and off. It's had some treatment. If you look at it clearly from here also, you can see this ankle is completely unstable. Okay, that's one part of it. And then he has a small, probably a sinus which is coming on and off. The key thing in cases of diabetes, and if I'm thinking, first thing is, what is the skin condition? What is the medical background? Is the diabetes controlled or not? And the last thing is the vascularity. Okay, looking at it, the vascularity looks good. He has a good amount of hair. Skin looks reasonably good. Skin here distally is also fine. I'm convinced that if you were to do something surgically, we can do something surgically. Of course, before you embark on doing anything surgical, you'd always want to get physician opinion. Get a arterial Doppler. Okay, that is one important thing. If you see that there is some atherosclerotic changes beyond the knee or beyond the popliteal, speak to an interventional radiologist and get it sorted. Okay. Now you need to always, in diabetic foot, you cannot work alone. You have to work with multiple disciplines. Okay, you have to have a good physicians, diabetologist or endocrinologist, radiologist,
interventional radiologists, vascular guys, and plastic guys. These have to be your friends, where sometimes some things can go really haywire and you need to get help from these guys. So here looking at it, everything looks good. Check for the pulses. Pulses, I think it's there. Okay, ankle is very unstable. I can't get him standing. As soon as he stands, the whole ankle goes wobbly. He has a discharging sinus. As of now, it is not discharging, but it has been on and off. I would, in his case, of course, look at the x-rays. Let's look at the x-rays here. Anything else you want to know from the clinical side? If you look at the x-rays, ankle, look at the talus. The tibia and the foot is 90 degrees, okay? So that's very, very unstable. You can see there's some form of some reaction happening here. So I would first get bloods, CBC, ESR, CRP, check what is the counts are there. If the counts are normal, fine, I would still get an MRI done. I would probably find some sort of a reaction and some sort of things happening there. If you want to do some really surgical intervention, first thing I would open up posteriorly, excise the sinus, clean up the whole thing, debride it. Maybe 1 stage, 2 stage I would do it. First stage, remove everything, send for cultures. If whatever cultures come, I would put the stimulant beads, get the infection sorted. That's part 1. Because the reason why he's having his or started it is because he's walking on the medial side. So the final thing is you need to get him on a stable foot. That would mean getting him on a hind foot nail. Okay, but a good hind foot nail, not a close. You have to do an open hind foot nailing. Okay, you have to prepare the ankle, you have to prepare the subtalar joint, get it sorted, get it a plantigrade foot. Now, in diabetics, if you were to do a hind foot nail, you need to immobilize them and give them a cast for 3 months. After 3 months, you can make him weight bear in a walker boot for how long? How long? Till he says my walker boot is breaking. And the walker boot has to be a really good quality. So invariably it's 9 months to 1 year. I tell them, walk. Because they will stabilize. Even if it doesn't unite, the foot will stabilize with fibrous tissue and everything. And even if the nail breaks or whatever it is, at least they're stable and you can sort it out. Okay, so a successful outcome is a planting.
Thank you. So this is going to be a short and sweet speech for late afternoon. It's about a perfect MTP fusion. So what is actually a perfect MTP fusion? It's one that heals in a perfect position. The position is actually what is going to determine whether your patient is happy with its fusion or not. A bad position is what has given a bad reputation to that surgery. If it's in a good position, you will be just fine. So what is a good position? Actually, it's important to have a dorsiflexion that you define relative to the floor and not the first metatarsal, because that's not what the patient is going to use when he walks. If that's the only thing you keep from that speech today, I'm happy. But then also we have to have a look at the valgus position, of course. We should avoid any impingement with the second toe. For that, we will choose a slight valgus of about 10 degrees. And we should also pay some attention to rotation, which should be neutral. Neutral means that if you look from the tip of the toe, the nail needs to be just aligned with the floor as well. What happens if we have excessive valgus? Well, there will be painful impingement of the second toe. In case of varus and shearing, of course it will rub with the shoe. What happens if the sagittal plane is malpositioned? If you have an excessive dorsiflexion, I'm kind of losing my pictures here. Funny. Yeah, here it is. If you have an excessive dorsiflexion, that will lead to high flexion of the IP joint because the patient will still try to grip the floor, of course, with an increased plantar pressure under the N1 head, and the toe will rub against the shoe. The worst of all malpositions is probably the one with an excessive plantar flexion, because when there's no clearage for walking, basically. So that will eventually lead to an interphalangeal joint overload with an excessive dorsal extension with arthritis. And it will also create pain and pressure under the hallux, so under the phalange of the first toe. People start to walk over the lateral toe, the lateral foot, because they have no other choice, and that will create stress fractures and problems like that. There's also a subtle problem. Sometimes the malposition can be in the frontal plane, meaning the rotation of the toe is wrong. And even a mild rotational malposition can actually cause some jamming, very painful pressure in just one point under the toe. So it's important to watch the details. So how can you avoid malposition? I think one of the first things to do is to use cup and cone reamers. They will help you while having a large surface that can actually fuse to really fine-tune the position without having to cut every time a little bit more, what we need to do with the flat cuts. So with flat cuts, at some point, you stop paying attention to the position, you just go for it. While with a cup and cone reamer, you can really fine-tune without losing length. The second thing to do is to have actually a flat surface in your OR, any kind of flat surface, to simulate the weight bearing so that you can really see how the toe off will be when they walk. There's a last little tip. If you do use pre-contoured dorsal plates, don't use any over 5 degrees of dorsiflexion. There's even a publication that has shown that will induce you into malpositioning. Okay, so now it's about fusion and position. There's a large debate about what fixation to choose, of course, plates, screws, That's not something I want to go into, because that also could use up the whole evening. I just tell you about my choice. My choice is a plate with a low profile. It's pre-contoured, it's stable, it's made of titanium, it's a locked dorsal plate, and now comes the important part. If you use a dorsal plate, please do use an independent screw. There's many studies shown that using an independent screw with the dorsal plate will actually increase the stability of the construct tenfold. Keep that in mind. Never ever don't do the screw. It's the most important thing. So here's my personal technique for that. We use a dorsal medial incision, like that. Careful for the cutaneous nerve. Then expose your joint. Please, if you can, leave the lateral collateral ligament intact. It's supposed to reduce any intermetatarsal angle. That can help. Then I do use these cup and cone reamers. I put in my K-wire. That also can help you to cheat it, but you cannot put it central if you want to correct an intermetatarsal angle that is a bit large. That's one of the tips. Then you use it. When you use it, if you're not used to it, please go slowly, because you can really go very quickly, very short. So be just go slowly. But let the reamer go full speed before touching the bone. That's the most dangerous part. Then for the distal preparation, same thing. Use the reamer. Then one thing that is useful is to put the Homan retractor actually under the phalanx and to really pull it to like a drawer to use, so that you have enough clearance, because that's something a pain in tight fusions. And then some joint preparation, of course, with the drill bit. Do not remove the graft that comes out of the drill, because it's actually your graft, so you leave it. And then what I always do is really remove the dorsal osteophyte so that my plate actually sits tight on the bone and won't ride, because otherwise it's very difficult to give it a good position again. Now you will find something that always is subject to discussion. I personally put the plate first. Just fix it with a plate, because if I do a screw first and my position is not perfect, I'm screwed. What can I do then? Nothing. So I put the plate, I try to find the good position, and then I put all my screws and the it's not really a lag screw, it's just a metatarsophalangeal screw in the end. And the most important thing is, while en route, always check the position with your plate, really check it. Do simulated weight bearing, find what we described before, and then you fix everything. We call it the home run screw from Seattle, of course. Don't forget it. If it's the only thing you take from my speech is take the screw, put it. And then comes the final control, of course, with all those positions, and you can see how nicely this MTP orthodesis will be done, and that's what makes a happy patient and a happy doctor. That was just a quick overview about how to produce a perfect MTP orthodesis. Yes. No, we have a plate that goes from 0.5 to 10. I almost literally never use 10. I don't know. Most of the time I use the 5 degree and rarely the 0. Maybe the 5 is my favorite. Everyone's tired.
So the next deformity talk is there. So I will request Dr. Manoj sir to talk on hallux valgus deformity.
Thank you. So one more thing which I really, Alicia especially, we do more and more, or at least in my practice, I do more and more of MTP fusion for hallux valgus, severe hallux valgus. So in there, reducing the IM angle actually we need it. So slightly different pathology and slightly different approaches in that sense. Anyway, so next topic, hallux valgus, how do I manage them? Multiple deformity components are still there in hallux valgus. You have the enlarged medial eminence, you have a lateral deviation of the great toe, you have the increase in the IM angle, sesamoids are subluxed, and of course great toe is pronated. If you want to planning for do surgery, again hallux valgus patients come to us in the clinic. Patients come to us in a clinic and sometimes they just say, I don't have any problem, it's just a bad deformity, but no issues at all, don't operate them. Don't do for cosmetic stuff, don't operate just because it's there. Only if they have some issues, and most of the time the issues are with footwear. We do not operate milds, we do not operate moderates, we only operate severe. Because unlike in the western side where mild and moderate, they have to have it because of the weather condition. Here our patients are quite well adapted. They will wear chappals, they will wear sandals, they wear slip-ons because weather is not a problem. So that's why. But if they do have a problem, then surgery is the only option. Bunion splints don't work. Yes, you can give them, they come for a consult, you need to give them something, you can give them a splint, but it's not going to correct the deformity. If you want to do x-rays, again weight bearing x-rays, comparative, check for different angles and we go through it. Check for patient's age, neurovascular status and patient's expectation. Critical exam findings, pes planus, if it is a severe flat foot and they are symptomatic, lapidus may work. Hypermobility, again this is slightly debatable. You may want to do a lapidus or you can still do only a hallux valgus correction. Of course, if it is a rigid hallux valgus, arthritic hallux valgus, then fusion is a better option. Again, always assess gastroc. So one thing again you are taking away from all forefoot deformities, you have to check for gastroc. All hindfoot deformities, you check for gastroc. So every time you check for gastroc. Different angles you really need to know when you are treating forefoot deformities and bunions. Hallux valgus angle, usually it is less than 15 degrees. IM angle, which is a more important angle, it's the angle between the first and the second metatarsal. Less than 9 degrees is normal, and then you have mild, moderate and severe. Distal metatarsal articular angle, which is the articular surface with the shaft of the first. Less than 10 is a normal thing. Excuse me. And then you have hallux valgus interphalangeus. It's the angle between the articular surface, the MTP and the IP joint. Again, it should be less than 5 degrees, 8 degrees. Always again check for weight bearing x-rays, because the last thing you want is an unstable first TMT joint, widening at the plantar aspect of the joint. If you see that, you know that there is something happening there, then you may want to treat it at the proximal part. Like here you have a second TMT joint instability there, it's opening up and you may want to fix that as well. It can be divided into congruent, incongruent and degenerative. Congruent joint, there is no subluxation of the proximal phalanx on the metatarsal head, and usually for these cases you may want to do a distal metatarsal osteotomy, scarf plus minus an Akin osteotomy. Akin is a close wedge osteotomy of the proximal phalanx to get the toe straight. So in mild, IM angle is less than 13, hallux valgus is 40, less than 40. What things you can do? A distal metatarsal osteotomy like a chevron. There are more than 150 procedures for hallux valgus. Okay, what works in your hand, you need to learn, find out what you are capable of doing it and what you have been trained to do it. You may want to do a soft tissue release and a possible Akin, but scarf works. If you have a moderate deformity, that is between 13 and 18 degrees of IM angle or more than 40 degrees of HV angle, again you can do a proximal metatarsal osteotomy like a crescentric close wedge osteotomy. You can do a scarf as well along with soft tissues or any other thing. If it is a severe deformities, which is what in my practice and I think everybody's practice in India is, we get only severe. Nobody comes mild. A person will come mild. I do get, but some expats who's in US, Canada, Australia, because they want to come to India and do it. It's a very mild deformity. Otherwise, they don't get it from India. Proximal metatarsal osteotomy, scarf, or a lapidus, or an MTP fusion. So these are the options for severe deformities. Usually, I go for, if I can't do a scarf, I would go for an MTP fusion. We'll wait from the other faculty members to take their opinion. Scarf osteotomy, I have a full video, but sake of time, we have not put in. I think that's my go-to for all my moderate and severe deformities. From a mild to moderate in between, I would do a modified chevron or a modified scarf. The modified chevron, where I take the plantar limb, extend it downwards more. It gives a more stability. Instability of the first TMT, we saw that lapidus works quite well. Though I don't believe, again there are two schools of thought, that you believe that there is TMT instability first, which then you have to address it when you are addressing a hallux valgus. I think there is a paper now recently which has come up that if you correct the hallux valgus, a good correction, and patient has flat foot, the IM angle, actually the Mary's angle gets better over a period of time. That's just a recent paper come out in FAI in the last year. So you don't need to then fuse the TMT joint. If you have arthritis or spasticity, first MTP fusion. Interphalangeus, AK osteotomy. So in summary, soft tissue procedure alone is not indicated. So one thing is very clear, mild and moderate, patient comes with only bump, you do not excise the bump. Okay, that's not the treatment which you would be offering. I think moderate and severe, if you were to learn one procedure, yes, you could do anything. Scarf works quite well, it is very versatile, but it's a challenging operation. So if somebody want to do it, I think get trained properly, but once you are there, I think you would do like me. In every case I almost try to do scarf, except somebody tells me no, you can do something else, and I'll tell you what I do now. Congruency is confusion. I would just go through that, it's just sake of time. Operative consideration, soft tissue procedure alone not indicated. Osteotomy alone, no. If it is tissues are tight, you need to release it. Just few cases. Distal biplanar chevron osteotomy, you can correct it, DMMA corrected, HV angle corrected, IMA corrected. Okay, again, IM angle severe, you can do a proximal osteotomy as well and do an open wedge osteotomy, and you can get that corrected. Okay, look at that, more than 13 degrees IM angle, more than 40 lapidus, okay, and a second TMT fusion. Again, severe deformity, moderate deformity, more than 13, 40, instability at the first EMT, do a lapidus fusion. Again, Aikin is a good thing. Now, there are two reasons why I do Aikin almost in every case. One is because, you've corrected with your scarf, you've corrected with a chevron or something, you got your 90% corrected and the toe still looks slightly off. Aikin really helps. You get that really good correction. That is the first part. But the key thing, the second part is, when you move your toe inwards, your EHL acts as from a deforming force to now a normalizing force, and you really get that maintenance of that joint, okay, that correction. So you do an Aikin. Again, don't go through that. I just want to add one more thing now. MTP fusion. So a lot of stuff there, MTP fusions. Now the key thing is, you just don't pull over, okay, you need to correct it and you need to derotate it also. That's the other thing. Okay, there, that's the thing, derotate. 13 degrees, 25 degrees, correct it and then do a fusion. Okay, so when you do an MTP fusion, it's just not a box standard fusion. You still need to derotate it, you still need to do all your releases and then do a fusion, otherwise the recurrence rates are very high. Now it's quite interesting, if you do an MTP fusion, they have seen that over a period of time the IM angle also reduces, okay, along with an MTP fusion. Again, this is proximal crescentic. There are multiple ways to skin a cat. Find what works in your hand. Lapidus, non-union. So the reason why I don't like lapidus is there are more things going wrong than right. In US, there's a whole wave of lapidus happening. Not even lapidus, lapiplasty. It is literally every company is coming out with jigs to correct it, and just making money out of it. I think it's just because I think they're not trained well in scarf. That's why they're probably just doing a proximal correction osteotomy. Now the next thing is, I'll just go through that. It's just too many things. Sorry. This is end of the day. So bunions, you don't do a bunionectomy alone, you need to correct it and make sure you correct the DM angle also. Okay, there you go. Correction of IM angle worsens, that's fine, and then you correct the distal part. So again, multiple ways you can do it. But the key thing now is MIS. You guys do MIS? We have spoke about that. I think The one thing which will change and should change in bunions is minimally invasive surgery. Okay, that really works well, because two things you can do is through a small incision you can do a transverse osteotomy. The reason of doing a transverse osteotomy is, one is you can do a clean cut osteotomy, and the second is you can derotate the capital fragment, and you can derotate it to an extent where you can see the sesamoid sitting nicely onto the under the head. Once you do that, and then you shift it, reduce the arm angle, and then you fix it. So these are few of my patients. The right side, she is one of the actresses. She had a bunion done. That's just immediate. The left one also, you don't see the scars at all. And this is what you need to do. Yes, these are special screws which you can use it. You can shift as much as you can. It works in even severe deformities as well. Okay, and they work quite well. Now, if you don't have screws, you can use K wires as well, but you need to make sure you do 3 cortices K wire. Okay, so that's why. So you go in, you come out, and then you go again in. So in, out, in. So that's a 3 cortex fixation is very. This is 4th generation meta MIS bunion surgery. Okay, that's the new thing in the block, new kid in the block. We've been doing it in Mumbai. That's what it is. Thank you so much. Any questions for bunions? Sorry, at just the end of the day at 7:30. Weight bear, day 1. Flat shoe, day 1 weight bearing. And no plaster. No plaster. No, just a flat shoe, like a Don Joy or Darko or anybody's. Yeah. Or even flat sandal is fine. Done. Done.
Thank you, sir. And it was a wonderful talk. And now I request our pediatric orthopedic surgeon from Mumbai, Dr. Tushar Agarwal. He will be speaking about CTV, and then we all will go for workshop, and then we will have a dinner with some light music outside. So I request Dr. Tushar Agarwal to go for his CTV. So, and in between,
I always maintain that for a faculty there is nothing more difficult than giving a talk on clubfoot, because everybody is so enlightened and everybody knows everything on clubfoot. But I made an effort to sort of review the literature. Okay, great. So this talk is more of a review of literature, and in between I shall put in my personal experiences. And I've been told to put like a 30-minute talk in 10 minutes, so pardon me for going through it very fast. The whole talk will take you through a journey from antenatal diagnosis of clubfoot. I get almost 1 patient every week coming to me with an ultrasound that I'm going to get a child with clubfoot. So how do you counsel the parents? Then Ponseti casting, obviously, bracing, and how do you identify early relapse and how do you prevent them from happening? So we all know that such ghastly surgeries are now gone. Okay, and now we have come to the era of Ponseti casting, right? I think from 2003 onwards. So this is one of a 16-year follow-up we have. She had come for some totally different reason, and then she told me that I had treated her for bilateral club feet. So if a patient follows up adequately and gets, that's a fantastic outcome. So, but it does not always happen. Patients jump from surgeon to surgeon and miss follow-ups, and then these kind of outcomes also happen. So this patient required multiple follow-up surgeries, and eventually they become stiff. They get plantigrade feet, but they become stiff. So is clubfoot being done by pediatric orthopedic surgeons? No, they is done by everybody. In fact, they are done by medical students, means MS students. Are we doing it correctly? Well, it's a craft which you have to master, and it has to come slowly. Is there a lacunae somewhere? So there are minor lacunae everywhere. When you follow up your own patients, you will realize. And how to ensure super outcomes with a great experience for parents. So I think having a clubfoot clinic, counseling parents, making them meet other clubfoot patients, and really keeping them on a tight leash of follow-up is the best way to give them a super great experience. So this is one case. I was called in for another hospital case, and I went there and I was quite aghast. This is like day 2 kid. She was the second born female child, very obviously very rigid feet, like Pirani, DiMeglio, you will have the highest score. This patient did not have any antenatal diagnosis of this clubfoot and the parents were in a state of shock. Okay, this is a relatively minor unilateral left-sided clubfoot. This is actually my physiotherapist kid. She had gone to another city, Ahmedabad, to give birth, and because she was my therapist, she said, I'll come back. So only thing I told her is, just flip the child over and show me what is happening. So what I was trying to see is for a low sacral dimple or any evidence of any tethered cord. So now first step, we talk about antenatal counseling. So I have selected some articles from 2018 to 2023. Okay, and what is it saying? That ultrasound is the benchmark test for diagnosing clubfoot. It has got a positive predictive value of 81.1 and a negative predictive value of 99.5. So when a sonologist says, no, your child does not have clubfoot, means the child should not have clubfoot. And a positive predictive value means when they say that your child has clubfoot, 82% chances there that the child is going to have clubfoot. However, I don't agree, because I have only 40% patients of clubfoot who have an antenatal diagnosis. Remaining 60% clubfoot have got multiple ultrasounds and have got never been told that they had clubfoot. So in India, because we probably don't follow an international protocol or for whatever reason, it gets missed. Point number 2, why does it get missed? Because clubfoot is an evolving deformity. So what really happens is that you may do an ultrasound in your second trimester, late second trimester, but actually a clubfoot will appear when the baby is 26, 28, 30 weeks, when they are actually not doing the antenatal ultrasound. Now the advantage, however, what is the advantage? The article says that all parents who knew that their child has clubfoot are very well adapted and they come on day 1 for your treatment. Whereas the other patients who don't have an antenatal ultrasound will waver a little. Now certain countries and certain centers have started adding an MRI and also adding chromosomal arrays whenever they have the facility available. Why? To identify the more significant clubfoot, to identify the more syndromic clubfoot, to identify an arthrogrypotic clubfoot, because that is what is where we are going to tell them probably you don't want to have this kid. So it's a big decision we make as a pediatric orthopedist to tell them that whether you want to continue with this pregnancy or you don't want to continue with this pregnancy. Now in my practice, what do I do? In my practice, I send them for a repeat ultrasound to a specific sonologist. There are 2 or 3 of them in the city of Mumbai, and I ask them specifically to look for 3-4 things. One is hypokinesia. Is the fetus moving adequately or not? Second is whether the hip is contained or not. Third, whether the knees are contained or not. So if there is hypokinesia, hips and knees are a problem. If there is a hyperextension of the knee, this child has arthrogryposis congenita multiplex. So I will counsel that you may not want to continue if you don't want to take the headache, because a clubfoot primary and a clubfoot with AMC is a completely different ball game. You know, you don't want to have a CDH with CDK with CTV and say, parents will say, तुमने बोला था इसको पैदा करो, अभी तुम ही संभाल. Number 2 is spine diagnosis. So they should not have an open spinal defect. Okay. Now clinical evaluation. This is a long sort of article, but I would advise that I'm not going to go into detail in this article, but this is an article written by Canavasi and DiMeglio. You must go through it. It's an open free source article. Please look for it online. It will tell you in detail how to evaluate a clubfoot. This is how we evaluated the clubfoot today. So you approach cautiously, you remove the diapers, you see for the sex of the child, you see for any other anomalies, genitourinary, hernias, okay, by the time you are examining the feet. Also, you look for the empty heel, convex lateral border, deep medial crease, toe flexors, toe extensors, peroneal movements. You will look for neutral knee or hyperextension knee. You will look for adequate abduction, or if or at all, whether there is any subluxation. So this particular patient had some sort of subluxatability in the left hip. However, a newborn is going to have a physiologically subluxatable hip. So you don't need to rush into anything. Okay, you counsel them for casting and do an ultrasound at 3 weeks. Upper limbs are good, and you see the child is very quiet and comfortable. So the child is not in any sort of pain or discomfort. You flip the child over and look for low sacral dimple. This is very, very important. Low sacral dimple has to be put on paper. You may not tell the parents that your patient will have tethered cord or something, but you put on paper, because tomorrow if it relapses, that is one of the causes that you will be having.
We'll skip through this. This was relatively normal kids examination. I had shown you feet. Now this is a very important video. This is a pathognomic sign of a clubfoot. Short first ray with a hyperextended toe, and it springs back. So the first ray is terribly short as compared to the second ray. This shows that the patient has complex clubfoot. Complex clubfoot are always more difficult to handle, and this is how they will look. I just showed you that deep medial crease. So if you have a persistent deep medial crease, this is a complex clubfoot. Now this is an arthrogrypotic, which we all know. So the clinical evaluation, you have to just understand one thing: the baby's normal foot should be 7 cm, clubfoot is smaller, and baby's normal feet should be very supple with high degrees of range of movement. Clubfoot is not there. Finally, when you evaluate the clubfoot, you are going to talk on heel, lateral border, range, tone, and other joint involvement. And final comment is going to be on appearance, range, correctability, calf atrophy, creases, and peroneal power. Sorry, I have to go fast. So once you have examined the clubfoot, what is the next step? You got to classify and you got to score. What is the difference between the two? Classification is descriptive, and scoring is an objective way of telling what point it is. Okay, so normally we don't classify. We are doing Pirani. Everybody is familiar. We are doing Pirani scoring and Di-Meglio scoring. Okay, the literature is divided. Which one of them is better? Both of them are equal, and they have roles in management of clubfoot. So how will you score this? Please apply your mind. Otherwise, we would have discussed how will you score this. This would be roughly 5.5 on 6. Okay, that's the Pirani score. So no matter how obvious your diagnosis of CTEV is, we must do a detailed evaluation. You cannot miss minor issues here and there. And other joint involvement, neuromuscular syndrome evaluation, neck movement, torticollis must be seen. Talk about family history. Every fifth foot I see, the father has had clubfoot. So the family history is far more significant and realistic than we ever sort of realize. Okay, and never get discouraged when you see this very rigid clubfoot. You start with your Ponseti, it will always correct. Always it will correct. Ponseti is the mecca of everything in clubfoot. Each and every article says immediate correction is to the extent of 94%. Hardly any article is saying that there will be less than that success rate. Okay, even in complex clubfoot. So it's obviously early casting, toe to groin, POP cast. We will do it in the workshop. You correct it in this form: cave, cavus, adductus, varus, and equinus. The persistent equinus is corrected by the tenotomy, and the absolute hard talk of CTEV is the bracing, because the bracing has to continue for all of your treat clubfoot. So you will advise bracing for? No. You abduct. Foot abduction orthosis is for 5 years. The current protocol is for 5 years. But you are not going to tell them on day 1. Okay, otherwise they will run away. So every time they are happy with you, you increase few months. But ideally, you are supposed to use it for 5 years. Okay, the Ponseti technique is far superior than the kites method. Okay, parental satisfaction is very high, and tibialis anterior transfer is becoming very common. You should defer it till 5 years of age, because it may lead to a sluggish dorsiflexion. Okay, now there is something called as accelerated Ponseti. Suppose you have hyper parents who have come from another city, change cast twice a week, you can get exactly the same outcome as you are getting by the standard Ponseti casting. We will see this video from the workshop. See, you see this, the pressure I am applying. So that's the first cast. The pressure, where are you applying the thumb pressure? How much supination you are able to give in equinus, and the other thumb is at the level of the talar head, and you are doing heel molding so that the plaster does not come out. Okay, this is a relatively minor involvement. So here I am only lifting the first metatarsal. There I was lifting the entire forefoot into supination. So like madam said, if there is one thing you want to take from my talk, differentiate between simple and complex clubfoot. You do first ray elevation in simple clubfoot, you do the entire forefoot elevation in complex clubfoot. Okay, as you keep giving more and more cast, you are going to take the foot in abduction, maintaining the supination and equinus. You are not going to pronate the foot, you are never going to dorsiflex the foot. Okay, Roughly by the end, 4th or 5th cast, the foot should look like this. And now you give the last plaster before you take them for tenotomy. So the first small roll, 3 wraps around the foot, then cover below knee and then take it above knee, and the third roll you strengthen the plaster, and this is how it should look at the end. All your plasters should just keep looking similar. If you are doing club feet, when somebody sees your plaster, they should know ye isne kiya. Should just keep looking the same. Okay. There's lot of thing in POP casting. Train your staff. Where do you have to stand? How much they have to hold? You must train. What is the role of the parent? They have to stand on the same side, opposite side. Removal of plaster is a big deal. Never use plaster cutting machine. You have to wet the plaster and remove. There are enough articles to say that you will never you should use the plaster cutting saw. Level of surface on which the kid sleeps, because otherwise you will get backache. If you are doing 17 casts a day and if you are bending low, it's not good. It should be a nice comfortable level at which you are bending. Your assistant who is holding the foot should always be on the side which you are casting. Okay, size of the plaster should always be 6 inches cut into 2. Size of the soft roll is always 6 inches cut into 2. Water should be kept accessible. You should not be jumping over the patient and getting the water. Otherwise, the entire tub will fall on a small newborn neonate. Okay, are you comfortable all the time? Is the child manageable? Otherwise, do that. Make the child manageable. Use pacifier. Use feeding. You can have breastfeeding also. In certain compliant parents, when they are being breastfed, they are comfortable and you can cast. So make sure that the parents are always counseled and they are aware of the changes that are happening in the feet. They are very happy after which cast? आप लोग सब पॉन्सेटी कर रहे हैं ना? So they are very happy after the second cast only. It starts looking corrected. So once you are into the third cast, it looks significantly better. And tell them how many number of casts and manage it in that much only. Okay. Now there is a question. When do you start Ponseti? If you start late, does it matter? No, it does not matter. Result is same whether you start before 6 months, after 6 months. However, I like doing clubfoot surgery. So after 1 year of age, I do not offer them Ponseti. Other people are offering up to many 3 years, 4 years, 5 years, 6 years also. You can do accelerated. I use it for out of station patients. There is mild to moderate pain when you are doing club feet. It has been proven in literature. Use non-nutritional pacifier. That is what they say, or some form of feeding, so that they are happy. I am very of a very late start to Ponseti casting because I feel bracing mein they are not compliant. Okay, pacifier is a must. You must tell the parents to use a pacifier. Kid is much quieter. Okay. Now outcome. Abhi aapne Ponseti complete kiya, so what will you do? You will follow up and see your outcome, right? So 93.5% success rate is there in short follow-up. However, in a longer follow-up, if you follow them till 10, 11 years, the success rate starts coming down. Some or the other surgery starts creeping in. So follow-up is your killer. You follow up till 12 to 14 years of age. And then you will find what is really happening in the clubfoot that I treated. Okay, everybody is chilled after the 6th cast. It is looking super sexy. Absolutely correct. There is no problem at all. All the problem starts at follow-up. And according to me, that problem starts at 18 months. Why? Because foot looks good, foot looks good, foot looks good, foot looks good. Acha, now you don't come for follow-up, come slowly. So parents to decide to run away only. That is the time where you tighten the follow-up. When the child is 18 months to 2 years, start calling them again monthly. That's the time you get the maximum relapse. Okay. Now, this is a very good paper from Wadia. That's why I put it. And they have said that you get equivalent results on complex clubfoot and syndromic clubfoot. However, the number of casts will increase by 40%. Okay. Now, day 1 tenotomy, very interesting paper. It says that when you are done 5 casts, your posterior foot looks very chubby and edematous, and sometimes you are not able to differentiate where the tendo HL is, and you will end up doing an incomplete tenotomy. So to avoid that, do day 1 tenotomy and then start casting. Bachchu aaya, do tenotomy, then start casting. In fact, they are saying that squatting is much better in these patients. However, if you are going to use that in your practice, talk to some people. I have not yet incorporated it into my practice. Pirani and DiMaglio score is not helpful on day 1 to prognosticate. However, after the 2nd cast, it is very useful to prognosticate what is going to happen. So you may have a horrible Pirani score on day 1, doesn't mean you are going to have a bad outcome. After the 2nd cast, what is your Pirani score is, that is what is going to tell you how the outcome of this patient is going to be. It is proven in literature also and in our day-to-day practice. Okay, now so that is what I was saying, not helpful on day one, and both Pirani and Demaglio are equally useful. One big complication of percutaneous stenotomy is an abnormal vessel of the peroneal artery can creep into your cut and therefore bleed a lot. Number two, most of the kids are boys. They can have altered PT-PTT. You will not know. They have hemophilia and you have cut the tenotomy and they will bleed. Your whole cast will get soaked. Their hemoglobin will drop from 11 to 3. Okay, and you will require to admit them in ICU. So this can happen. Okay, and what do you do when you feel your Achilles tendon tenotomy has failed? Okay, it always happens, right? Once in a while, after doing 500 also, one may not happen in overconfidence. No problem. Continue serial stretching cast. They have proven that you will get the good result, that it stretches out. Whatever you have cut, the remaining stretches out. This is a video showing with needle. I will advise everybody should reverse to needle if they are using blade. 18 gauge or 16 gauge needle directly on tendo Achilles. You scratch the surface of the tendo Achilles and cut the tendo Achilles. You cannot cause any insult at all. Okay, this is with the blade and you feel for the tendon. The tendon has shifted to the lateral third, middle third and lateral third of the calcaneum. Okay, now this is with the needle I am doing. The next one we will do with the blade. See, the blade goes in. Okay, and then you go by the side of the tendo Achilles, turn it 90 degrees and then again bring it out, taking care not to cut the skin. But you have to feel the tendo Achilles all the time. It has to be on the tendo Achilles. This side we got the cut. Now you see, I was using the blade on the other side and I felt that one strand is remaining. So I had to complete it with a needle. So needle is very useful. You go back home, every tenotomy you do with needle only. Okay, so in literature, it gives equal outcomes. It's cheaper to do with needle. Now, confirmation of healing. So they have done ultrasound studies to show that clinically you will feel tendon has healed at 10 days. But ultrasonologically it is healing only at 20 days. So you must continue cast till 3 weeks. Okay, 3 weeks you have to continue casting. Now, I asked myself whether you should do the tenotomy under GA or you should do under LA. Okay, and literature totally supports local anesthesia. However, I am doing all my tenotomies under GA. However, literature is supporting only local anesthesia. So if in your practice you don't have an anesthetist who will anesthetize a 4-week-old child, go ahead under local, do the tenotomy. They have assessed that the child will cry for 84 seconds and they have assessed the decibel level of the cry. It is within acceptable levels. However, I have found that my patient has a breath holding cyanotic spell and that makes me feel very anguished at that point of time. So to have an anesthetist standby is very good. You may not give anesthesia. Okay, bracing is everything in CTV. You will agree. I have got 2 braces here. You can see if the patient is not compliant to the standard braces, you have to use, this is a Michel brace. Okay, so this is with a soft AFO. Okay, you should use the Michel brace. This is for 9,000 rupees and this is Dobbs. So the Dobbs brace everybody accepts, everybody, and the Dobbs brace costs 24,000 rupees. So it's pricey, but if your child is not accepting the standard foot abduction orthosis, please see these braces and they can be bought online as well. Okay, this is in detail how you give the duration of bracing, but let me tell you, it's 23 hours to start. And you should never take it below 12 hours, no matter what happens. On paper, it will be 12 hours per day till 5 years of age, on paper. Then you have to keep managing what happens. And now, in UK, they have come with a unilateral brace. So some consultant friends of ours are using. So this is an innovation. Once it comes in India, that will be very good. No bar, unilateral brace, maintaining foot abduction and external rotation. So this is like a wow, you know, the Instagram thing, like a wow. So Santora Michel Dobbs, this is the order in which I go up on the brace. That was my scoring system. We can discuss over the workshop. So early relapse cause in all articles is non-compliant bracing, which means you are good. You are obviously going to get a perfect outcome, but relapse is because of non-compliant bracing. So keep telling them brace, 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 brace. To prevent such relapses, brace. In my practice, this is what the kind of minor relapses that we get. You see this little Rajma shaped foot with tight toe flexors. So if you make them squat early and if you stretch their long toe flexors adequately, you can prevent this relapse also. So we have to keep stretching the long toe flexors. You can involve a pediatric therapist also. It helps very much. So at the outset, clubfoot looks very ghastly. At the end of tenotomy, the clubfoot looks brilliant. However, there will be issues with bracing and compliance, so clubfoot may not look good. And some will be having AMC, MMC, so the clubfoot may not look good. So I had showed you two cases. I will show you the journey of those two cases. Okay, so this was the first rigid clubfoot. She went through the sequential casting. So you see, it doesn't look good a lot like how so it starts gradually after the 4th, 5th cast. See the deep medial crease is still there, and I'm still at neutral. I'm not able to bring it to abduction. The deep medial crease, long toe flexor is still there. Foot is looking chubby. So at this point I did the tenotomy. And I did 2 casts after the tenotomy because this was a complex clubfoot. So now it's like corrected. The long toe flexors we are stretching and the patient is in a foot abduction orthosis. Okay, this is the therapist kid. This resolved very fast in 3 casts. 4th cast was under GA tenotomy. See, and we started incorporating very early squatting. You see this assisted squatting. So that helps a lot. And these are his feet. You can't make out which one had clubfoot. So now, so reframe CTV in the minds of the parents and acquire the skill to do great casting. A robot is never going to come in CTV. Okay, you have to practice. You are the robot there. You practice, give perfect cast, and you get an outstanding result. And love the patient, love the parents, follow up the patient, and then you will have a great outcome. Insist. Now you see, this parent sent me. They were twins. Both had bilateral club feet, and they are both playing soccer for school now. So that's the emotional moment you get. You know, this is at the end of the tenotomy. Both the twins had club feet. This is a 7-year follow. So my boss, Dr. Johari, always says, only in pediatric orthopedics, almost 10% time your patients will outlive you. You know, and this is the beauty of treating kids. Thanks a lot.
Excellent talk, sir, and quite few things we have learned, and I think we will be going back and practicing those steps. So I request Dr. S.K. Singh sir to facilitate Dr. Tushar Agarwal. Sir, I'll take care of it. And उसके बाद इधर खड़े हो जाओ. ले और ले आओ. सर आप यहाँ खड़े हो जाइए. I request Dr. Pradeep Manoj sir to please come on the dais. Thank you, sir, for taking out your time and sharing your valuable thoughts on foot and ankle surgeries. Now I request Dr. Atner sir, please sir, and we feel honored that every time sir visits India, he shares his valuable time. Sir, please be here. Now I request Dr. Leska, and I congratulate her on becoming the president of Foot and Ankle Society of Switzerland. request Dr. Singh sir to be on the dais. I request Dr. Shivam Sinha, Secretary VOA, to please come. और किसको बुलाना है? बस डन। हाँ बस बेटा। So उसको टेबल की जरूरत नहीं, मुझे लगता है जूता उतारना पड़ेगा, बस टेबल की जरूरत नहीं। I thank everyone, the senior doctors, our colleagues, the faculty from abroad and within India, and most of all the delegates, those who have taken out their time and learned something new, I hope. And I thank Indian Foot and Ankle Society for giving us this opportunity to conduct this program. We do not have any UPOA office bearers with us, unfortunately, but I thank them too for giving us the platform, and none other than our VOA, the Dynamic Secretary, for allowing us to conduct this program. And once again, I thank you all for attending this meet. And now we have a workshop. Those who wish to attend it, we are going to have that workshop, the quantity casting technique and the chest fixator in the foot. And we will be starting our dinner, I think another 7 minutes.
ये जो पहला ही प्लास्टर है बस वही इंपॉर्टेंट, बाकी सब तो सही होने वाला है। और आपका प्लास्टर निकलना नहीं चाहिए। सपोज आपको ऐसा लगता है इनिशियली, आप लोग सब कर रहे होंगे, बट अगर निकलता है, बहुत लोगों का प्लास्टर निकल जाता है दोज हुआ, तो दैट मीन्स आपने ज़्यादा पैडिंग दी है, आपने हील के पीछे मोल्डिंग नहीं की। और कभी कभी आपको लगे तो हल्का सा टिंचर बेंजाइन आप लगा सकते हैं, तो जिससे वो प्लास्टर नहीं निकलेगा। फिर अगर आप रेगुलरली वो नियोनेट को प्लास्टर नहीं लगाए, मतलब डे 2 का बच्चे को प्लास्टर लगाने के लिए रेगुलर हैबिट चाहिए ना। आप 1.5 महीने के बच्चे को लगा रहे हैं, बस 2 दिन के बच्चे को प्लास्टर लगाने के लिए एक हैबिट चाहिए, तो फिर आप ज़्यादा फोर्स भी नहीं अप्लाई कर सकते। ऑप्टिमम फोर्स हैज़ टू बी अप्लाइड, अदरवाइज आपका पेशेंट घर से फ़ोन करेगा वो रो रहा है बहुत। And a newborn, if he is crying excessively after your first cast, it's best to call him and remove the plaster. तो प्लास्टर रिमूवल का उसके ऊपर भी पेपर लिखा हुआ है, तो आपका जो लास्ट में आपको ऐसे एक छोर ऐसे छोड़ना है, तो उससे आपको पता चल जाएगा कहाँ पे है, तो गीला करके आपको उसी को पकड़ के उखाड़ना है और रिवर्स घुमाना है गीला करके। मतलब आपको प्लास्टर कटिंग मशीन नहीं यूज़ करनी है। दे हैव एक्चुअली अप्लाइड पल्स ऑक्सीमीटर एंड मॉनिटर्स एंड सीन के बच्चे को बहुत सारा डिस्कम्फर्ट होता है व्हेन यू यूज अ प्लास्टर कटिंग सॉ, प्लस थर्मल बर्न्स तो होते ही। ओके, सो अगेन व्हेन डू यू डू टिनोटोमी, आई थिंक वो मैंने उधर एक्सप्लेन नहीं किया था। यू शुड गेट 30 डिग्रीज ऑफ एबडक्शन, थोड़ा बाहर आ जाए पैर, और फिर 10 डिग्रीज का इक्वाइनस बचा है या थोड़ा ज़्यादा इक्वाइनस बचा है, थियोरेटिकली उससे ज़्यादा भी हो सकता है, तब आप टिनोटोमी करेंगे। आप टिनोटोमी कहाँ करेंगे, तो लोग बोलते हैं कि आप एक फिंगर ऊपर करें, तो दैट इज़ अ रफ थिंग। यू आप उखाड़ नहीं सकते एड़ी पे से, मतलब आप ब्लेड से एड़ी पे से उखाड़ेंगे नहीं, आप एक उंगली ऊपर जाएंगे और जहाँ पे आपको हील कॉर्ड फील हो रहा है वहाँ पे आप नीडल लीजिए। 16 नंबर 18 नंबर, 16 नंबर की आपको नहीं मिलेगी, इसलिए 18 नंबर उपयुक्त है। 18 नंबर से आप सिर्फ डायरेक्ट टेंडो एचिलिस पे जाइए और उसको ऐसे 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 स्क्रैच करिए, वो कटेगा ही, आपको कोई टेंशन नहीं है, आपको कोई एनेस्थीसिया की जरूरत नहीं है, आप बस टिनोटोमी करिए। अनदर कॉज ऑफ रिलैप्स इज नॉट डूइंग टिनोटोमी एंड ट्राइंग टू फिक्स द फुट एबडक्शन ऑर्थोसिस। फिर वो एडी ऊपर रहती है और फिर वो एडी ऊपर ही चली जाती है। फिर आपकी प्रैक्टिस बहुत बिजी है, आप ऑलरेडी रोज 8-10 सर्जरी कर रहे हैं, कहाँ आप वो बच्चे को देखते फिरेंगे, और फिर वो धीरे धीरे रिलैप्स में चला जाता है, तो इसलिए प्रॉब्लम आती है। सो यू शुड टाइट फॉलोअप, राइट टाइम टिनोटोमी, राइट टाइम फुट एबडक्शन ऑर्थोसिस। और ये जो मैं आपको बता रहा था, तो ये सॉफ्ट है, ये बहुत पेशेंट्स रियली लाइक दिस। और ये ना इससे डिस्कनेक्ट हो जाता है, तो इससे डिस्कनेक्ट होता है तो एक एक स्प्लिंट एक बार में लगाने का और फिर उसको साथ में कनेक्ट करने का, बिकॉज इसमें हिंज है, इसके कारण एक ही आदमी बच्चे को स्प्लिंट पहना सकता है। जो स्टीनबैग का शूज है ना, उसमें 2 इंसान लगते हैं, एक बच्चा पकड़ने के लिए, एक स्प्लिंट पकड़ने के लिए। कभी कभी 3-3 लोग लगते हैं उसको स्टीनबैग पहनाने के लिए। बट स्टीनबैग इज एंट्री लेवल एंड ग्लोबल ब्रेस। यू शुड ऑलवेज टेल देम स्टार्ट विथ स्टीनबैग, बिकॉज स्टीनबैग आपको 700 रुपये से 1250 रुपये में आएगा, बराबर। ये 24,000 का है, मुझे नहीं लगता वाराणसी में कोई जल्दी से 24,000 का, मतलब इट्स इजीएस्ट वे टू लूज योर पेशेंट। और ये 9,000 का, बट दिस इज गुड अगर अपने किसी कलीग को, मतलब कोई हाई फाई, मतलब कोई कलीग है, कोई पॉलिटिकल लीडर है, किसी के ऐसे किसी बच्चे को हो गया तो उनको यही देने का, मतलब हाई, मतलब यू शुड गिव अ गुड क्वालिटी ब्रेस। एंड व्हाट शुड बी द विड्थ ऑफ द ब्रेस, द विड्थ ऑफ द शोल्डर। तो जब 1-1.5 साल का होगा तो ये खोल के थोड़ा सा इसको वाइडन करना, ठीक है। सो वी हैव ए इंडियन वर्जन ऑफ दिस विच इज अवेलेबल फॉर ओनली 4-5,000 रुपीज, दैट्स कॉल्ड द सेंटोरा ब्रेस, दैट इज ऑल्सो अवेलेबल ऑनलाइन। मतलब अगर आपको लगता है आपका कोई पेशेंट स्टीनबैग नहीं यूज कर रहा है, आप हमको कॉल करेंगे, हम आपको सेंटोरा भेज दें, खाली फुट का इंप्रेशन भेजना है आपको, एंड इट वर्क्स। वी हैव प्रूव, मतलब अभी तो 20 साल से वी आर यूजिंग, सो देयर इज नो प्रॉब्लम एट ऑल। हाँ, वेरी गुड। जस्ट एज द टो कम्स स्टार्ट्स कमिंग आउट, मतलब उस आपका विजिट पे आया ना, तो जब मैचिंग होने लगा तो बोलना अगली बार आप नया ही लेकर आओ, क्योंकि अगली बार जब आएगा, ओके। फॉलो अप, so follow up is monthly for 3 months, 2 monthly for 3 months, followed by 3 monthly follow up. Once the child is 3 years of age, it can be 6 monthly follow up. नहीं, तो आप जब एक्टिवली उसको करते हैं तो आ जाना चाहिए। स्नैप की आवाज नहीं, टिनोटोमी के पहले की पूछ रहे हो। हाँ हाँ हाँ, मतलब वो न्यूट्रल नहीं रहना चाहिए, बाहर आने लगना चाहिए. बट कॉम्प्लेक्स क्लब फुट में कभी कभी वो स्टैटिक हो जाता है. आप एक प्लास्टर दे रहे हैं, दूसरा दे रहे हैं, तीसरा दे रहे हैं, बच्चा जोर जोर से धाड़ मार के रो रहा है और वो बाहर ही नहीं जा रहा है, तो आप पहले टीनोटॉमी करो और फिर बाकी के 3 प्लास्टर दो. आप समझ जाओ कि आपके पास आर्थ्रोग्राइपोटिक या कॉम्प्लेक्स क्लब फुट आया हुआ है, या फिर फुट ब्रेक होने लगे, मिड फुट ब्रेक, यानी ऐसा फ्लैट फुट बन रहा है, तो आप टीनोटॉमी पहले कर दो. The moment they are able to come back up for a 7-day follow-up. आपको बोलना है कि आपको 7-7 दिन में प्लास्टर के लिए आना है, 5 दिन में भी बदल सकते हैं, बट 7 दिन से दूर में नहीं बदलेंगे. मैं बता रहा हूँ, अगर डे 1 पे करना है आप डे 1, अम्बिलिकल कॉर्ड के साथ ही करते हैं हम लोग, तो कटा हुआ कॉर्ड है. मैंने बताया ना, जिनका एंटेनेटल डायग्नोसिस हो गया वो डे 1 पे ही कास्ट करा, बिकॉज वो 4-6 महीने से रेडी है उसके लिए.
Fortunately, you are getting antenatal patients for counseling, and if you get a arthrogryposis patient with CTV, you ask them to discontinue the pregnancy.
No, but I explained to them that this is arthrogryposis.
You may, right? But
so I'll tell you my experience. So if it is like a 21-year-old woman who has got pregnant, just like that, बाजू में बैठ के pregnant हो गई, तो they will not continue. और जिसने बहुत गेम बजाया और प्रेग्नेंट हुए, दे कंटिन्यू. जिसने ऑलरेडी 12, 15, 25 लाख खर्चा किया है, 4-5 IVF किया हो, तो कंटिन्यू करेगा.
नहीं, वो ठीक है. आई एम आस्किंग अनदर क्वेश्चन. इन अवर सिनेरियो वी डोंट यूजुअली वी आर नॉट लाइकली टू गेट
antenatal.
So if a child comes with arthrogryposis with CTV, what should be the schedule?
Okay. Very nice. So arthrogrypotic foot are, so whether it's a plain CTV or it has got something else. So most of the arthrogrypotic would be one side vertical talus, one side CTV. Also they would be stiff at the knee and the hip, or some problem in the upper limb will be there. Gradually the upper limb problems start resolving, so you don't try to go for the upper limb. You start casting the foot, the club foot arthrogrypotic, like a complex club foot. So you take the whole forefoot supine it and then start abducting. The moment you will feel कि अब मेरे से progress हो ही नहीं रहा है, मेरे को control ही नहीं आ रहा है, तो then you do the tenotomy. Sometimes you do 2 tenotomies also. In 10 casts you will do 2 tenotomies. The tenotomy will heal and then you will do a repeat tenotomy. But you will bring it to about, not like a idiopathic club foot like 70 degrees, but you will be able to brace it in 30-40 degrees of abduction. Now if the child is comfortable, the protocol says keep increasing it by 10 degrees till the child starts crying too much. If that answers your question, I'll say one more thing. Many patients children are very uncomfortable with bracing. So अपन को जबरदस्ती नहीं करने का, नहीं आपको 24 घंटा अब भी पहनाना. आप बोलो आप 1-1, 2-2 घंटे से इंट्रोड्यूस करो. I have seen 100% of them by the end of 7 days they are okay. If they are not okay by 7 days, you introduce these 2 braces.
नहीं, CTV with MC.
मैं बता रहा हूँ सर.
नहीं, तो will again the Ponseti will work there.
100%. मैंने बताया था आपको कि 40% more number of plasters are required. So normally 4 to 6, so this will require 8 to 10 plasters. 15 days. So people are doing this when they are going on outstation visits, pediatric orthopedic surgeons. You can do it, but there are no articles on that. 5 to 7 days. The traditional Ponseti is 5 to 7 days or twice a week. Once in 2 weeks is done when I'm coming to Varanasi every fortnight. So then I'll tell मैं ही आके plaster बदली करूँगा. Then, otherwise there is no reason. $10 degrees of plantar flexion रहेगा तो compulsory tenotomy करना चाहिए. By the time if you have got a fully abducted external rotated foot. So I will suggest one thing. You do a stress dorsiflexion X-ray with knee in extension. It is not described, but do that. And if your calcaneum is just slightly low or neutral, that means you do a tenotomy. The calcaneum should come up by 10-15 degrees. So कैसे करने का? अभी जैसे ये इसका फुट है ना, ऐसे लेटा के ये नी सीधा करके, पूरा नी सीधा करके मैक्सिमम डॉर्सीफ्लेक्शन में पकड़ के लैटरल व्यू कर रहे हैं। फिर आप कैल्केनियम देखो टू द टिबिया और आपको दिखेगा वो ऊपर आ रहा है कि क्या है, कौन सा जस्ट, मैं इतना ज्यादा पढ़ा हुआ नहीं, मीन्स द डिमेग्लियो, हाँ द टेपिंग, हाँ आई डिडंट रिव्यू इट बट द पीपल हु राइट ऑन इट आर सेइंग दे आर गेटिंग कंपेरेबल रिजल्ट्स. But why will somebody do it? No, now it's the Ponseti, which is the benchmark way of doing. We should do a correct Ponseti. बस that's the one thing. मतलब ये Cure Foundation सब क्यों आए हैं? You have to do the right Ponseti manual. Don't change it. और जो मैंने points बोला है उसको याद रखना है आपने. तो कब टीनोटॉमी करना है, कैसे करना है, नीडल से करना है. आप बगैर एनेस्थीसिया के करिए ना. सबसे बड़ा भय तो यही है कि पेशेंट को टीनोटॉमी बोलेंगे भाग जाएगा. अरे हम पसली काटेंगे तो एकदम बावले हो जाते हैं, क्या बोल रहे हैं डॉक्टर. बहुत प्रॉब्लम आती है. आई एम स्टिल लूजिंग पेशेंट्स, बट देन टीनोटॉमी बोलना चाहिए.
आप एक जरा से नीडल से कैसे आप करते हुए जरा से
वो ब्लेड है वो दिखाइए. आई शो यू विद द ब्लेड. So blade say you are going, you going in like this, and then you are turning at right angle and then coming up. Needle say you go directly on the tendo achilis, and then keep scratching it. And with the दूसरा hand you do dorsiflex. चौथा scratch मारा के वो पूरा ही कट जाए. अपन ये करते ना, कोई लोग ये करते ना ट्रिगर फिंगर का जो, बस सेम ही है. वो बीवेल से आप काटते जाइए. But वही best. You stop using the blade at all. Just don't use the blade at all. Stop from today. Just use only one finger above. One finger above is a measure generally up to first 2 years of age. यानी यहाँ पर हमारी प्रॉब्लम हम यहाँ से उखाड़ देते हैं. That is very bad. You should never avulse. बिकॉज कैल्केनियम इक्वाइनस में है ना, तो आप ऊपर जाके ही करें. उसको नीचे उतरना है ना, जब आप टीनोटॉमी करेंगे फिर ही नीचे उतरेगा. और 3 हफ्ते से कम का प्लास्टर नहीं लगाए. हाँ मैंने बताया ना वो आर्टिकल कि आपने अल्ट्रासाउंड इट इज प्रूवन दैट इट हील्स ओनली एट 20 days.
मतलब टीनोटॉमी करने के बाद नेक्स्ट प्लास्टर जो है 3 हफ्ते के बाद ही करना है, नॉट 7 days.
नेक्स्ट प्लास्टर नहीं लगता है. प्लास्टर निकाल के ब्रेस में डालना है. नेक्स्ट प्लास्टर कॉम्प्लेक्स क्लब फुट में लगेगा. मैं करूं इस पे करूं. सो फर्स्ट इज यूज दिस 6 इंच का बटा हुआ. फिर असिस्टेंट विल रिमेन ऑन दैट साइड. ये सब बहुत इंपॉर्टेंट है. फिर असिस्टेंट को आपको क्या बोलना है कि एक हाथ ट्रोकेंटर पे रख और एक हाथ से अंगूठा पकड़. इसमें कुछ भी मतलब चेंज नहीं करना है. रिलेटिव को क्या बोलना है, तो दूसरा पैर पकड़. हो गया. आप कौन से हाथ से प्लास्टर करते हो उस साइड पे आप पानी रखिए. अगर आपने इधर रखा तो फिर ऐसे हाथ क्रॉस करेंगे. ये सब नहीं करना. लेवल ऐसा रखिए कि आपको ज्यादा झुकना नहीं पड़े. स्टार्ट फ्रॉम बियॉन्ड द टोज. ओके. और यहाँ पे पतला ले.
डायरेक्शन का भी कोई यूज है? आप मीडिया टू लेटरल जाएंगे कि लेटरल?
नहीं मैं लेफ्टी हूँ इसलिए ऐसा कर रहा हूँ. इट विल बी ऑन योर हैंडेडनेस. हाँ तो सॉफ्ट रोल पूरा जाएगा ऊपर तक टिल द ग्रॉइन. ये फटा. इसमें वो डंडू है बट आई डोंट कीप दैट. सो नाउ फर्स्ट 3 turns हियर, 3 turns हियर, एंड बाय द टाइम एकदम सही हो जाता है यू कम टू द नी. ओके. देन यू यूज योर स्टैंडर्ड प्लास्टर. सो आपको उसका सेटिंग टाइम मालूम है. फिर सबसे पहले आप 5 टो देखो. बहुत बड़ा प्रॉब्लम है, अपन कंसील कर देते टो, फिर बहुत प्रॉब्लम आती है. नाउ सी व्हाट आई एम डूइंग. यही मैनूवर करना. आई थिंक ऑल ऑफ यू ऑल शुड डू दिस एंड प्रैक्टिस. ये आपको ऐसे नीचे खींचना है. ये मेरा हाथ टेलर हेड पे. सो दिस इज ऑल्सो अ काउंसलिंग कि आपका जो पंजा है वो दूसरी तरफ देख रहा होगा. सो आई विल कीप डिफॉर्मिंग. नाउ आई हैव अनलॉक्ड इट कंप्लीटली. So no attempt at straightening the lateral border, nothing. But ये देखिए, ये अगर मोल्डिंग नहीं हुई ना तो कास्ट निकल जाएगा. ऑल्सो ना कभी कभी अपन क्या करते हैं, थोड़ा अपना केमिस्ट शॉप है ना, अपन प्लास्टर का ब्रांड चेंज कर देते हैं, उसमें बहुत तकलीफ होती है. सडनली ज़्यादा गर्म हो जाता है प्लास्टर, चाइल्ड स्टार्ट्स क्राइंग. ये लोकली एक है जिप्सोना वाला अपनी फैक्ट्री खोल देगा, फिर बोलेगा सर 12 रुपये में दे रहा हूँ, टेम्पटेशन में रख लिया अपन ने, फिर ये सब लफड़े चालू है. तो मेंटेन अ स्टैंडर्डाइजेशन इन दिस, एटलीस्ट बच्चे का पियो. ये नहीं, जो भी आपको सूट हो रहा है. नहीं ये हाथ से छोटो बच्चों है ना. एक्चुअली क्या वी डू क्वाइट फ्रीक्वेंटली ना, तो सेट हो जाता है एक ही हाथ से. हाँ, एंड वंस आई हैव डन दैट, नाउ जस्ट आई एम मेंटेनिंग द प्रेशर ऑन दिस एंड मेंटेनिंग द इक्वल. आप ये देखो, ये जब खींचता है ना तो आपको ऐसा फील होएगा कि मेरा मिडल बॉर्डर खुल रहा है, आपको फीलिंग ही आएगी. मैं इसको बोल रहा हूँ, आई कैन फील माई फुट अनलॉकिंग. इफ द फुट इज नॉट अनलॉकिंग ना, यू विल फील. सो आप ये प्लास्टर 2 बार लगाइए. ओके, दैट डजंट मैटर, योर फर्स्ट कास्ट शुड नॉट बी लाइक, सबके पास इतना नहीं रहेगा तो सेकेंड टाइम भी सेम लगाने का इन सुपिनेशन. बिकॉज मैंने देखा है कभी कभी है ना, ऐसे दिखाने में कोर्स में वर्कशॉप में ना, ये ज़्यादा टाइट हो जाता है. आई एम ओवर स्ट्रेचिंग इट, यू नो, द चाइल्ड इज क्राइंग और अपन लगाए जा रहे हैं. नहीं करने का ऐसा. इफ द चाइल्ड इज क्राइंग टू मच, डिक्रीज योर, लेट इट गो. जैसे अभी मैंने छोड़ दिया, देन नेक्स्ट टाइम कर लीजिए. फिर आप इसको ऐसा एबडक्ट करना चालू करिए, सेकेंड, थर्ड, फोर्थ, और फिर 5th या 6th में आप टिनोटोमी करके. अच्छा, बुक में लिखा है कि 30-40 डिग्री का डॉर्सीफ्लेक्शन आने वाला है, कुछ नहीं आता है ऐसा. और प्लास्टर बहुत टाइट हो जाता है बिकॉज दैट प्लास्टर यू आर गिविंग अंडर एनेस्थीसिया. टो ब्लैंच नहीं होने चाहिए, जस्ट लेट गो. एकदम टोज ब्लैंच हो जाते हैं. आप ऐसा करके, अरे बुक में लिखा है 40 डिग्री डॉर्सीफ्लेक्शन, इतना 40-50 डिग्री एबडक्शन, कुछ नहीं. जो कंफर्टेबली आ रहा है विथ वेस्कुलर टोज, दैट इज एनफ. डोंट पुट देम, ब्लैंच द टोज. बिकॉज आपने पूरा प्लास्टर दे दिया और टो एकदम वाइट दिख रहा है. आ जाएगा 5-10 मिनट में, बट वो 10 मिनट में अपना 2-3 कोरोनरी खत्म हो जाएगा. तो इट्स जस्ट नॉट वर्थ इट ओनली. बिकॉज देखो क्या है सर, ये सिंपल चीज़ है, ये रिवीजन THR नहीं है कि जिसमें आप 3 दिन पहले से THR बंद, अपना कोरोनरी बंद कर रहे हो. इसमें लोचा हो गया ना तो कोई माफ ही नहीं करे. यू नो, दिस इज लाइक रेडियसल्ना प्लेटिंग, यू कांट फक इट अप. मतलब नो बडी, योर कलीग्स विल फाइंड इट डिफिकल्ट टू डिफेंड यू. रिवीजन THR में केज किधर है, स्टेम किधर है, ठीक है, नो बडी इज गोइंग टू टेल मच. बराबर बोल रहा हूँ ना. यस, सो व्हाट यू डू, तो ऐसा एकदम थिन स्लैब बनाना. और ऐसा आपको स्लैब देना है और ये अंगूठा ऊपर लेना है. ऊपर से तो दिखना ही है, यहाँ से आ जाएगा. और फिर इसके ऊपर एक छोटा सा प्लास्टर और लगा. सर क्या होता है, अगर आपने प्लास्टरिंग 2 महीने के बच्चों से चालू किया ना, तो आप सब में स्लैब दो. नियोनेट के अंदर इतनी ताकत नहीं होती है, उसके तो क्या नामकरण के पहले अपना कास्टिंग खत्म हो जाता है ना. हमारे यहाँ बारसा बोलते हैं, तो अभी 12वें दिन वो पोस्टपोन कर देते हैं. तो जनरली दे गिव यू लॉट ऑफ भाव, दे अलाउ यू टू कीप द नेम ऑल्सो. पैर सीधा हो गया तो यू कैन डू एनीथिंग. So it's very gratifying, but you do the right casting, do the right tenotomy and keep them on follow. और अगर आपको ब्रेस में प्रॉब्लम आ रही है ना, don't neglect, pay attention to them, solve their problem. हाँ, so what they are saying is that some people इधर बहुत चब्बी हो जाता है फुट, edematous, because of 4-5 casting. तो आपको फिर दबा दबा के टेंडन ढूंढना पड़ता है. वर्जिन फुट में तो टेंडन अंधे के जैसे दिख रहा है. सो डू द टिनोटोमी राइट अवे एंड देन डू 5 कास्ट. वो लोग बोल रहे हैं, आई डोंट नो, क्योंकि टीनोटोमी के बाद पहला कास्ट तो आपको 3 हफ्ते रखना पड़ेगा. बट दे से टीनोटोमी इज मस्ट, अर्ली और लेट डू टीनोटोमी. बट मैंने कोई ऐसा आर्टिकल नहीं देखा जिसमें लिखा है कि रिलैप्स इज इन मोर इन वंस इन विच दे हैव नॉट डन टीनोटोमी. अभी तक नहीं देखा. आई डिडंट आस्क दैट क्वेश्चन व्हेन आई वाज सर्चिंग. बट आप टीनोटोमी लोकल में करिए. कीप अ कलीग स्टैंड बाय, पीडियाट्रिशियन और एन एनेस्थेटिस्ट स्टैंड बाय, ताकि वो ब्रेथ होल्डिंग स्पेल वगैरह आया, ब्लू हो गया तो दे कैन जस्ट हेल्प यू बस. बट डोंट, बिकॉज वर्टिकल टेलस है ना, उसमें हमने रिवर्स पॉन्सिटी चालू किया था. दैट्स द डॉप्स टेक्निक. फिर उसमें वो क्या बोलते हैं, वंस यू हैव रिड्यूस्ड यू शुड डू इंसिजन, ओपन रिड्यूस द टेलोनेविकुलर जॉइंट. So that becomes anesthesia and that comes at 5 weeks. So Vincent Mosca, the biggest foot surgeon in the planet, pediatric foot surgeon, he comes every year to our POSI meeting. So उसने बोला they have given it up, they do now at 6 months. Because there are some papers which say that if you give anesthesia before 6 months of age, we don't know what is the हाँ. सो दैट पेपर ऑन रिलैप्स, ओके, अतुल भास्कर मेरा कलीग है, उसका पेपर है. सो यू हैव टू सी व्हाट इज द रिकरेंस, वेदर यू आर गेटिंग इक्वाइनस, यू आर गेटिंग फोरफुट एडक्शन, और यू गेटिंग कॉम्बिनेशन ऑफ बोथ, वेदर इट इज स्ट्रेचेबल और रिजिड. अगर आपको लग रहा है वो रिजिड है तो आप प्लास्टर करिए, नहीं तो आप ब्रेसिंग प्रोलॉन्ग बढ़ा दीजिए और एक्सरसाइजेस चालू कीजिए. हाँ हाँ. एंड पेरोनियल स्ट्रेचिंग, स्क्वाटिंग, लंजिंग, डक वॉक, उससे ठीक होता. एंड क्रॉस लेगेड बिठाना चालू करिए. they do W sitting along with CTV, so you feel it's a CTV relapse, but actually they are intoing. So dynamic है, stretchable है, totally correctable है, तो leave on splinting bracing exercise. Very rare कोई जिद्दी बच्चा है तो प्लास्टर है. एक इंपॉर्टेंट क्वेश्चन आपने नहीं पूछा कि फुट एबडक्शन ऑर्थोसिस नहीं पहना, कोई मर भी गया नहीं पहनने का तो क्या करेंगे. तो देन यू कैन डू एंकल फुट ऑर्थोसिस AFO, बट आप अबाव नहीं पहनाइए, सिंगल लेग अबाव नहीं, उस पर कोई आर्टिकल नहीं. बट घुटने के ऊपर का आपने बना दिया कि AFO, नी एंकल फुट ऑर्थोसिस विद एक्सटर्नल रोटेशन एबडक्शन, तो वो काम कर जाए. हो गया सर? ये सर क्लब फुट तो बहुत कॉमन है ना सर. 1 in 800 लाइव बर्थ्स, एंड बॉम्बे शहर में 26,000 लाइव बर्थ्स एवरी डे. तो क्या रौनक ही रौनक है हमको. हाँ, मेरे को रोबोट से बहुत घृणा हो रही है. हर जगह रोबोट ही रोबोट दिख रहा है. स्पाइन मीटिंग में भी रोबोट है ना. खुद अच्छा पहले स्क्रू डाल रहे, फिर पेपर प्रेजेंट कर रहे कि बगैर सीएम के स्क्रू डाल रहे, अब पेपर प्रेजेंट कर रहे कि अभी तो हम रोबोट के बगैर स्क्रू ही नहीं डालेंगे. चले चलो, थैंक यू. हाँ सर चलते हैं. थैंक्स सर, थैंक्स फॉर होल्डिंग दिस. तेरा हाथ दुख गया.